Good morning, everyone, and Women Ophthalmology Society gives you a warm welcome on this chilly day. And I hope this will be a very unique presentation and a unique session in the way Women Ophthalmology Society holds both academic as well as life skills in its motto. So we'll begin with the session today. I request Dr. Meenakshi ma'am to kindly introduce the session and welcome everyone. Dr. Meenakshi ma'am.
Yeah, thank you, Dr. Manushri. It's a pleasure for me to be here in this wonderful gathering, and a very good morning on a Sunday, which is very cold. To all my dear WOS friends, it's indeed my pleasure to start the launch of this educative venture of Women's Ophthalmological Society, the state competitive resident virtual session. And Madhya Pradesh has taken the lead, and under Dr. Shweta and Dr. Meeta, they have done a great job. Dr. Shweta has really been working very hard at it. And of course, it's thanks to Dr. Mohita, the inspiration and of WOS, that we are all here today, and Dr. Madhu. And without much ado, I'd like to say that this is a session in which we are giving a chance where all the postgraduates are getting a chance to present, and their mentors would also be there. So we look forward to this wonderful session, and over to Dr. Shweta.
Thank you, ma'am. Thank you for briefing us nicely. I would now like to request Dr. Meeta Joshi ma'am, Head State Chapter for Madhya Pradesh Women Ophthalmology Society, to brief us about the Women Ophthalmology Society activities of Madhya Pradesh.
Thank you, Manushri. Good morning, everyone, and a warm welcome to this session of WOS. And like Meenakshi ma'am said, it is a wonderful initiative, and we will be trying to come up with more initiatives, and especially in the state chapters. And I'd like to thank Dr. Shreya Thatte, Dr. Vinita, Dr. Kamla Lalwani, and other members of the state who are all very active. And special thanks to Dr. Shweta Walia for taking up this challenge and doing it in a very beautiful manner. And with that, Manushri, I think we can just start our program for the day.
So we begin with the very interesting topic for the day. Before we start with the competition, we have a very wonderful speaker with us who is
Manushri, you're frozen, I think.
an inspiration for all of us, and she would be talking about challenges faced by women in ophthalmology.
I'm not able to share the screen. Can someone help? It is written, somebody else is sharing the screen.
Manushri, please stop sharing.
Stop your screen share. First, let me welcome you all in this first first MP state chapter, and in which I'm going to talk about the challenges faced by the woman ophthalmologist. And thanks for the WOS giving me this opportunity to talk about very important topic for woman ophthalmologist. It is always, we all know that being a doctor is always hard, and it is harder for the woman. Path is very long, and for the modern men also, and it is worse for the woman. Because women often wear many hats. Same time she is wife, partner, mother, daughter, house manager, and the list is is long and it is on and on before considering the role of doctor, which is the most important demanding in terms of time and energy. So she has to make the home, she has to bear and rear the children, she has role in social activities, support the family, and simultaneously she has to keep up with the advances in ophthalmology. She is to be called a super consultant, super wife, or superman woman. But still, because of all these different roles, the less women in subspecialty and various posts are seen. And there is study done in US and that shows that there are only 8% women subspecialists and only 1/3 of the full professors or even fewer are the heads of the department. So what do you think? They are less capable or less ambitious than the male counterparts? Are there failure? No. But if you think that talent and capacity is there, where and why do we lose women in ophthalmology? Why they are not successful? For me, success is certainly not defined by either income or external rewards. It is when I feel I am giving purposefully aligned with my values, believe I am helping others, and feel surrounded by the loving relationships. So, women need to be successful in many fields, and therefore, sometimes it is taking on too much, which results in burnout. So, there is desire for the quit, and knowing when to quit requires careful consideration. So, how to overcome this burnout? We have to say no to smaller concerns or commitment. We have to avoid adding unnecessary stress, and we have to have time to focus on a bigger issues. The mentors can be important in helping these burns out to the woman. Another thing is there is uncertain future about marriage, getting new job, planning family, and circumstances after marriage. They also take part in these challenges. So that we can just overcome this challenge by doing the part-time job in institute, which allows academic satisfaction and provides time to spend with the family. Or else one can start with the private practice, so you get a lot of flexibility. And starting private practice with partner also facilitates the in case of family problems that partner can take over the practice. So we need balance between the professional and personal life by scheduling the working hours. Gender bias is definitely there and which impacts the woman negatively both directly and indirectly, which slows down their advancement. And there is psychological damaging enough to lower the self-confidence of a woman. Now, because of awareness, educational exposure, that this gender bias is reducing. And now the society is accepting the abilities, talent, and potentials of a woman. There are many inspirational models like role models, mentor. Institutes also helps the woman to come up. There are professional societies also. These all can participate in improving the situations. So now there is change of face. Initially, women were not accepted in the medical society, but they are not well accepted. And moreover, they are in demand because since long they are known as healers. In this new generation, there is gender balance, reaching the gender balance. There are many opportunities in the form of increased fellowship and training programs, which help this new generation ophthalmologists to come forward. They are different than the older one in training, practicing, even entering the workforce than the older generation. While it is true that the present ophthalmologists tend to have different values and place more emphasis on the other aspects of their lives. But today's ophthalmology is more competitive. Residents have to learn the things which we have not learned by the older generation. There's too much of technology and they need to know each and every technology to progress themselves. Entering workforce is also different today's era, as there are many institutes are coming up and they are providing the already established practice which most of the women are interested, and they provide academic satisfaction also. And because of this and increasing number of patients, there is high demand of the young ophthalmologist, and I say this market is now buyer's market for the young ophthalmologist. There are many societies, they also play like RVO, WOS, and they arrange meetings, workshops, mentor-mentee program for the women, and some of these societies, they also give the travel fellowships. And I'm proud to be member of Indian Women Ophthalmic Society, which is doing wonderful job for the women to come forward, to get them established and to mentor them properly and to guide them properly. But still, there are barriers to reach the top. There are many issues. One thing is there, networking and marketing yourself is one of the issues, but still we can see there are women, they have established themselves like major. The example in front of us is the Mohita, who has done a wonderful job by establishing her institute. So how to meet these challenges? We have to emphasize the importance of flexibility at workplace, and sometimes women choose the specialty not by their interest or passion, but by the flexibility which it offers. So, and most of the time, if we have the facility at the hospital of for the daycare centers for the baby, the problems can be solved very much. So at the end, never say impossible. It itself says that I am possible. Don't say I can't. Take out the T. I can. After every storm, the sun must and sooner or later come out. The reign of the female inequality in medicine is slowly but surely reaching its end, and the newer generation of the women continue to find own way in changing the world and become successful in life. I wish all the women ophthalmologists a very best, get success in their career. Thank you.
Thank you, ma'am.
One thing, Manushri, can you just ensure that everybody else is muted apart from the speaker? Because otherwise there are lots of extraneous sounds. If you can tell the admin that, because the chat is disabled.
Yes, ma'am.
Thank you.
Backhand can do it. Tell the backhand that mute everybody else except the speakers, and in the end the judges as well. Like, judges should not be muted, otherwise, in the end there may be a challenge sometime.
Yeah.
Judges should mute themselves.
Yeah.
Yes, ma'am. Thank you, Shreya ma'am, for your enlightening words. Your words always help us to move forward. Shreya ma'am is known to everyone. Introducing her would be like showing lamp to the sun. But for those PGs who are new to the field of ophthalmology, I'm sure even they must be knowing her. But just for a brief introduction, Shreya ma'am is the professor and head department of SAMC, that is SAMES Institute Indore. And she is known for her work in cornea and anterior segment. She has done fellowship for the same from Eye Foundation America, and she has more than 50 publications in many international and national journals of repute. She is a renowned speaker, a very sought for speaker, and has won many awards. And the list of her awards would be exhaustive, so I have just enumerated a few here. That is the R.P. Dhanda Award for Best Video Presentation, MPSOS Best Lady Presentation, National Level Best Teacher Award at ECOIN, and WOS Leadership Award. These are just a few to enumerate. Thank you so much, Shreya ma'am, for enlightening us.
Thank you, Manushri. Thank you so much.
Now we have with us a youth icon, Dr. Mohita ma'am, who has touched our life. She even doesn't know how many lives she has touched. So, ma'am, you are also an inspiration for all of us. And introducing you is again like I'm humbled that I can do such a big job. And Mohita ma'am is the founder and chairperson of Tirupati Eye Center at Noida. She is a well-known ophthalmologist working in the field of retina, cataract, and LASIK for 27 years. And she has worked as an executive and presidential post in many societies and won many awards at international and national level. These are just to enumerate a few. She has won the WIO Honorary Award in 2017 in USS San Diego, then Champions of Change Award in WOS 18, President Appreciation Award for IMN 17 and 18. And again, it's a very exhaustive list. And I would just enumerate few more. That is, she has won an International Heroes Award at AIOS. And yes, definitely, ma'am, you are an international hero. So, I would now request ma'am to please enlighten us with her words and tell us more about WOS. Thank you, ma'am.
Can you stop sharing your screen, Manushree? So, is my screen visible? My screen is visible?
Yes,
Yes, ma'am.
So hello everybody and welcome to WOS. Very happy at this launch of the state competitive session, and a very big thank you to Dr. Meenakshi Dhar, who has taken a lead for doing these state competitive sessions. And I think it's a very big initiative which she had consented to take the lead, and she and Dr. Shweta are working very hard for it. My one big thank you always to Dr. Madhu Bhadwaria, our president, who's our inspiration and who's the biggest support for WOS always, as the most positive person who always comes up with so many positive ideas which keeps us going. And definitely the MP team, Dr. Shreya Thate, Dr. Amita Joshi, and Dr. Shweta Walia again. And these three ladies have worked very hard, and they have always been proponents of WOS, and we are very, very thankful to them. So WOS, if I describe in one word, it means I would sum up that one word as opportunities. So WOS is basically a society which is meant to give opportunities, and these opportunities are meant to make ordinary women ophthalmologists extraordinary, and the extraordinary women ophthalmologists even better. So initial few of my slides are a little philosophical. Allow me to be philosophical, because whenever I talk about WOS, I become a little philosophical, and I want that many of you juniors are here. So we want that you should imbibe these things in your life so that for lifelong they are with you. You are no ordinary people. You are a soul on a mission. And when you really want to do something, it's because that desire has originated in your soul, and you were born not to be mediocre and ordinary. When you start walking on your journey to learn, you soon become a part of the crowd, and learning takes a backseat, and the crowd or herd mentality roots. Being a part of the crowd is a very easy way out, but ultimately it makes your soul suffer. And this can change the day you decide to be different. And this is the day that is written in the stars. And this day is a date with your destiny. And maybe this is the date when you decided to join WOS. Because WOS is that platform which wants to give you opportunities and make you the best in your profession. And so WOS is all about being different. So all our programs are designed towards the mentor-mentee concept, because we believe that mentor-mentee concept is something which can actually pull up the mentees, as well as it gives the greatest level of satisfaction to the mentors. So we started this mentor-mentee program around 3 to 4 years back. And the gist of this program is that you are not alone in your professional journey. And we connect you, these are just two examples. We connect you with several mentors. And these mentors, you can actually choose your mentor, and you can connect with them on a one-on-one basis on a 1-hour virtual session. And this is followed by a lifelong connection. So whenever you need your mentor is there with you. We have a series called Rendezvous with Life series, which is conducted by our another strong pillar of support for WOS, that is Dr. Aarti Nangya. And in this, you have men and women ophthalmologists, national as well as international, who talk about how they reached where they reached and what were the challenges and how they overcame their challenges. we find that there is less representation of women in leadership. So we definitely conduct sessions which are in which we invite women who are in leadership roles, and they talk about how they became the leaders, and what are those factors which were actually pulling them down, and how they overcame those challenges and got into the leadership roles. We have inspiration series going on in which there are international award-winning presentations by young ophthalmologists in which they give those presentations. You get an opportunity to hear them and to get inspired by them. We have inspirations, and of course we have academic sessions, and we have women who have gone beyond ophthalmology also and proved themselves to be a success, because life is not just ophthalmology, it's beyond ophthalmology also. One of our flagship programs is Women in Research, a very ambitious program and a very looked up upon program. And these are just some of the photographs. But to sum it up, it is a program in which you get all sorts of inputs on how you can get into research, whether it is in the form of CP trainings, whether it is access to ethics committee, which if you don't have, then you can get that access through a WOS access ethics committee. These are some of the examples of women who completed their initial studies, and again, some of the photographs showing how various sessions, various teachings are going on in women in research. And I also want to tell you that Women in Research is soon starting a complete module for getting into research. And this module is based on how you can be a clinician as well as a researcher. It is not that you have to be a pure researcher, but you can be what is called a clinician scientist. And one of the ladies is today, Dr. Divya is today talking about how you can be a clinician scientist. So these are practical sessions on research. Very proud to say that last year, Women in Research has launched two important things. One is there is a rare eye disease pilot project, which is soon starting, and all of you are invited to join it. And then we collaborated with Department of Science and Technology, and three of our ladies have actually started government projects. One of them, Dr. Mezzabeen Rahman, will be presenting also today. So this is the Rare Eye Diseases group, which is soon starting. And this year itself, we are coming out with a special issue of Indian Journal of Ophthalmology on rare eye diseases, in which many of you WOS members have contributed. So I end by saying that WOS is an opportunity for all of you. Join us at WOS and webinar. Many of you have already joined in the last 1 week. So welcome everybody. And I'm sure that your presence is going to benefit us as well as you both. In WOS, we have always emphasized on one concept, and that is the concept of givers gain. You will find a very different environment here, where you'll find that everybody is trying to give rather than to take. So because we believe, and I personally also believe in this concept, the more you give to others, the more you automatically get back. So this is something that you will find in WOS. And so welcome again, and thank you everybody for who has made the efforts to conduct this session.
Thank you, ma'am. Your words have always been inspirational, ma'am, and what a lovely message you have given. The more we give, the more we gain out of it. And we all would like our lives to be like you and try and give more and more as you have taught us. And thank you so much, ma'am. I'm very happy to share that Dr. Ulka ma'am has joined us. Ulka ma'am has been DME of Madhya Pradesh Health Medical Sciences, and also Dean of MGM Medical College Indore. And she has been an explicit teacher and a guide for both men and women in ophthalmology. And we are very happy that Ulka ma'am has joined us today. We would request Dr. Ulka ma'am to please share a few words with us. Dr. Ulka ma'am.
Thank you, Dr. Manushree. Am I audible? Because I am on my way to Indore from Bhopal. Am I audible?
Yes,
ma'am, you are audible.
Okay, thank you. First of all, I would like to give thanks to Dr. Mohita, who is I think, inspiration for all these things in the WOS. And I am thankful to Dr. Meenakshi also, and my special thanks to Shweta. Yesterday only I asked her, can I join this? Because as Dr. Moita said, either we are giving or we are receiving. I think today I am at the receiving end because for last 5 years I was in um, directorate, working as director in medical education. So there the things were different. But of course, I help ophthalmology people by giving certain equipment and encouraging them for different things, different projects. So I think somehow I am always trying to uh, help the ophthalmology. And now I think I am at the receiving end. I am now getting active in the ophthalmology part only. And as as a teacher, I will say a few words for the newcomers because this today's meeting is for the budding ophthalmologists. So I think they should have in their mind 4 Ds, which are there for them only. That is, they should work with dedication and dedication along with devotion. So I will say that there are certain Ds which they should remember. So one is dedication along with devotion, because in any field, if they work, they have to have these two things in their mind. And of course, as Dr. Mohita said, distinctiveness. You should stand apart from others by excelling in that field. So distinctiveness is the third D. And then as in any field, we require discipline. So a disciplined thing, it is not only that reaching in time is a discipline. Discipline is whatever you are doing, do it with its full inspiration. Like it should be fulfilled with all the things which are required to do that process. So that is discipline. And the last thing is do all the things with dignity. So I think this is a message for all the newcomers in this ophthalmology. And my special thanks to all of you and my all the wishes, my best wishes to the competing uh, committees and their work in the field of ophthalmology. All the best. Thank you.
Thank you so much, ma'am, for your enlightening words and for guiding us. I'm so happy that you are here today along with us. Now, before we start with the competitive session, I would like to introduce to you all our judges who are the best ophthalmologists not only in India but who have worked explicitly and are well-known ophthalmologists in the entire world. So we have some of the best surgeons, the best clinicians, best teachers in the panel of judges. I would introduce them in brief. Thank you so much, ma'am, for your enlightening words and for guiding. We have with us Professor Meenakshi Yadav, who has worked over 2 decades in Kerala at Amrit Institute of Medical Sciences at Kochi and is well known in her interest and work.
Manushri, you just do the full screen and then click on Meenakshi madam's slide, because you are showing my slide there.
Okay, ma'am.
Full screen.
क्या हो गया तो
अरे ये समझ नहीं आता है। एक तो इतने सारे लड़के कच्छों की दाढ़ है, कच्छा एक भी मिलता नहीं है पहनने को, कहाँ के कहाँ रख देते हैं पता नहीं।
वही नहीं, हम तो खुद ही ला के रखते हैं जो भी है तुम्हारे, उन्हीं के नीचे तो नहीं घुसे, सिर्फ कच्चे एक साथ तुम्हारे झुले थे कल।
Somebody is talking in the middle. I don't know who this person is. I think this should be sort of.
Yeah.
Can the admin please mute everybody?
Is my screen visible?
Not as yet.
Please share your screen and
Yeah, and then go down.
go down one by one. You're right.
Yes, ma'am.
Full screen and then just press next slide. It will come.
I
Press
hope
full screen, bache.
Never mind if the full screen is not happening, then just go to the next one. Come to the screen that you are describing in the person.
Press the
ma'am,
down arrow. The next slide will come. Just press the down arrow.
Right.
Is it visible, ma'am?
Yes, it's
Dr.
visible.
Mohita's is visible.
Now just press next and next like that.
Yes, ma'am.
No, it's not next. You have gone miles ahead, I think.
Ma'am.
Now speak about Dr. Madhu, then you can go
Yes,
to the
ma'am.
next. Yeah.
Okay, ma'am. Sorry for the inconvenience.
No, it's fine, but go ahead. Yeah.
Dr. Madhu, madam is with us today as in the panel of judges, and ma'am is a graduate and postgraduate from KGMC Lucknow and has done her fellowship from Shankar Netralaya Chennai in interior segment. She has worked with the armed forces for 25 years as a very nice clinician, teacher and research worker. And after taking a voluntary retirement from armed forces, ma'am joined the Regional Institute of Ophthalmology in Sitapur. After ma'am's joining that institute, the institute has revived and is now working as a dinosaur in the eye care. And this is all because of her dedication and hard work. During her career in the army, she has received many prestigious awards, and she is a versatile and accomplished anterior segment surgeon and can perform corneal transplant surgeries, trabeculectomy, Ahmed glaucoma valve surgeries. Her special area of interest is in glaucoma, especially the newer diagnostics. And ma'am has presented various papers, live surgical videos, and has done explicit research in the field of glaucoma. And she has conducted many instruction courses at annual conferences in national and international levels. Ma'am has received various awards like the Dr. Sheila Memorial Award in 2010, General Officer Commanding Southern Army commented in 2009, and she has also received All India Achievers Foundation Award in March 13 for excellence in healthcare. Vision 2020 has awarded her for equitable eye care, especially for women and children. Welcome, ma'am, and we are blessed to have you in the panel of judges.
Session start होता 10 बजे
With us, Professor Meenakshi, who has spent over 2 decades at the Amrita Institute of Medical Sciences in Cochin, and her subspecialty interests are in neuro-ophthalmology, glaucoma, squint, and cataract. Being a pen ophthalmologist, she has a teaching experience of more than 25 years and loves to teach her postgraduates. She has presented numerous papers at national and international forums. And Dr. Sunita Dubey, ma'am, who is heading the glaucoma services department at Shroff's Charity Eye Hospital and is known for her technical as well as community work and performed more than 25,000 cataract surgeries. We are proud that she is an alumni of MGMMC Indore, and she is a life member of many scientific committees, including International Research Advisory Board of Elegant Pharmaceuticals and many other international companies, and has again published more than 50 research publications, especially in the field of glaucoma. She has received many awards, including Best Paper Award for Outcomes of Pediatric Glaucoma at the World Congress, then E.T. Selvam Award for the Best Poster Presentation, and Best Presentation in Glaucoma Session for the paper Surgical Outcomes of Pediatric Glaucoma in AIS 2007. It is indeed a pleasure to have Sunita Dubey ma'am with us. We also have Dr. Somshila ma'am with us, who is the head of cornea and anterior segment services in LVPI Hyderabad. She is an alumni of BYL Nair Charitable Hospital in Mumbai, and is known for her work in uveitis and ocular pathology. Ma'am has done her fellowship in cornea from LBPI and the fellowship for uveitis and ocular pathology from Los Angeles, USA. She has over 14 years of rich experience and is one of the most sought after surgeons. She has extensive experience in conducting clinical trials and has more than 60 publications in various peer-reviewed international and national journals. She has a passion for teaching and takes an active interest in various doctor training programs. Welcome, Somshila ma'am, and we are blessed to have you with us. Then we have with us Dr. Aarti Nangia ma'am, who is the unit head at Fortis Vasant Kunj and Fortis Escorts Hospital, Delhi. Ma'am has been an associate and senior consultant with the Site Avenue, senior resident for 4 years at Batra Hospital, and she's a visiting consultant at Max Hospitals and also was one of the founder members in the conception of Max Hospitals. Ma'am has headed various executive posts in various ophthalmologic society, including the Women Ophthalmologic Society Haryana chapter. Then we have with us Dr. Devi Aishwarya ma'am, who is a consultant for cornea and cataract and refractive services at Dr. Agarwal's Eye Hospital, Cuttack. Then Dr. Ashu Agarwal ma'am, who is a vitreoretinal surgeon. She is the associate professor in the Department of Ophthalmology, SMS Medical College, Jaipur. Then we have with us Dr. Sandhya Makhija ma'am, the senior consultant at Sant Parmanand Hospital, Delhi. She is a fellow in Retina Foundation, fellow International Council of Ophthalmology in Belgium, fellow New York Eye and Ear Infirmary. Then we have with us Dr. Shubhra Goyal ma'am, who is an known oculoplastic surgeon at an international level, and she is working with the Apollo Hospitals, Hyderabad. She has won the prestigious American Academy Achievement Award for the year 2016, Innovation Award by Women Ophthalmologic Society. She is also the section editor for Oculofacial Aesthetics, Indian Journal of Ophthalmology, and has published various prestigious publications in national and international journals. Welcome, Shubhra ma'am. So these were the very nice panel of judges who have consented to be with us today. So with the judges' permission, can we begin with the session for today?
Please go ahead.
So we have with us our first speaker for the day. The first presentation is of Dr. Aviral Vasudev, who is a third-year resident at Aurobindo Medical College and PG Institute, Indore. His mentor is Dr. Pragya Prakash, who is assistant professor at the same institute, who has also done a fellowship from Arvind Eye Institute. So Dr. Aviral Vasudev, the first presenter. All PG students, you will be given 5 minutes for your talk, followed by 4 minutes of discussion. And we have a time limit for this. And for every 1 minute, if you will exceed, there is a negative marking also. So please stick to the time.
Dr. Aviral, are you there? Dr. Aviral Vasudev?
Aviral, are you logged in?
Manish, we can take the second candidate.
Yeah.
We'll take the second candidate. Our second candidate is Dr. Garima Tiwari from Sames Institute, Indore.
Dr. Garima, are you there?
Yes, ma'am. Good morning, ma'am.
Please start your screen share.
Yes, ma'am. Ma'am, am I audible? Can I start?
Yes, please.
Good morning, everyone. Today I am going to present my case on collateral damage of COVID lockdown in lives of diabetic patients, and my moderator is Dr. Sonam Verma, ma'am. A 50-year-old male came with clinical complaint of painless, significant gradual diminution of vision in both eyes, right eye more than the left eye. He has progressive blurring of vision since 1 year, and in June 2021, he got his first shot for Covishield, after which he noticed that his blurring of vision increased. And here he misunderstood his nature of disease and he correlated with the Covishield. He is a known diabetic since 11 months, and he was diagnosed elsewhere for proliferative diabetic retinopathy in the right eye, but he did not take any treatment. His both parents were diabetic. There was no history of consumption of tobacco and alcohol. On general examination, he needed no assistance in walking and was thin built, and rest of the general examination was normal. On ocular examination, his right eye visual acuity, both unaided and best corrected, was 1/60, and left eye it was 624. And rest of the anterior segment examination was normal, including the IOP and the color vision. We can see here, this is the fundus photo of the right eye, in which we can see the media is hazy. The disc is normal in size, shape, color, and margin, but there is NVD. The CD ratio is 0.3:1. The FR is obscure due to the subretinal hemorrhages. The blood vessel is dilated and tortuous. The background shows cotton wool spots, hard exudates, and a lot of hemorrhages, pre-retinal, intraretinal, dot blot, and lot of NVE. These are the peripheral pictures of the right eye fundus photo. We can see the traction bands as well. On the OCT of the right eye, at the disc and around the disc, we could see a lot of inflammation with the taut hyaloid that caused a lot of traction. And at the macula of the right eye, we can see a band which is causing traction, the vitreous band. And on the B scan, these findings were consistent, and it also revealed an unorganized fresh vitreous hemorrhage. The left eye fundus photo, we can see the media is hazy. The disc is normal in size, shape, color, and margin with NVD. The CDO ratio is 0.3:1. The FR is obscured due to macular edema. The vessels were again dilated and tortuous, with background with a lot of hemorrhage and neovessels, dot blot, and superficial hemorrhages. These are the peripheral pictures of the left eye. The left eye macula showed that there was a vitreous detachment, posterior hyaloid was detached, and we can see the foveal counter is irregular with a lot of inflammation and old cystic spaces and a subretinal fluid. So my provisional diagnosis for the right eye is advanced diabetic retinopathy, and left eye high risk proliferative diabetic retinopathy with macular edema and taut hyaloid. The patient was admitted and investigated systemically. FFA was not preferred due to deranged renal profile. The investigations, we can see the sugars were raised. He had a poor sugar control in the past as well, and the renal functions were deranged, for which a nephrology opinion was taken, and he was diagnosed with acute kidney disease. The management for the right eye after the investigations done so far was planned that on the day 3, intravitreal anti-VEGF injection was planned, and after 3 days, a vitreoretinal surgery was planned. So we can see here after pictures of the right eye after the anti-VEGF injection, we can see there are regression of the new vessels on the disc and the periphery as well. This is of the vitreoretinal surgery. This is the 7th day post-op. We can see the clearing of the blood which occurred after the surgery and the 20th day. This is the whole picture. Here we can see the 30th day post-op as well, when the vision was 1/60. For the left eye, a prompt PRP, first sitting was planned on the day 1 and then twice at 3 days interval. So here in this diagram, we can see the first picture is of the pre, and the rest 3 are the post-PRP visual acuity with post-PRP fundus photos with a visual acuity of 624. So my differentials include any condition that causes hemorrhages or a similar picture like Valsalva, retinal vein occlusions, retinal ischemia, radiation retinopathy, anemias, any vasculitis, severe hypertensive disease, and Turson syndrome. So my conclusion is that prompt intervention in both eyes in a patient prevented impending catastrophe. Patient's livelihood is restored. At least 6 out of every 10 patients in our OPD suffered quick progression of diabetic changes in eye due to a similar picture. So progression we can see is associated with preventable irreversible blindness for lifetime, and adoption of a total lockdown twice, and a pandemic fear caused near total suspension of OPD visits and psychological barriers to access the health services. Presumptions regarding any random symptom that patients co-linked with the side effect of vaccination made people further predisposed to mismanagement. So backlog of diabetic burden in working population, hence needs rapid understanding of the behavior of disease to adopt approaches in COVID exposed population and expecting the unexpected. Thank you so much.
Over to the judging panel.
Do you think the vaccination could have had any effect on the occurrence of the symptoms?
Morning, ma'am. Yes, ma'am. The studies, we need more studies for this, and I think it's slightest 1 or 2%. Yes, there may be, but not totally. But maybe in further reports or in further future studies, we may see that there are some associated side effects due to vaccination.
No, what ocular changes can occur due to COVID now that you brought the vaccination part?
Ma'am, due to COVID, we have seen the spike in the sugar of the patients, basically, that the patients that were admitted here, the OHAs, that were the patients were on them, but they didn't have any effect. So we
Any
had to shift.
vasculopathic changes?
Yes, ma'am. A lot of hemorrhages and it involve the optic disc as well, causing neuritis and the optic nerve involvement.
So vascular changes have been reported a lot. So what are the types of vascular changes that have been reported in patients of COVID?
Ma'am, hemorrhages, intraretinal hemorrhages are reported.
That's random hemorrhages or some kind of special diagnosis. And there have been some optic nerve changes as well.
Yes,
cranial nerve changes as well. So are you aware of them?
Yes, ma'am. Ma'am, intra dot blot hemorrhages and superficial splinter hemorrhages.
No, that's not a diagnosis, that's a finding. But there have been certain firm diagnoses and multiple case reports on this, that there have been vascular occlusions. So that you go back and read, I won't waste time. A question I want to ask you is that what are the things you see in the anterior segment in a patient of diabetes before you get inside the eye, like before you dilate and before other things that you start seeing? What are the 3-4 multiple important things that you see in diabetics?
Ma'am, anterior segment, we see basically the iris. There are any changes of blood vessels on the iris. There are new vessels on the iris. Then the iris margin, the lens, because in diabetes they are predisposed to cataractus changes. There may be early cataractus changes. So the lens in the iris specifically.
And what investigation would you do?
No, will you check the angle or not before dilating to examine? Yes. Because the patient will require multiple examinations, right?
Yes, ma'am. Yes, ma'am.
How would you check the angle?
Yes, ma'am. Sorry, ma'am.
How would you check the angle?
Ma'am, angle on the slit lamp I'll check by the von Herrick grading, and if I'll find that it is narrow, then I'll go for gonioscopy and then go for dilatation of the patient.
When you are asked a question about how to check the angle, you should straight away talk about gonioscopy. So that's what is definitive.
So what was your counseling to the patient before you embarked on the journey for treatment?
Ma'am, first I'll explain the nature of the disease, that it is life threatening, and I'll make him understand that it is a very important disease that he should not lost to follow up, and then the treatment will start. And I'll also explain the different treatment options that are available, like PR, pan-retinal photocoagulation, and the anti-VEGFs, because Indian patients are usually not compliant to anti-VEGF injections. So basically, for these follow-ups, basically a follow-up is very important for a diabetic patient.
Why do we give anti-VEGF before doing either a PRP or doing a surgery?
Ma'am, because it regresses the new vessels, and when we do surgery or we do the laser, then there is a lot of chance of bleeding, and that causes hazy media, and it further causes difficulties in performing the surgery as well.
Is there any role of any kind of a steroid, intraocular steroid?
Yes, ma'am. In pseudophakic patients, basically, it was found that the intravitreal steroids were much helpful, and it can be replaced by the anti-VEGFs for regression of the new vessels.
Any role in DME?
Ma'am, in DME, anti-VEGFs are preferred, ma'am.
Why?
Ma'am, because it slows down the progression of the disease and regresses the vessels. And we can also, ma'am, because there we can not use, like we have the focal in the grid lasers, but for the phobia as well, we need the anti-VEGF specifically if it involves a phobia.
In which patient of DME you will not give anti-VEGF?
Ma'am,
Ischemic. You will give us steroids only. You cannot give ischemic contraindication. I think we are done with our 3 minutes. Backhand, please tell us when 3 minutes are over, because we are the oldies. We can ask, carry on asking questions for life.
The 3 minutes are over.
Okay, so we can go to next case then.
thank you.
Just one comment. Just one comment, Dr. Garima.
Yes, ma'am.
Nicely presented for the shortage of time, but just one comment. When you're saying about BCVA, I think near vision is a very important component of BCVA.
Yes.
So don't just leave it at distant vision. This is for all the postgraduates.
Yes, ma'am. Yes. Thank you, ma'am.
Thank you, Dr. Garima. You can stop sharing your screen.
Yes.
All the presenters, the moment presentation is over, please stop sharing right away.
Dr. Garima, please stop sharing your screen.
Yes, ma'am. Ma'am, actually, it is not working.
It's on the top. It's on the top. Go on the top of the screen. Yeah.
We have our next presenter, Dr. Aarti Tiwari, who is a third-year resident from MGMMC Indore. Her mentor is Dr. Shweta Walia, ma'am. Dr. Aarti, please.
Yes, ma'am.
You will be given 5 minutes. Please do not exceed your time limit.
I think after 5, tell the person to switch off the screen sharing bit, so that the time is automatically marked.
Yes, ma'am.
Ma'am, is my screen visible, ma'am?
Yep, go ahead.
Good morning, ma'am. Today I'm presenting a case of a 60-year-old female.
Your
presented to
slides
our
haven't
OPD
come
with
up.
chief complaint of patient.
We can't look.
Yes,
the
ma'am.
case is not open.
Screen is not
Slide
visible.
hasn't come up.
Your case hasn't opened up. Open a PowerPoint.
For all the presenters, please keep the first slide open so that when you start the slide share, that's what comes up.
Ma'am, is it visible now?
No, it's
So
not.
It's not.
Stop screen share and restart it.
Stop screen share, open your presentation, and then start screen share.
Is it visible now?
Yes, yes.
Good morning, ma'am. Today I'm presenting a case of a 60-year-old female presented to our OPD with the chief complaint of facial pain, followed by protrusion of left eye since 3 years. Patient was apparently already year back when she experienced left-sided facial pain with nasal block on and off, for which she took some over-the-counter medications and got relief. She then started observing her left eye, which was bulging forward. Protrusion was... Yes, ma'am.
The presenter, please, slides have to move. Yeah, thank you.
Ma'am, is it moving now?
Yes, yes, please continue.
She then started observing her left eye, which was bulging forward. Protrusion was gradual, progressive, not associated with any pain initially. Later, she had painful eye movement. She also noticed gradual, progressive diminution of vision in the same eye. History of on and off with recurrent nasal congestion and itching in nose. History of right eye painless, progressive diminution of vision with floaters since 1 year. On leading question, patient was not aware of any diplopia or nose bleeding during the course. Rest of the history was negative for thyroid eye disease or malignancy. Patient was a known diabetic since 2 years, for which she was taking oral hypoglycemic agents. Personal history and family history were unremarkable. Patient was alert, conscious, cooperative, well-oriented to time, place, and person. Pillar was present. Rest of the examination was normal. Vision in the right eye was 660, improving with -5 sphere to 636, and near vision was N10 in the right eye. On the left eye, the vision was counting fingers close to face and projection of face inaccurate in inferior and temporal quadrant, and not improving with glasses. Examination of head was in a down out position, and aberration proptosis was present in the left eye. Upper lid of both the eye were covering 2 mm of superior quadrant. Lower lid was just touching the limbus. Palpebral fissure height was same in both the eyes. And
I think there is some connectivity problem with her. Network issue.
Should we take the next participant?
Yes, we can take next participant.
Next, we have Dr. Rakshit Agarwal, second-year resident from MGMMC Indore. His mentor is Dr. Preeti Rawat, ma'am. Dr. Rakshit Agarwal, please join.
Yes, ma'am. Good morning, ma'am. Ma'am, is my screen visible?
Make it full screen, please. Yeah. Yes, it is.
A very good morning to all the respective judges, moderators, and my colleagues. I would like to thank my mentor, Dr. Preeti Rawat, ma'am, for helping me prepare this case. My patient is 40 years old, female, resident of Salayagram, Ashoknagar, MP, laborer by occupation, presented with the chief complaints of drooping of right eye eyelid since 15 days. Patient was apparently all right 15 days back when she started experiencing drooping of eyelid of the right eye, which gradually increased and progressed in 4 days to complete drooping that was associated with headache. There was no history of trauma, no history of any redness, photophobia, discharge, swelling, or any other complaints or any complaints of loss of vision. There was no history of any neurosensory or motor loss. There was no history of generalized weakness, tingling numbness, or stiffness in the body. There was no history of nasal stuffiness, dental, or oral pain. Past history, she was a known case of hypertension since 2 years and poorly compliant on treatment. There was history of COVID-19 infection 1 year back. No any history of similar episode in the past, and no history of diabetes, tuberculosis, or asthma. Family history was not significant. Personal history, diet was mixed, sleep and appetite normal, bowel bladder habits were normal. Drug history, there was nothing significant and no known drug allergies. On general examination, patient was conscious, coherent, cooperative, well oriented to time, place, and person. And the rest of the general examination was within normal limits. Systemic examination, CNS examination, CVS, respiratory system, and per abdominal examination were within normal limits. Binocular eye examination, position of head was normal. Position of eyeball, right eye was in 15-degree exotropia position. Ocular movements of right eye were restricted in all the cases, and abduction and infraduction movements were 25% restricted. Were only 25% present, and supraduction and adduction movements were totally restricted in the right eye, while the left eye was normal. Vision of right eye was 6.9 with pinhole improving to 6.6 partial, and of left eye was 6.9 with pinhole improving to 6.6. Near vision of right eye was 6.36 and of left eye was 6.24. On right eye ocular examination, the lid showed complete ptosis and the lens showed gray-white reflex. Rest examination was within normal limits. Pupil was 3 mm in size and central circular reacting to light. Left eye examination was completely normal. These are the photographs of patient in supraversion, dextroversion, levoversion, and infraversion, as well as primary gaze. We can see some movements of right eye were present only in dextroversion and infraversion. In rest of the gazes, the movements were completely restricted. Fundus examination of both the eyes were within normal limits. On the basis of this, my provisional diagnosis is right eye external ophthalmoplegia with probable etiologies and differentials being cavernous sinus thrombosis, superior orbital fissure syndrome, orbital apex syndrome, Tolosa Hunt syndrome, myasthenia gravis, ophthalmoplegic migraine, and lastly, rhino-orbitocerebral mucormycosis. Investigations. All the blood investigations were within normal limits, and MRI brain plus orbit was ordered. That showed no significant brain parenchymal abnormality. The cavernous sinus also appeared normal, and no constriction in the internal carotid artery lamen. The edema and hyperintensity at the region of orbital apex was observed in the on the right side, and these findings were suggestive of inflammatory pathology. On the MRI report, the findings were most likely suggestive of inflammatory pathology and query Tolosa-Hunt syndrome. My final diagnosis, right eye external ophthalmoplegia, secondary to inflammatory pathology, probably Tolosa-Hunt syndrome with cataract and is grade 1. She was started on treatment with IV methylprednisolone 1000 milligram for OD for 3 days, followed by oral prednisolone started at 50 milligram per day that was tapered weekly, tablet Nervoc OD 1 OD for 30 days, and tablet paracetamol 500 milligram as and when required. Locally, Nepafinac eye drops were started 3 times a day. These are the pictures of patient at day 3 of starting the steroid. There was some resolution of extraocular movements, but the ptosis was still present.
एक मिनट ना, मेरा सेम केस यही है, मुझे सुनना है क्या क्वेश्चन पूछना है.
On 1 month follow-up, this is the photograph of patient showing.
Dr. Rakshit, your 5 minutes are over. You can stop sharing your screen now.
Thank you.
What was the pupil like?
Ma'am, pupil was reacting to light and 3 millimeter in size.
So what is your diagnosis?
Ma'am, my diagnosis is Tolosa-Hunt syndrome of right eye.
No. Clinical diagnosis.
Ma'am, clinical diagnosis is right eye external ophthalmoplegia.
Which all nerves do you think are involved?
Ma'am, third and fourth nerve are completely involved, and also the sixth nerve is involved.
You are saying that the eye was in exotropia.
Yes, ma'am.
But you are still saying that the sixth nerve is gone.
Ma'am, sixth nerve is not completely affected. Therefore, there were some movements of the lateral rectus present.
Wouldn't you call this a pupillary sparing ophthalmoplegia?
Yes, ma'am. External ophthalmoplegia does not involve pupil.
All your differentials had acute conditions, cavernous sinus thrombosis.
Yes, ma'am.
How will you consider cavernous sinus thrombosis in a normal walking, talking patient?
Ma'am, we just want to
things out that you had asked for, there were actually mucormycosis an year after is not happening in COVID patients.
Yes, ma'am. That's why I put
and the course is very acute.
Yes, ma'am. That's why I put it in the last because and also cavernous sinus thrombosis is a life-threatening condition. That's why we need to rule out it first.
So now, logically, what are the possible differentials you should think of in a condition like this?
Mostly superior orbital fissure syndrome, orbital apex syndrome, and Tolosa-Hunt are the first 3 diagnoses we should put in this patient.
Dr. Rakshit.
Shubhra, yeah.
What was the age of the patient, Dr. Rakshit?
40 years, ma'am.
Sorry?
40 years.
Okay, so in a 40-year female who had a certain onset of ptosis with, the ophthalmoplegia, the differentials which you have given is a very generalized differential. So what would you think would be the most common thing which you can think can happen in a 40-year-old female? Forget about Tolosa-Hunt. Tolosa-Hunt is just a very, it's not a very specific diagnosis. Any inflammation happening at the apex can be labeled as Tolosa-Hunt syndrome, and you can give IV steroids. But I just want you to go on the case. When you are doing a case presentation, it's not important to jump to the.
Myasthenia gravis is an important provisional.
Sorry?
Myasthenia gravis.
Does myasthenia gravis cause ptosis, complete ptosis with external ophthalmoplegia uniocularly in a young patient like 40 years who has no other things happening on the other eye?
And constant?
No, ma'am.
Yeah. And mucormycosis, myasthenia gravis, I think you should just take them out of your differential. So I think what you have to first think of in such individuals is there any mass occupying lesion at the apex? Is there any ischemic changes happening? Is there diabetes, hypertension, or any other ischemic changes which could cause sudden onset of orbital apex syndrome? Superior orbital fissure syndrome, orbital epic syndromes are just the conditions under which there are specific reasons why it happens, right? So that could be the thing. And if you see your MRI, there is actually a lot of things happening in the medial orbit at the apex. So it is still unknown why this patient had what she had, because intravenous methylprednisolone will work anyways, whether it is inflammation or any other ischemic changes. So I think a lot more work has to be done. Now, another pointer here is, and please stop me when I'm crossing my time, is that as a postgraduate student, when you're presenting, nobody is asking you to come to diagnosis. What they're looking at is how have you reached to your diagnosis? Have you done the examination properly? Are you logically connecting the dots? So if there is a painless, sudden onset proptosis, where this patient doesn't have any thyroid eye disease, what are the first three common differentials which you will have? Because you can't have so many of differentials happening. Okay, even I cannot write so many differentials. And mucormycosis, just because we are in COVID times, please don't bring it into your diagnosis list, differential diagnosis list.
Akshit, before you jump into the differentials, as very rightly Dr. Shubha said, what are the basics of getting investigations on the sinuses? Because sinuses with diabetes can not only be fungal mucor, it can be aspergillosis also, and a whole lot of other things. Because of growth there in the orbital apex is likely very, very common from the years we've been seeing is a diabetic patient with fungal infection, not really mucor always. It can be many, it can be a white, like a candida infection or an aspergillosis. So did you take the history of sinuses or get a CT or a X-ray done on the sinuses as well?
There was no such history of any immunocompromised status of the patient. She was non-diabetic, and as well MRI was done, so it does not show any mass in the area, in that area.
You didn't take an ENT consult on that? It's
No.
usually a referral, any proptosis to be seen by an ENT surgeon as well.
Okay.
Dr. Rakshit,
Dr.
from
Rakshit,
your presentation, what were the
Shubhra's question is unanswered. Let him finish answering her question before he moves forward, please. Rakshit, Dr. Shubhra asked you a question, right?
Yes,
so
ma'am.
will you please tell her what did you think? What are the three things that you thought of? Because that is the crux of this whole case.
Ma'am, first of all, I thought there can be any lesion in the orbital apex or in the brain.
That is site of lesion. She's asking you the nature of lesion. What are the kinds of nature of lesions you can have in a short duration, unilateral, constant, painless ophthalmoplegia, if I can sum it for you.
Ma'am, it can be inflammatory lesion. It can be any aneurysm or any vascular abnormality that can cause this.
Inflammation without pain, one.
Yes, ma'am. Any neoplasm or
what neoplasm can you think of?
Ma'am, craniopharyngioma can be there.
There, craniopharyngioma.
In the
I think the 2 minutes should be up.
I think they are up.
Yes, ma'am, they are up.
Actually, think of common causes, don't jump to uncommon causes. That's a mistake we do as postgraduates because we get very fascinated by the uncommon diagnosis. Okay, so we can discuss the cave offline because the time is over and you have to conduct the session. But yeah, good presentation. Keep it up.
Common things commonly correct. Rare things rarely correct.
Okay.
Thank you so much, ma'am. Now I would be handling it over to Dr. Anshu Khare, ma'am, who would be moderating the session from now.
Thank you, Manushri, and I welcome everyone and good morning to everyone on this chilling morning. We have a guest speaker, Dr. Namrata Sharma. She's here. Good morning, ma'am.
Good morning. Good morning.
Good to have you, Namrata.
Hi, ma'am. How are you?
Everybody.
Everybody is going. I am going through COVID, so it is recovering from COVID.
So I hope, ma'am, you get well very soon.
Thank you.
And it is my great privilege to introduce one of the most inspiring lady ophthalmologists to not only the females ophthalmologists here, also to the male ophthalmologists who are present here. I welcome Dr. Professor Namrata Sharma ma'am. She's Honorary General Secretary AIOS, and I think she doesn't need any introduction, but still just to sum up, it's huge introduction. I tried to fit into few slides, but really I was short of slides to put her introduction here. So she's consultant ophthalmologist, cornea, cataract and refractive surgery services, RP Center, AIMS, as we all know, and she did her post-graduation from RP Center, All India Institute of Medical Sciences, New Delhi, and further she pursued her fellowship from Moorfields Hospital in London, and she's Regional Secretary, Asia Pacific Academy of Ophthalmology, and she's the Honorary General Secretary of All India Ophthalmology, as we all are very aware of. Her clinical work includes all the phacoemulsification surgeries with foldable intraocular lens implants, and her field of interest is the excimer laser refractive procedures, all kinds, LASIK, PRK, SMILE, phakic intraocular lenses. Her key area of interest are corneal transplantation, including all kinds like DALC, DSEG, DMEC, reconstructive procedures, keratoprosthesis, and her areas of research include all aspects of corneal diseases, including keratoconus, cataract and refractive surgeries, as well as lab-based stem cell therapies. List of award and achievements is huge, but just to sum up and name a few, she has 2 patents, Natasol and Natametrix. She's a brand ambassador of Tear Film and Ocular Surface Society in India, and also she's in the research committee member of Asia Pacific Academy of Ophthalmology. See, it's a huge list of international and national awards. So, but one which fascinated me really is she's been honored as one of the 100 most influential female figures in ophthalmology in the world, the Power List 2021 by ophthalmologist. So it's a great achievement, ma'am, and really you deserve it. And also she has won the leadership award in APAO, and she's the Senior Achievement Award in American Academy of Ophthalmology, and there are many more to list. And also she has received many national awards, and we are very well aware of her administrative position. So she's been on the presidential and secretary and executive members of so many societies. And just to sum up, ma'am, we invite you for your enlightening talk. So ma'am, please.
Thank you so much, Anshu, for that kind introduction. And it is an honor, privilege, and always a pleasure to be on the platform of Women Ophthalmological Society and to be addressing all the lovely ladies here. Especially, I would like to thank the President, Dr. Madhu Badoria, Dr. Mohita, MP State Chapter representatives, including Dr. Meeta Joshi, and all the other people who have organized this and who have invited me here. So thank you so much. It gets very difficult to select a topic for the postgraduates, and I was just thinking what to talk to them, and then I just thought that what is relevant to them, I think I'm going to talk about this, and that is maximizing your PG or residency program to your full potential. So what generally happens is that we really don't realize when we are at that stage in life that it is all in making, and those are the things which lay foundation. And having said this, I would also say that in life actually what you become much later on. So wherever you are, whichever medical college you are or whichever fellowship program you are into, it doesn't matter. Only thing is you have to give it 100% of it. And there are various things which you need to learn as you go through your PG program or residency program. So you have to hone your clinical skills in whatever your limitations are, whatever your OPD structure is. So you have to hone your clinical skills, then your surgical skills, because surgery is what we are here for as ophthalmologists. Your research caliber, even if you don't have it, it doesn't matter. But I think one very important document that you all would be writing would be thesis, and I feel that it gives the maximum satisfaction if at least your thesis is published somewhere. And I'm sure all the mentors who are sitting here they are all great mentors and would help you to do your thesis as well as help you in your pursuit for publication. And I think it is very important because ophthalmology is a ever evolving branch, and by years and by days and by months you have another machine, and it is very important to, not saying you should know all the machines, but it is very important to adapt to the technology. So while you are a resident, one should be very good at clinical examination. And ophthalmology is a little different because it is medical as well as it is surgical. And maximum amount you would learn from your teachers, but I think I should say that maximum amount you would learn from your seniors. So if you are a first year, say junior resident or a PG student, you would learn maximum from a final year PG student, or you would learn maximum from your own senior resident, because you will not have that hesitancy factor in asking any question at your level. And best to ask all your questions now, because as you get senior you cannot ask too many questions because you are supposed to know all the answers. Of course, case presentations and routine ward round that is happening plays a very important role in honing your clinical skills. And sometimes you read so many pages of a book, but if somebody just shows you a finding, or somebody just tells you a tip, or somebody just tells you a trick while you are doing surgery, then those things are not written in 3,000 pages of a book. You may read it, but then in ophthalmology, which has both medical and surgical disciplines to it, what your seniors tell you in just 1 second or in 5 seconds or in 10 seconds stays by you throughout your life. It is important that you learn all the instruments. Here I'm shown some high-five instruments. Whatever instruments you have in your department, whether it is just plain slit lamp, or it is a keratometer, or it is a biometer, I think it is very important that you learn how to operate those instruments at your level, rather than expecting the optometrist or expecting the paramedical worker to do the test for you, because that is going to stay with you for always, and that is probably the only time when you would be doing it yourself. So it is important that you focus on getting adapted to handling of these key instruments. It is very important to develop good communication skills, especially with the patients, because always remember that anybody who walks into your OPD is walking into a temple of, you can say, treatment, and is akin to almost like God. And this is, I quote Professor V.K. Dada's words, who was my teacher, because he is allowing you to learn so many things on himself or herself. So it is very important to take consent of the patient, to be nice to the patient, because patients are your primary teachers, and never miss an opportunity to learn something new on them. So, like I said, that your primary books are actually your patient's eyes, or in fact, patients in total. Then I do realize that in this era where COVID has hit everybody, last 2 years have really taken a toll on the PG teaching program. And so there are various kind of simulators which are available to improve the clinical skills, which may or may not be available to you. But wherever and whenever they are available, I think we should use them. And it is important that you learn every aspect of ophthalmology. You would be jack of all trades, but then you need to choose later on in life what you actually want to become, which specialty you want to choose, or even if you don't want to choose a specialty, then you need to be a comprehensive ophthalmologist. So you need to learn all the skills at least at your stage. Then whether it is indirect ophthalmoscopy, this is the scene of our surgical skill development lab, where we do have synthetic corneas and we do have goat eyes, etc. I think there is a need that we should have a surgical skill development station in all the medical colleges and all the regional institutes of ophthalmology, in all the places wherever training is going on. It doesn't take too much to have it. It probably requires only a workstation kind of a thing, but then it is a harbinger of a lot of confidence that we might instill in our postgraduate students, And I think that is something which we really need to work. All these things, I'm sure you are well aware, excellent presentations being done by the postgraduates, and all these things you should know. This is just a small list of what you should master at the end of the residency training, all your ways to examine whether it is slit lamp, direct ophthalmoscopy, tonometry, gonioscopy, indirect ophthalmoscopy, even contact lens evaluation, which is very much ignored. And it is only later that when people are starting their practice, they come back to, our contact lens clinic to see how it works. So I think all that is available to you should be used at the same time. Of course, surgical skills is very important because ophthalmology is a hybrid field, and only surgeries give the amount of satisfaction that we all are looking for. Here, I would just like to say again from the COVID era that even if you've not been able to do surgeries, it really doesn't matter. You can be assisting surgeries, you can be watching surgeries, you could be looking at unedited videos of your mentors, because that gives a lot of knowledge. Just to give one example, when I was in pool officer and I did not do surgeries for almost 3 years, which is a long time, I used to think that, I will never learn phacoemulsification because that had just come in at that point in time. But then by watching surgeries from my own seniors, by editing their videos, by making presentations, I could fathom all the complications, all the problems that could occur. So when eventually I did start phacoemulsification, I didn't have to go through those problems, or even when they occurred, I knew what to do. So it is very good to watch all your teachers, our senior teachers are there, and they would have videos with them which are unedited. And if you watch those videos, you would know at what point in time the problems can occur and how to tackle them whenever you have an opportunity to tackle them. Of course, all the surgeries, these are basic surgeries. You can do some of them, but you may not do some of them, at least watch some of them. If not in your own theaters, then maybe on YouTube. Nowadays, there is so much of material already available on the virtual platform that it is easy to get hold of it. In our times, we used to struggle to even get through the journals, which were not available, and we used to visit conferences so that we could get the material there. And additionally, whenever we went out for a conference, also tried to visit a center at, for a day or two, so that we would have a different kind of a perception there. So I think it is important to view the surgical procedures. There are a lot of new machines which have come up, which may not be accessible to you, but then I think if you just watch them on the YouTube, that is good enough, because the idea is that you have to watch the steps of the surgery. Then there are numerous ways of acquiring the surgical skills, like in the surgical skill center. Like I said, we would strive to have one in every medical colleges, at least one workstation. And we are also having it at the All India Ophthalmological Society headquarter. And we would be inviting most of you for these kind of surgical sessions, which would be in the form of wet labs. So you will not have to wait for conferences to happen where wet labs are there and there you practice your surgery. The surgery practice session will be available round the clock at the AIOS headquarter, where you can come and be a part of it. It will be generally a 2-day or a 3-day course. Now, this is just to highlight the fact that sometimes, sometimes, in fact, what all your teachers, we've learned all our, especially the skills during the post-graduation, have learned from our own seniors who were our senior residents or who were our senior junior residents. And it is important that you learn it from them, because you may not know everything all by yourself. So, like I said, these sort of setups are required, and this is going to be the way it is going to be, at least for a couple of years, and also because we cannot have our postgraduates not knowing any surgery and passing through the virtual exams. They have to have some kind of hands-on which is required. So this is just to show a model surgical skill development center where we do have operating microscope, and then you have monitors like this, so that as you do the surgery, people can guide you through the surgery just sitting outside, and tell you which step you are doing wrong or which step you are doing correctly. So I think it is not moving now. Sorry. So this is just to show that not only the cataract surgery, but there are several types of surgical procedures which can be done on the goat size. Like you can make a incision in the goat size, or you can do phacoemulsification procedure, or you can do a corneal perforation and pretend to repair it with a 10-0 monofilament nylon sutures. Even the squint surgeries can be practiced on the goat size because there are muscles which are present there, and even passage of things like buckle can be done on it. And all these surgeries should be a resident is expected to know all these kind of surgeries, especially chalazion or pterygium or cataract surgery or entropion surgery, which are basics which should be known to all the residents. Of course, like I said, the machines whichever are available in your institute should be completely mastered by you, and the interpretation of those which are not there with you, especially the maps, because the patient will move from one place to the other with these maps, which could be, your fluorescein angiograms, or could be your ultrasonographies, or could be your keratometry maps. So it is important to master all these. And of course, like I said, once you've done your thesis, then it is important to publish that thesis. The idea of thesis is that you inculcate the way you have to do your research, and you should devote time to your thesis, because if you're not taking research in a big way in future, at least this is going to be your beginning of the research. Again, do not hesitate to take help or assistance whenever you require this. It is important to write it well, and a well-written thesis must also be published at the earliest. So don't just do it to pass the hurdle of the exams. And this is one of my students after doing her thesis, Dr. Priyadarshini. And sometimes the students, they do it so well that you don't need you don't need to modify it at all. So this is the publication which came thereof after doing her thesis, and this just got accepted in one shot. I did not even have to go through the minor revisions. So if you really do it well, then it just shows, and it is taken by any journal. So I think it is very important to do this. Then there are didactic lectures, seminars, workshops. You have to eventually prepare for your exams, case presentations, clinical rounds, journal clubs, programs such as this, which WOS is embarked upon, which I'm sure are going to be very useful. And I was really amazed to see the level of the case presentations. The pictures which are drawn more beautiful than the photograph themselves of the various funders' pictures. It was really very heartening to see that. And of course, I think nothing to beat your own notes which you make on any topics. You have to you have to reinforce by seeing and by learning, and by making sure that everything that you read also is practically enforced, so that you remember it always. Apart from this, beyond residency, I think this is something which you will learn later on about medical ethics, about medico-legal matters, about financial skills, about stress management, about law and statutory regulations as you set up your own clinics and as you set up your own hospitals and you become a part of it. So I think this is just the beginning, and well begun is well ended. So it is very important for you to give your 200% to whatever you are doing, especially in terms of your teaching and in terms of your training. And I'm sure with lovely mentors who are there, it's just the beginning of this program. I'm sure you will all reach there, and thank you very much for your kind attention.
Thank you very much, ma'am. It was really, really an inspiring talk for all the residents. And what we have learned is to respect our patients, treat them as God, and to learn whatever you can during the residency. So I think that's a really inspiring talk for residents and also for the practicing ophthalmologists to keep learning. So now, not wasting much time, we will start with the presentations of the residents. So Okay. Okay, so now we have resident Dr. Varshika. She's JR2 GRMC Gwalior, and she'll be presenting a case on primary angle closure glaucoma. Her mentor is Dr. Abha Shukla. She's Associate Professor, Department of Ophthalmology, GRMC Gwalior. So I invite Dr. Varshika to please share her screen and start with her case presentation.
Good morning, everyone.
Please share your screen, Varshika.
Yes, ma'am. Is my screen visible?
Yeah.
Good morning, everyone. Myself, Dr. Varshika, second year junior resident in GRMC Gwalior. Today, I'll be presenting a case of primary angle closure. A patient, 60 years old female, presented with complaints of diminution of vision in both eyes since 2 years, which was insidious in onset, gradually progressive in nature, and not associated with redness, pain, watering, or discharge. Her past history, personal history, and family history were not significant. In her general examination and systemic examination were within normal limits, and there was no abnormality detected. In ophthalmic examination of right eye, visual acuity in right eye was 660, which was not improving with pinhole. And she had nuclear sclerosis grade 2 cataract in right eye. On the other hand, in left eye, her visual acuity was 6/18 with pinhole improvement and nuclear sclerosis grade 1 lenticular opacity. Rest all examination in both eyes were normal. Her intraocular pressure in both eyes was 14 millimeters and fundus was within normal limits. After this routine examination, patient was diagnosed as a case of both eye immature cataract, and she was admitted in our setup for right eye SICS with IOL implantation. On the day of surgery in the morning, when patient was dilated for the operating eye, her post-dilatation NCT was done for routine purposes. It was observed that IOP in right eye was increased. It was 42 millimeters of mercury. After this, intraocular pressure was confirmed by applanation tonometry, and it confirmed to be raised. So surgery was postponed, and IV mannitol was initiated. And after 2 hours, topical pilocarpine 2% was instilled to bring about the constriction of right eye. 4 hours later, IOP was again measured in right eye, which came out to be 20 millimeters. After this episode, we suspected patient to be a primary angle closure suspect since her intraocular pressure in right eye raised after pharmacological mydriasis. So on the next day, she was planned for glaucoma workup, and we went ahead with gonioscopy. In both eyes, her gonioscopy revealed iridotrabecular contact of more than 270 degrees with no peripheral anterior synechia. So after this examination, her visual fields were also assessed, which came out to be normal in both eyes, and her fundus examination was also normal. Only the gonioscopic findings were there. Angles had iridotrabecular contact. So we came out to a diagnosis, provisional diagnosis of right eye primary angle closure with immature cataract, since her intraocular pressure was raised in this eye after dilatation, and left eye. Diagnosis is primary angle closure suspect with immature cataract. Her differential diagnosis would be plateau iris syndrome, iridocorneal endothelial syndrome, neovascular glaucoma. On the management part, in both eyes, topical brimonidine and timolol BD was started. In right eye, laser peripheral iridotomy done, followed by phacoemulsification with lenticular extraction after a week. In right eye, topical brimonidine timolol resumed after surgery, and in left eye, prophylactic LPI was also done. By this scenario, we came to a conclusion that we should always put post-dilatation pressure check should be there in patients. Just taking patient to the OT, and non-contact tonometry has helped in this scenario because it is a very fast and quick, simple method to screen patients for high IOP, though it overestimates intraocular pressure, but it has less potential for disease transmission and there is no risk of corneal injury. On the treatment part of PACG, we have seen lenticular extraction and PCIOL implantation has found to be beneficial in cases of angle closure glaucoma. So in this case, as post-dilatation NCT before taking patient to OT, as in our case, proved very helpful to detect primary angle closure suspect, and it can help to detect hidden cases of anterior chamber angle diseases. It should be done as routine pre and post-dilatation.
Thank you, Varshika, for finishing your case well in time. Over to the judges.
Varshika, what was the part of clinical examination you really missed that you landed up in this problem?
Good morning, ma'am. Ma'am, from this case, I have learned that gonioscopy, post-dilatation pressure check, patient should be thoroughly examined in the OPD itself before admitting for cataract surgery. Post-dilatation and pre-dilatation pressure checkup.
This is not, I think, what Dr. Madhu is referring to. More importantly, you have just written the vision, 660 and 618. Did you do a refraction?
Multiple
Yes,
things
ma'am,
are
subjective test. Yes.
Varshika, from the outset, if you see multiple things, Meenakshi brought it out very clearly that did you see the type of refractive error the patient had? Did you see the anterior chamber depth? Simple thing, even a torchlight Smith method would have given you an indication that you should do gonioscopy. And gonioscopy is a must. You have gone on NCT, and more NCT, right?
Yes,
and second thing is your patient went into an attack and no PS.
Yes, ma'am. After gonioscopy, there was only a contact. There was no peripheral anterior synecdoche seen in the angle.
So when does that happen? And who are these people who go into attacks? In the angle closure, what are the causes of angle closure? I think first mechanisms you tell, then you will understand yourself. What are the mechanisms of an angle closure?
A relative pupillary block can be there.
And?
Ma'am, as in our case, pharmacological mydriasis also put patient in angle closure.
Why? Actually, you take on her simpler. I can't be more simple than this, yaar.
Okay, what is the type of refractive error would you have expected?
Ma'am, in this case, myopic.
Do you think myopes have angle closure glaucomas?
Small eye.
No, ma'am. Hypermetropic, small eye patients have angle closure.
So you are going from one end of the spectrum to the other end. Please take a patient and think about what you are going to do for a patient rather than think of the tests that you are going to do. Whenever you examine a patient, for all you know, the patient's vision may have also improved. You have not even bothered to do the refraction. Did you comment upon the disc?
Ma'am, disc was normal, ma'am. Initially, fundus examination was done before admitting patient for cataract surgery.
So don't give all these long sentences. You have
good.
only 2 minutes, please, ma'am. You have to just say whether what was the cup disc ratio.
Ma'am, it was 0.3 to 0.4, ma'am.
Was it a crowded small disc? What was the IOL power? What was you are saying ultimately the surgery was done. What was the IOL power?
Ma'am, IOL in right eye it was plus 23.5 and in left eye it was 22, ma'am.
Okay.
How did you see the disc? There was NS3 and you did not dilate. If you dilated, the pressure rose then would have risen then also, right? And how do you plan to dilate without doing a gonioscopy?
Yes, ma'am.
So do you do a gonioscopy? Actually, I want to know truly. Do you people do gonioscopy? So when do you decide to do a gonioscopy?
We do.
So when
ma'am, in OPD, yes, ma'am. In OPD, when patients come and there is a shallow anterior chamber or intraocular pressure is this patient comes with a complaint of pain, then we go for gonioscopic workup, ma'am.
What do you see on slit lamp that gives you an indication that you should do a gonioscopy?
Ma'am, time is up.
Ma'am, in Von Herrick grading is done.
Okay, learn this. This is the most important thing of the whole case.
Yes, ma'am.
Okay,
yes,
okay.
Okay, thank you, Varshika. Now we'll take the other presenter.
Dr. Giriraj. Dr. Giriraj is JR2, GRMC Gwalior, and mentor is Dr. Abha Shukla. So, Dr. Giriraj, please share your screen. Dr. Giriraj?
Good morning, ma'am.
Yes. Please share your screen.
Are you screen? Are you?
Yes, we can see.
Good morning, ma'am. My screen is visible.
Start. Yes.
Please start.
Good morning to all. Myself, Dr. Giriraj. I am presenting to a case of post-traumatic secondary open-angle glaucoma. A 17-year-old male student resident of Gwalior sustained injury by belt in right eye one day back, following which he presented with sudden diminution of vision in the right eye with pain, redness, and swelling in the same eye. His personal history, there is no history of any spectacle users for distant and near vision, and as well as no history of any systemic illness, no history of any bleeding disorder or blood transfusion recently, and no history of any previous steroid administration. Past and family history is not significant. His general systemic physical examination and systemic examination reveals no any abnormality. Come to the ophthalmic examination is right eye. Best corrected vision is 3/60, but in the left eye 6/6 part. Right eye orbital margin intact but tenderness present inferiorly, and the eyelid showing the swelling present in both upper and lower lid, and mild lower lid ecchymosis as well as small bruise present over the lower lid. Conjunctival shows the conjunctival congestion with mild subconjunctival hemorrhages present temporally and intranasally. Cornea shows the diffuse stromal edema with the Descemet's fault present. In the entry chamber, there is normal in depth, but on slit lamp examination, I found that a spot hyphema present at the 9 o'clock position, but the aqueous cells and flares cannot be assessed due to the hazy cornea, as well as pupil iris and lens. There is cannot be assessed as measured structures. The reaction to light is present sluggish only. Is the intraocular pressure measure on that day? It is 16 in the right eye and near and color vision within normal range. Fundus examination on after 2 days, the right eye showing red glow seen, but the media hazy. That's why the cornea. That's why other structure cannot be assessed, and the left eye showing a small hypermetropic disc changes. Now at that time, the clinical immediate diagnosis and management. My clinical at that time diagnosis is the right eye closed globe injury with hyphema. Then patient was hospitalized and treatment initiated with IV antibiotics and topical antibiotics, eye drops. Systemic and topical steroid started, and oral estrazolamide we started. With that treatment, after the 5 day of treatment, the patient gets improved vision up to the 6/18. Corneal edema and hyphema gets cleared off. Anterior chamber is normal in depth with the aqueous flares and cell present at 1+ grade. His right eye intraocular pressure at the 5-day treatment is 18 mmHg in the right eye. Discharge with the continuous same treatment for next 7 days and call for follow-up after the 1 week. Patient comes after 2 weeks and the positive findings are in the right eye showing best corrected visual acuity is 6/18 with pupil showing RAPT grade 2, and intraocular pressure I checked that it was shoot up to the 42 mm of Hg. That's why I'm going to the gonioscopy, but the all angle structure are visible normally. And then given treatment again steroid continue with the tapering dose for next 7 days with the topical timolol and estrazolamide to come out to reduce the intraocular pressure and come for follow-up after 1 week. Patient come after 1 week, then the positive its vision is again improved up to the 6/12, but the intraocular pressure is reduced from 42 to 24 and color vision is normal. Then I go further examination again, that showing the mild pellar disc with the normal CD ratio and other findings within normal range. Then I advise for the perimetry for the field examination and the OCT for the retinal layer evaluation if any damage or any changes occur in the field.
and a retinal layer 2 evaluation. Give the treatment again to lower the IOP for the travoprost, brimonidine, timolol, and then nebuphine continuously. My clinical diagnosis in this case, probably a secondary open angle glaucoma, but the differential diagnosis with the traumatic optic neuropathy, maybe juvenile glaucoma, maybe steroid-induced glaucoma. The clinical equipment concerned, the regular follow-up and IOP monitoring is mandatory because a small traumatic hypoma can lead to elevate the IOP, and even uncontrolled high IOP can result in ischemic optic neuropathy. As well as always look for the secondary hemorrhages because they are more severe than the primary hemorrhages. And in recent advances, in this case, maybe anterior segment OCT and ultrabiomicroscopy can be revealed in its angle structures more precisely.
Dr. Giriraj, please stop sharing your screen. Your time is up.
Thank you, ma'am.
Over to the judges. Over to the judges.
Yeah. Essentially, you are saying the patient first came. Did you do the cornea that you showed? Did you do any corneal staining on that?
Corneal staining is negative at the, on the day. Staining was negative and no any epithelial breach, but
what do you think are the causes? According to you, the initial IOP was normal. Is that so?
my initial IOP is normal 16 mm in the right eye, but comparatively to the left eye is different.
Okay. What are the causes of increase in IOP after trauma?
Ma'am, it might be due to hyphema, maybe due to any bleeding, intraocular bleeding.
Hyphema and bleeding mean the same thing?
Yes, ma'am. Maybe in iris sphincter tear maybe possible. Maybe in
see, iritis can produce, not iris or sphincter tear.
Yes, ma'am, iritis.
In these patients, does the hyphema, with the hyphema, does the IOP rise immediately or it takes some time to rise? And why does it rise? IOP rise takes some time to rise or it happens immediately? When a patient comes right after trauma, will you have very high IOP or will it rise a little afterwards? And what are the reasons of IOP rise following a closed globe injury?
Might be it rise after some time because might be angle trabecular outflow may be obstructed due to some traumatic debris in the anterior chamber.
1, 2, 3, 4 like that you tell.
Is it traumatic debris or is it something else specific? Please be more specific. What causes the obstruction of the trabecular meshwork?
Maybe mostly it is maybe inflammatory reactive cells or inflammatory macrophages. They clogged up to the outflow obstruction trabecular block.
See, structurally, something can be dialyzed, no? It can be a ciliary body dialysis.
That will lead to low IOP, so it's not that. Just think of the things which can happen. A direct injury to trabecular tissue, this thing, forget it. Now you told on the gonioscopy you saw PTM, right? Only
yes,
PTM you saw, and you didn't tell the gonioscopy of the other eye. And then on the other side you're saying disc is hyperopic, but you did not say in the left eye, you said disc is hyperopic, you did not say refraction. So gonioscopy is never in one eye when we are dealing with a patient of trauma. So what is it that you want to see?
Yes, ma'am. Ma'am, and left eye gonioscopy findings is normal, and that's why I'm not showing it.
What is the normal finding in gonioscopy from your side?
Ma'am, just pigmented TMI I can see in the left eye also. So I think it is not.
Excuse me, ma'am, time up. Time up for the questions.
Okay.
Thank you, ma'am. Thank you.
So two of our PG students were left out in the previous session. So I invite Dr. Aarti Tawar, whose mentor is Dr. Shweta Walia, to present her case.
Yes, ma'am.
You can share your screen, Aarti.
Yes, ma'am. Ma'am, is my screen visible?
Yes, but your PowerPoint is not open.
The PowerPoint should be opened. Last time also we had told you, keep the PowerPoint open.
Ma'am, is it visible now?
Your screen is visible. Your PowerPoint is not open, beta. If you are taking time, I will take the next speaker.
We'll take the next speaker. Please open your slides.
Okay,
And we had
Aarti,
already
please
presented
be ready. Please be ready. We'll take Aviral Vasudev. Aviral Vasudev, are you ready? Dr. Aviral?
Stop sharing your screen.
Yes, ma'am, I'm here.
Okay, so Dr. Aviral, please share your screen. His mentor is Dr. Pragya Prakash from SAMES Indore.
जी ma'am. Ma'am, just a minute. I'm sharing my screen.
Okay.
like इधर भी shared है उधर भी कर दिया फिर क्या दिक्कत आती है?
Aarti, please
Mute
be on
yourself,
mute.
Aarti.
Aarti, please
Yes.
mute yourself. Aviral, please make it fast.
Is my screen visible?
Yes.
Now it is.
Okay.
Make it
Now you
full.
can, yes, now you can start.
Good morning, everyone. Respected judges and my dear colleagues. Today I'll be presenting a case of a 7-year-old male who is a resident of Dhar who was brought to the same ophthalmology OPD with the chief complaint of swelling below the left lower eyelid since 3 months. As per his mother, there was history of trauma by a wooden stick at the left lower eyelid 3 months back, which subsequently developed a small swelling, which was insidious in onset and chickpea sized. It gradually increased in size, which was roughly a lemon size. The swelling was painless and non-tender. The patient was treated at Dhar with oral medications, the details of which were not available at the time, and the swelling did not subside after that. There was no history of diminution of vision in both the eyes, no history of pain and discharge from both the eyes, no history of floaters, no history of spectacles, and no history of any ocular surgery was present. The birth history was found within the normal limits, and personal history was also normal. The general physical examination of the patient was within the normal limits. On local examination, a lemon-sized solitary swelling was present below the left lower eyelid margin, approximately 2.5 by 3 centimeters. There were no visible pulsations, no erythema or skin color changes, and the overlying skin appears to be normal. On palpation, a well-defined, firm, non-fluctuant, non-reducible, non-mobile swelling was present, which was attached to the underlying tissue. The slight tenderness was present while palpating around the inferolateral orbital rim, and no pulsations were felt, and temperature of the overlying skin was also normal. On auscultation, no bruit or murmur was heard. On ocular examination, the visual acuity was 6 by 6 in both the eyes. Intraocular pressure as measured on non-contact tonometry was 14 millimeter of mercury in the right eye and 16 millimeter of the mercury in the left eye. Extraocular movements were full and gazes in both the eyes. Eyelid has a swelling of approx 2 by 3 centimeter below the left lower eyelid margin, producing a grade 1 ectropion. And the conjunctiva of the left eye has mild congestion, which was present inferolaterally, and rest of the ocular examination of both the eyes were within the normal limits. Patient was then referred to a pediatric surgery OPD for their opinion, where sonography was advised. The patient has a previous CT report, which was done at Dhar, which showed a well-defined isodense lesion of 1.4 by 1.2 centimeter at the angle of left orbit, suggesting of a sebaceous cyst. And the fresh USG, which was done at our institute, showed a heterogeneously hypoechoic solid cystic lesion with internal calcific foci with no internal vascularity on the Doppler, measuring 1.4 by 1.4 centimeters, suggesting of a dermoid cyst. So our new fresh CT face and orbit, in view of the incongruence between the history, clinical findings, and the imaging, a fresh CT was ordered. A fresh CT was then showed a 2.5 by 2.1 by 2.2 centimeter well-defined round to oval hypotenuse of tissue mass, which was inferolateral to the left orbit, appearing to be arising from the left zygomatic bone, roof and anterior wall of the left maxillary sinus with erosion of the adjacent bone, and which was causing compression of the left eyeball. No fat density or calcification was noted, and it was suggestive of eosinophilic granuloma or a sarcoma. So a provisional diagnosis was made of a left lower orbital dermoid cyst or a eosinophilic granuloma or a sarcoma. The hemogram of the patient was found within the normal limits. Parents were counseled regarding the surgical intervention, and the excisional biopsy of the mass was done under the general anesthesia. Intraoperatively, a hemorrhagic mass was noted and excised meticulously. A gel foam was inserted and drain was inserted after the hemostasis. 2 soft tissue pieces was excised and they were sent for histopathology. We were thinking of these differential diagnosis: dermoid cyst, sebaceous cyst, eosinophilic granuloma, sarcoma, or rhabdomyosarcoma. But on the basis of histology, the microscopy showed the fibrocollagenous tissue with jumbled up, dilated, thick walled blood vessels, adipose tissue, thick collagen bundles and interstitial hemorrhage, and the underlying bone also showed dilated and congested blood vessels. There was interstitial hemorrhage, adipose tissue in the section, and the thick wall of blood vessels which show dilated blood vessels. On the basis of histopathological examination, final diagnosis of bony hemangioma was made. On the evening of surgery, the patient developed gross edema and hemorrhagic soakage. Re-exploration of the wound was done, and the ophthalmic examination was found to be normal. Hemostasis was achieved and pressure bandage was applied. Patient was kept on intravenous antibiotics and supported management. Regular dressings were done, and edema gradually subsided on postoperative day 3. On postoperative day 8, there was sudden increase in the periorbital edema and the ecchymosis with conjunctival chemosis. Patient again planned for re-exploration under the anesthesia. A large hematoma was found inferior and lateral to the eye. A diffuse ooze from the periorbital tissue was present. On ocular examination, chemosis of the palpebral conjunctiva and subconjunctival hemorrhage was noted, and rest of the ocular examination was within the normal limit. Immediately after the evacuation of the hematoma, the hemostasis was achieved with the compression and the bipolar diathermy. Bone wax and Surgicel was applied. Wound was closed in layer over the suction drain with Vicryl and the nylon suture. The patient was kept on regular dressings and edema gradually decreased. And one packed cell volume was transfused in the post-operative period. The ocular examination of the left.
Aviral, please stop sharing your screen. Time is up. Okay. So now over to the judges.
Thank you. Aviral, a nice case presentation. I have just few pointers here for you. I think nicely depicted the whole story. Why do you think you had a differential of dermoid and sebaceous cyst as your first two differential diagnoses? And why do you think you thought of sarcoma and rhabdomyosarcoma as your third and fourth diagnosis? Let's just think about the differentials here. Otherwise, the presentation was fine.
Ma'am, initially when the patient presented to our OPD, on the clinical examination, the consistency of the swelling was that of the dermoid cyst, while the location was not that common at the inferonasal side because the dermoid cysts are usually superotemporal.
Sorry to interrupt. You had a CT scan done. After the CT scan, you have given us a differential diagnosis of 4, which is dermoid, sebaceous cyst.
Yes, ma'am. On the basis of previous CT scans which the patient had
So
before.
your CT scan was done, a repeat CT scan was done. There are 4 different diagnoses. See, why am I coming to this point is again the importance of not jumping at the specifics, because orbit is a Pandora box, and unless you have a histopathology or it is a very straightforward diagnosis, you don't know what you're dealing with. Now, you have some pointers here to tell you what it could have been. So can you just kind of look at your case in totality and tell me what it could be and what it could not be?
Ma'am, it could have been a dermoid cyst, but there was no suggestive evidence of rhabdomyosarcoma or a eosinophilic granuloma.
Eosinophilic granuloma is a diagnosis of histopathology.
Yes, ma'am.
Does it cause so much of erosion of the zygomatic bone? Is that the location, and does it cause so much of erosion of zygomatic bone?
No, ma'am, it doesn't cause so much erosion of the zygomatic bone as
That's
compared to a rhabdomyosarcoma.
Yeah, is that a very classical area where the rhabdomyosarcoma, and is that the age of a patient where rhabdomyosarcoma could be commonly present?
No, ma'am, that the age group was different as commonly seen in cases of rhabdomyosarcoma.
Exactly. Now, you have had a patient with history of trauma. The trauma led to a swelling. It could be coincidental, I agree. And if you go back and look at your sonography and the imaging which has been done, the other question I have is, if there is a trauma, was the imaging done with contrast or without contrast?
No, ma'am, the imaging was done only without the contrast. We advised the patient for MRI with contrast, but the patient was not that much affording. So we were not able to get an MRI with contrast.
When do you advise a CT? When do you advise an MRI in a patient like this?
Sorry, ma'am? I couldn't
What
hear.
is your criteria of advising CT scan versus MRI in such patients?
Ma'am, we were trying to look for if the swelling is invading any nerve or because.
Which do you think would be present in this area which can cause this kind of
trauma? What is the best option, CT or MRI? Simple question for the exam: in trauma, CT or the RI? MRI.
CT.
What are the preferred?
CT scan is preferred.
Time is up. Time is up.
Okay. Not enough time to discuss the case, but that's okay.
Yes. So I think Aarti, you're ready?
Yes, ma'am.
Okay, so we'll take Aarti Tawar. She's going to present her case. Aarti, you can start.
Good morning, ma'am. Today I am presenting a case of a 60-year-old female presented to our OPD with a chief complaint of facial pain followed by protrusion of
Can't hear
30
you.
years. Patient was apparently already.
If you are having problems with your connectivity, you can stop the sharing and speak.
Later, she had painful eye movement. She also noticed gradual progressive diminution of vision in the same eye. History of mild.
Continue, please.
Switch off your video, only keep audio on. Keep the presentation and audio and switch off your video.
Yes, ma'am.
Go on to the video of Zoom, off it,
Yes,
and then share screen. Yeah, now share screen.
Yeah, now speak.
She also noticed gradual progressive diminution of vision in the same eye and history of mild headache on and off with recurrent nasal congestion and itching in nose. History of right eye painless progressive diminution of vision floater since 1 year. On leading question, patient was not aware of any diplopia or nose bleeding during the course, and the rest of the history was negative for thyroid eye disease or malignancy. The patient was known diabetic since 2 years, for which she was taking oral hypoglycemic agents. Personal history and family history were unremarkable. Patient was alert, conscious, cooperative, well-oriented to timepiece in person, and Pilar was present. Rest of the examination was normal. Vision in the right eye was 660 and improving to with pinhole to 636. On refraction with minus 2.5 sphere, my patient improved to 636. And in the left eye, the vision was counting finger close to face and projection of rays inaccurate and inferior and temporal quadrant, not improving with glasses. Position of head was normal, facial asymmetry was absent, orbital margins in both the eye were intact, eyebrow of left eye was higher than the right eye and the contour was S-shaped. Eye position of the left eye was in down and out position, abaxial proptosis was there. Upper lid of both the eyes were covering 2 mm of superior cornea, lower lid in both the eyes were just touching the limbus. Palpebral fissure height were same in both the eyes and scleral show was absent. Worm's eye view and axigus view were then done to confirm the abaxial proptosis. Inspection, eyeball was down and out, fullness in the inferior orbital aspect was there, finger insinuation was possible along superior and medial orbital rim, no attachment were felt, temperature was normal and deep tenderness were present, pulsations were absent, changes in size on bending and valsalva was absent and resistance to retropulsion was present, skin changes were absent, surface was smooth, acraminal gland were not palpable, lymph nodes were not palpable and neck swelling were not seen or felt. On auscultation, there were no bruit heard. Then corneal reflex was centered in the left eye in the nasal limbus and horizontal distance of medial canthus from root of nose was increased in the left eye. Vertical displacement was also found in the left eye, inferiorly 10 mm. Anteroposterior displacement was also increased in the left eye, and on comparison with Lutz exophthalmometer, the left eye was found to be 20 mm proptosed. Movements were then checked and found to be restricted in the left eye and were further confirmed on force reduction test, which was found to be positive. Right eye examination shows grade 2 nasal pterygium progressive covering 3 mm of cornea, and lens had a nuclear sclerosis grade 2 to 3 with posterior subcapsular cataract. Pupil was 4 mm in size in the right eye and the central circular reacting to light. Direct reflex was present and consensual was absent. In the left eye, mild superficial diffuse congestion of conjunctiva was present. Nasal pterygium grade 2 was also there. There were no signs of thyroid eye disease. Cornea was clear and sensations were intact. And the pupil was 4 mm in size, central circular with RABT grade 2. Direct reflex was absent and consensual was present. Lens had a nuclear sclerosis and with grade 2 to 3 and with posterior subcapsular cataract. Intraocular pressure measured by Goldman application was 12 mm Hg. Fundus of right eye had asteroid hyalosis and medullated nerve fibers. Rest of the fundus was normal. And in the left eye, fundus had a pale disc of 1.8 mm size and NRR was also pale. Castelbaum index was 4. No spontaneous venous pulsations were seen at the disc and there were no signs of diabetic retinopathy. So on the basis of my examination, my differential diagnoses are sinus tumor, thyroid eye disease, lacrimal gland tumor, secondary nasopharyngeal carcinoma, and choriostoma. And my examination favors the sinus tumor because there was a nasal block with sinus pain preceding the bulging, and proptosis was down and out, suggestive of frontal and ethmoid sinus tumor or mucocele. We ordered some blood investigations, which were all normal except the blood sugar, which was deranged, and HbA1c, which was 9.4%. MRI brain, paranasal sinus, and orbit post contrast showed a large lobulated expansile lesion involving the left ethmoid.
Aarti, please turn off your screen. The time is up.
Yes, ma'am.
Okay, so the judges,
Dr. Chubra again.
all oculoplasty today.
Aarti, first of all, I want to just give you one tip when you're presenting. This case was like all over with too many texts, too much of material, and it is very difficult to keep up with the pace of what you're actually presenting. So that's one thing which I can tell you. We'll not go to the diagnosis, but because you couldn't present it completely. But yeah, it does look like a nasoorbital mass. It could be anything, nasoorbital mass. And I don't know why in differentials, all of you, in fact, since morning, what you're saying, why are you adding all the diagnoses which are so uncommon and not to be discussed at all? The differential diagnosis has to be the categories of diseases which could cause them. It could be infectious, inflammatory, malignant, and based on the location, it could be 1, 2, 3, right? So in this case, for example, is it infectious? Is it malignant? It is inflammatory. And if it is malignant, you're thinking of it is infectious. What could be the first 3 common diagnoses, differential diagnosis for a sinoorbital disease? Because you're saying the sinus was involved, facial pain was there, then there is a dystopia which is happening. So of course there is something happening from sinus and going to the orbit, right? So whenever all of you are presenting, especially about the oculoplasty, I can talk about is do a very crisp and very clear examination. You don't have to narrate the story because you don't have so much of time when you're presenting in the cases. Examiner is not interested in knowing the things which are normal. Examiner is interested in knowing what are the pointers which you've got in the case, right? And when you're doing the differential, it has to correlate with your case history, and you have to come. For example, if you're talking about proptosis, is it axial? It is non-axial, painful, non-painful. It is, is there any associated facial abnormality? Then based on that, you describe whether it is infectious, infective, neoplastic, traumatic, whatever. In fact, that orbital apex case also, which was presented, the thing which we're looking for was, is it infectious, is it inflammatory, or is it malignant? Now in that, there would be differentials, because unless you do biopsy in these cases, you can never say, unless it's a classical case of cavernous hemangioma or anything which is very classical, you should never utter a word saying that this is what is what, right? So I think in general, what I noticed with the plastic cases is, for all of you who has presented and in general, is please make it very crisp, very short and sweet with specific findings which are there, and the differentials have to be very logically narrated. Because lacrimal gland tumor in this case, and I don't know what all was mentioned, it doesn't make any sense, because lacrimal gland will not cause the dystopia to go down and out. It will cause the orbit to come down and in, right? Or it will push the globe outside, and then you will have different kinds of symptoms presenting in that case. By the way, what was the final diagnosis in this patient?
Ma'am, my final diagnosis in this patient was mucocele of the frontal and ethmoid sinus.
Exactly. So it was a very simple case of a mucocele, which was a sinoethmoidal mucocele, invading the orbit. So it's a very, very.
Ma'am, time is up. Time is up.
I just wanted to say that. Thank you.
Just let her finish the sentence.
Yeah, ma'am. Please continue.
No, that's fine. It's just what I want to say is that don't make the cases so complicated. It is very easy to present. I wish somebody had presented a ptosis also where, see, for example, in the Epic syndrome, myasthenia was being discussed. So you are digging your own grave by taking the examiner to the diagnosis, which is not so important. That's all. Thank you.
All right. So thank you, everyone. And yes, we have another very, very special guest with us, Dr. Rohit Shetty. Second.
Should I start speaking or should
Sir, I would just like to introduce, though you don't need any introduction, but I would just like to, say a few words in your honor. Uh, so everyone is very well aware and he is a very well known figure in ophthalmology. So Dr. Rohit Shetty is a consultant cornea and refractive surgery and vice chairman Narayan Netralaya, Bangalore, and clinical and translational scientist, Grow Laboratories, and faculty department of ophthalmology, Maastricht University. So he is a cornea refractive surgeon and a clinical scientist with a keen interest in keratoconus and corneal ectatic disorders, and has been practicing high volume refractive surgery since 14 years now. And he has completed his residency in St. John's Medical College and has done his DNB there. And later on, he did his FRCS from Glasgow, Scotland, United Kingdom, and he is currently an FRCS examiner. He has around 200 publications in peer-reviewed journals and is a reviewer for many index journals in this specialty. And he is also on the editorial board of Journal of Refractive Surgeries. He has a keen interest in imaging, and some of his research work include wavefront analysis, influence of ocular surface spherical aberrations. And in 2015, in annual conference of All India Ophthalmological Society, he has won the prestigious Colonel Rangachari Award for his best paper in Is Inflammation Driving Keratoconus, a holistic study of molecular pathways. And he was awarded the Case Bear Award for outstanding contribution to refractive surgeries. So I invite Dr. Rohit Shetty to present his enlightening talk on not an ophthalmic topic, but an inspiring topic on power of belief. So I invite you, sir.
Thank you, the WOS team from Madhya Pradesh, and Dr. Madhu, Dr. Mohita Sharma for inviting me, and the entire team who has made this program so beautifully structured. For the last 45 minutes, I've been logged in here, and I think that the concept of giving the residents the right way of doing things is very important. I mean, this is probably one of the worst affected years for any resident. You know, your teaching has been affected, your surgical training has been affected. Everything has been affected for the last 3 years, and some of us are aware because, you know, a lot of them coming out are struggling through many basic things. But I believe that there is no shortcuts for trying to learn, because in your life, after 10 years, you can't say that I did not do well as an ophthalmologist because the 2 years I was doing COVID duty. Because in 10 years, we may have something new, and this COVID will be a forgotten thing, like how we've forgotten plague and smallpox. During smallpox, everything got affected, but we don't, now nobody gives any sympathy saying that you were not able to do something because you were in that epidemic time. So my young friends, it's very important for all of you is to stop using COVID as a reason for not improvising yourself. And that's, I think, where the WOS team has taken a real big lead in trying to reach out to you. The second thing is, my talk today, I don't have a PowerPoint. I have 6 minutes talk, and I'm going to just go speak from the heart. And my talk today is about power of believing. The first power of believing is today is that you can be a better ophthalmologist in spite of this COVID nuisance. Don't use this as an excuse for not trying to do better, irrespective of where you're placed. You can go meet, greet, connect yourself to social media, to any ophthalmologist across this country today, and start learning from them. This is the time you use your disadvantage to advantage. Use your social media to connect. And I keep telling this to my residents and fellows, that connect to every single known ophthalmologist seniors through social media, whoever is active. Somebody is watching you. Somebody is looking at what you are doing. They're also watching you if you put up some irresponsible posts. They're watching you if you're putting something which is insensitive posts. So use social media to your own advantage. That's the power of believing. When we speak from this platform here, sometimes it just looks like an empty rhetoric because we are speaking to all of you as a postgraduates, and you all think, no, it's just a philosophical talk. And I used to feel the same when somebody used to come to my college as a postgraduate or an intern, and somebody would speak about this. I said, nothing like this happens. These are all philosophical terms. But when you're pushed to the wall and you're nothing else but to believe, then you start realizing that a lot of things can change. I always use this line. Faith is a house with many rooms. So faith is not one room concept. If one fails, something will open up. From the time I was a postgraduate to time where I am today, everything has worked with faith and belief. So in power of believing, the second point which I want to say is first is to stop using something which is not good in your life as a badge of honor. COVID is a badge of honor because I'm not doing well. My personal life is a badge of honor, I'm not doing well. I think it has to stop using that as a badge of honor and use something positive as a badge of honor. The second one is you have to mingle with people who are different than you. Like in this own group, we have Dr. Madhu. She comes from an army background. Dr. Moita, who set up something completely out of nowhere. There are so many people like them. They may be tough or they may be different. They may not speak the same language as you are. But their language is what has made it successful in their own small field. See, among youngsters, the real reason we fail is that we don't want to talk to people who are a little different. It starts from your MBBS. Somebody who's a little different, you call him nerd, you call him odd, you call him useless. I'm not talking about your toppers. I'm not talking about gold medalists. I'm talking about those who think a little differently. Somebody in my MBBS said that, I'm not going to practice MBBS. I want to be an IAS officer. So we found him really odd. He said, why did you become a doctor? And today, he's some undersecretary or something of one of the states, one of, I think, South India, some Tamil Nadu or wherever. See, at that point of time, we found him odd, but he was not odd. He just had a better power of belief than all of us. And somebody said that I want to do microbiology when he was third year, and nobody wanted to do microbiology. Everybody wants to be a surgeon. Everybody wants to have that glamorous thing. But he heads one of the biggest centers in Singapore. So vaccines are created like this. Scientists are created like this. So this is like my third point, is mingle with people who speak different language, and they are the ones who help you to make you believe. The fourth point is power of belief is every small thing sometimes triggers a huge influence on you. Even a small writing on somebody's wall. That's how brain works. So I had been to 18 years back. I'd been to Dr. Devashetty's room, and there was a small board, very small board, just behind him. The board said, if I remember the words right, never doubt that a small group of people can change this world. And there was a dot, and that inverted comma after that. In fact, is the only thing which has changed the world. Whether it's your WOS societies or your Elon Musk or anybody in this world today, it's that odd person who felt that I have faith and the faith has many rooms. He's the one who has changed this world. And it's very important that you start believing. So what the last point I'm going to say is, you feel that you are in a very, very doubtful situation of your career. Make this as your advantage, because everybody's in the same boat. There were times education in India is not uniform. Some places offer 500 cases and they come out very good. Some places offer no cases and them come out very bad. And this is the only time that 90% of the colleges are in the same place. So this is a great time for you to shine and start searching out for, looking out for what opportunities do you have. The last point is your future is not an extension of your past. Today, all of you are extremely skilled. Reason is that we start using both our hands now for computers typing. So we become ambidextrous. Ophthalmology is about how good is your non-dominant and non-dominant hand. So I believe that in 25 years from today, you don't have to teach anybody phaco. Within 10 cases, they'll learn phaco because their non-dominant hand becomes extremely strong, which is not the case many years back when you had to make an effort. That's evolution. So if I sum up my talk today, it's about faith. It's about meeting people, trying to connect. For example, if one of you, a lot of you in this group, youngsters, if you're connected to Namrata ma'am's post, and tomorrow you write something which you've done great in your clinic, if she gets to know, she knows that the work you have done needs to be highlighted in the society. If no, Dr. Mohita ma'am goes to know, she needs to know.
Excuse me, sir. Very sorry to interrupt. Please, can you please sum up fast?
Basically, this is what I want to say is power of believing is all about faith. If you have faith and your faith and vision is all you need to do. I did not speak from a pure rhetoric point of view. I just spoke from the heart. Thank you.
Rohit, I want to really profoundly thank you for this, for bringing this forward, because unless until you are challenged to the extreme, the best in you never comes out. And best in you, what you've really brought along, unless until you believe in yourself, nothing will ever come out. So I think you've just hit the nail. And this is, I think, is the best talk the kids should take home, better than cases. Thank you, Rohit.
Thank you, ma'am.
Thank you very much, sir. It was really an enlightening talk for all of us. Now, we'll move ahead with the next speakers. Dr. Ashul Chawla is JR3 NSCB Jabalpur. His mentor is Dr. Navneet Saxena, Professor and Head of Ophthalmology NSCB Jabalpur and ex-Dean NSCB Medical College Jabalpur. So I invite Dr. Ashul Chawla to come and share his case with us. Ashul, share your screen.
Yes, ma'am. Thank you, ma'am. Should I start, ma'am?
Yes, switch off your video. It would be better. Switch off your video.
Yeah, yes.
And then present your screen.
Please start.
Good morning, respected panelists and respected ma'ams and sirs. Today, I've been given an opportunity for this case presentation of a 63-year-old male patient resident from Panna. Occupation he's a farmer by occupation, who presented to our OPD with chief complaints of diminution of vision in both eyes since 5 years and pain and redness, which was on and off since 5 years. As per the patient, he was apparently all right 5 years back when he developed gradual progressive diminution of vision in both eyes, and diminution of vision was associated with intermittent episodic pain, which was sudden in onset, stabbing in nature, not relieving on medications, and lasting for a few hours before relieving by itself. As per the patient, pain was also associated with redness. Patient had similar complaints in right eye but was relieved after surgery. There is history of spectacle use. There is no history of ocular trauma or no history of pain on eye movement and no history of floaters. In past history, there is a history of left eye laser PI in 2017 and right eye laser PI in 2019, and there is history of right eye trabeculectomy 1 month back. There is no history of any chronic medical illness. In drug history, patient is using eye drop Timolol and eye drop Travoprost since 5 years. Family history and personal history were within normal limits, and general examination and systemic examination were also within normal limits. Moving on to the ocular examination of the right eye, vision was 618 and pinhole was 612, and the positive findings are as follows. On retinoscopy, patient was known to be hypermetropic with plus 2.5 DS, and a near addition was also given. He was also presbyopic. In conjunctiva, a diffuse filtering avascular type 2 bleb was present between 11 to 1 o'clock hours superiorly. Anterior chamber was shallow with von Herrick's grade 2, and a surgical PI at 12 o'clock position was noted. A laser PI was noted at 11 o'clock, which was seen on rectal illumination. Lens was NS grade 2 and tension was within normal limit. Now, relevant tests in chronological sequences that was performed were first gonioscopy, which showed narrow angle in 2 quadrants, which on indentation revealed that presence of peripheral anterior synechiae. And perimetry showed glaucomatous changes according to Anderson-Hodab classification. Fundus of the right eye, media was hazy due to NS2, and optic disc showed 0.6 cupping with inferior notching and Lavina dot sign. Now moving on to the examination of the left eye, the vision was no PL, and the positive findings were mild corneal edema with shallow anterior chamber, von Riggs grade 1. There was laser PI at 11 o'clock and pupil were mid dilated, not reacting to light, size 4 mm. Tension was raised and was 32 mm Hg at 12 p.m. using applanation tonometry. The relevant tests were performed. Gonioscopy revealed grade 1 angle according to Sheffer's system in 3 quadrants, which on indentation revealed presence of pars. Perimetry could not be performed. And fundus in left eye, the media was hazy due to NS2 and there was presence of asteroid hyalosis. Optic disc showed 0.8 to 0.9 cupping with nasalization of vessels, with lamina dot sign, with bayoneting of vessels and bearing of circumciliary vessels. Retinal blood vessels were attenuated. All the routine panels were within normal limits. Now, my final diagnosis is right eye post-operative case of trabeculectomy with functional filtering type 2 bleb with primary angle closure glaucoma with glaucomatous optic neuropathy with NS grade 2 with simple hypermetropia with presbyopia, and left eye absolute glaucoma with glaucomatous optic atrophy with NS grade 2. Now moving on to the management, right eye patient was advised 6 monthly follow-up with optic disc visual field and IOP monitoring, and in left eye IOP was controlled using a combination of anti-glaucoma drugs, and if further not controlled, then various procedures like glaucoma drainage devices, Ahmed valve implantation, retrovalvular alcohol injection, or destructive procedures like DLCP enucleation can be adopted. Now a 63-year-old male patient, hypermetropic, presented with a history of both eye laser PI, came with chief complaints of episodic pain, redness, and diminution of vision in both eyes since 5 years. Both eye gonioscopy was done, which gave narrow angles with pars in more than 180-degree angles, and positive findings in perimetry and optic disc. A diagnosis of right eye primary angle closure glaucoma with left eye absolute glaucoma was made. As IOP was not controlled on topical medications, a trabeculectomy surgery was performed in right eye to halt the further progression, whereas a combination of 2 topical anti-glaucoma drugs were prescribed, and the patient in the currently asymptomatic end stage left eye with a close follow-up. Thank you.
Thank you, Ashul, for presenting well in time and finishing well in time. So over to the judges now.
Ashu, you said pain. You said random pain. Are there anything specific about this kind of pain? Any variations? Are there any other symptoms that you should have talked about?
Ma'am, I have described the pain as per the patient's advice. The patient said the pain was stabbing in nature. It was dull and it was not relieving on medication, and it relieved by itself after a few hours. And this was episodic and generally.
At what time of the day was important? Other prodromal symptoms were positive, and one thing you said in the end that you destroyed everything. In angle closure, you were advised a GDD. You know what? You did everything perfectly fine. But like Hitiwicket, in an angle closure, GDD is contraindicated. In a blind eye, why will you do a GDD, man? Why will you spend so much of money, and why will you do something that will take him to malignant glaucoma, right? Komshila, you're this thing. She's not asked anything. So, sorry, Devi, you ask him.
Yeah, I wanted to know what is the kind of gonioscopy that you did for this patient. Do you do an indentation gonioscope when you have a filtering bleb, functional filtering bleb?
Yes, ma'am. Ma'am, I used a size 4 mirror lens for indentation and gonioscopy. Indirect gonioscopy was done.
Anshul, why do you do gonioscopy in a trap case? What do you want to look for?
Ma'am, I wanted to confirm the outside diagnosed angle closure. Trabeculectomy was done in our institute. So, ma'am, I wanted to confirm before the trabeculectomy that the diagnosis and the laser PI that was done in the outside by the outside practitioners was true or not.
Okay, so this was before. So this was
Yes,
before the trap.
Yeah, ma'am. Yes, ma'am.
Okay. So what do you think would have been done better? Because since it's not controlled with just a trap, so what do you think would have been the ideal
Ma'am,
line
I'm
of
sorry,
management?
ma'am. The patient when came to our institute had only laser PI with it, and
That's fine. So now retrospectively we understand that the pressures are not controlled. So would you have liked to modify your line of management in your right eye?
I'm sorry, ma'am.
What she's asking is, what could you have done instead of what has been done?
Yeah, retrospectively, would you have wanted to do something else for the right eye?
Would you like to change what you have done?
Ma'am, the right eye when the laser. Yes, ma'am. Ma'am, the outside practitioner who would have looked for did absolutely.
No, what would you have done? You have done a trap.
We did laser.
No, just a minute.
Don't
You have
talk
done
about the outside practitioner. Talk about what you can do.
So you have done a trap, and after trap, you're finding that the pressures are still uncontrolled. You still want to add anti-glaucoma drugs. So now, retrospectively, would you have wanted to go back and done something else than just a trap?
Ma'am, after the trap, the pressure is under control as of now. Had it not been controlled,
So are you using anti-glaucoma drugs in that eye?
No, ma'am.
Okay.
In that trap eye, we are not using. Had it not been controlled, ma'am, we could have gone for revising the trap. Otherwise, we could have gone for cycloablative procedures in case of a trap failure.
You have a cataract there, right?
Yes, ma'am. We can go for early cataract extraction also, ma'am.
Yeah.
Early lens extraction. Yes, ma'am.
Please make the presentation clearer. You are mixing up and events like what came from outside and who did what outside is not important. When you are examining what are the findings, what makes you think and what you want to do is important. We'll go on to the next case. Thank you so much.
Yes.
Thank you, ma'am.
Okay, so the next case is by Dr. Ritika Tripathi. She's also from NSCB Jabalpur, and her mentor is Dr. Navneet Saxena. So Ritika, please share your screen.
Yes, ma'am. Ma'am, should I start?
Please start.
Yes, start please.
Good morning, everyone. My patient Suman Kori, 46-year-old female, a housewife, resident of Panagarh district, Jabalpur, presented to the ophthalmology OPD of NSCB Medical College on 7th of this month with chief complaints of left eye foreign body sensation and redness since 25 days, followed by loss of vision and pain since 23 days. As for the patient herself, she was apparently all right almost 25 days back when she developed foreign body sensation and redness in left eye, which was sudden, progressive, and not improving. She instilled some unknown drop via some local practitioner, after which she started having complaints of loss of vision and pain. Loss of vision was gradual, progressive, and started after usage of drop and was associated with pain and watering. Pain was severe, continuous, dull aching in nature, and partially relieved on medication associated with watering and photophobia. She also complains of whitish discoloration in eye, which was initially small but has increased to the present size. No history of trauma, any foreign body entry in the eye, or any eye procedure or fever. Past history: after non-relief with initial treatment, she visited our OPD 18 days back when she refused admission and took medication at home, but her symptoms did not relieve. She is known case of diabetes mellitus and hypertension since 4 months on medication. No other chronic history. Treatment history: patient was previously on tablet amoxiclav, ranitidine, tacameral, ibuprofen. Locally, she instilled eye drop gatifloxacin, eye drop natamycin, eye drop atropine, and eye drop timolol. Personal history, family history, and general examination were found to be within normal limits. Ocular examination: The right eye of the patient was grossly normal. The findings of the left eye were the visual acuity of the left eye was PL present. PR was present in all the 4 quadrants. Position of head, face, and brow, eyeball, and extraocular movements were normal. There was mild upper lid and lower lid swelling, palpable height of 8 mm. The movements were normal. There was discharge present in the margins. The lashes were matted with discharge, and there was myomitis of +1. The lacrimal apparatus of left eye was normal with syringing patent. Conjunctiva, bulbar conjunctiva had circumciliary congestion with palpable and pharyngeal conjunctiva congested. Now the cornea. Size and shape was normal, while the surface showed central corneal ulcer of size 6 into 6 mm with distinct margins, stain positive, with stromal infiltration of size 8 into 8 mm centrally, 2 mm from limbus at all clock hours. The curvature was flat centrally. The transparency was opaque. The sensation were decreased, especially centrally. There was superficial vascularization present at 360 degree along the limbus of 1 mm. The anterior chamber showed hypopyon of size 1 mm and the transparency was opaque. Rest of the details were not appreciated due to the infiltration and the ulcer present. The DT was raised for the left eye, while for right eye it was normal. This is the corneal diagram and clinical picture of the patient. The fundus of the right eye was normal, while left eye could not be appreciated due to no glow. My differential diagnoses are bacterial corneal ulcer with first one. Second is hypopyon corneal ulcer. Third is fungal corneal ulcer. Now the investigation advice were local and the systemic investigations. The systemic investigations were within normal limit. The RBS was 104, HB1AC was 6.4%, which was mildly raised, and CBC was within normal limit. The local investigation showed B scan was normal. The gram stain showed gram-positive bacilli with occasional pus cells. Gram stain KOH was negative, and the cultures showed no growth. My final diagnosis is non-healing central bacterial corneal ulcer with hypopyon. 46-year-old diabetic and hypertensive female presented with complaints of foreign body sensation, redness, pain, and diminution of vision since 25 days, and had history of installation of some unknown drops. On examination of left eye, lids were matted with discharge. Circumciliary congestion was present. There was a central corneal ulcer of size 6 into 6 mm with deep stromal infiltration and superficial vascularization with 1 mm hypopyon. Rest details were not appreciated. DT was raised. Provisional license of bacterial corneal ulcer was made. The ulcer's base and edges were scraped and sent for microbiological investigation, which showed gram-positive bacilli, confirming the diagnosis. The patient was started on 45 antibiotic drops and cycloplegic and considered for paracentesis, and was waitlisted for therapeutic penetrating keratoplasty as the final line of management. Thank you.
Thank you, Dr. Ritika. She finished well in time, and now over to the judges.
Ritika, 25 days bacterial ulcer, right?
Yes, ma'am. Yes, ma'am.
Just think of it in your mind. 25 days of bacterial ulcer. Hypopyon is not straight, it is along the margin of the cornea, right?
Yes, ma'am. Margin. Yes, ma'am. Margin
Yes,
along.
it is not hypopyon. Hypopyon in a bacterial ulcer will not be like around the margin of the cornea. It will be a straight and shifting hypopyon. The points which are not going in favor, I'm just telling you. Can you think of anything when you will see on the gram stain what you are seeing, those dots, positive dots?
Yes, ma'am. Ma'am, for gram.
Diabetic. Patient is a diabetic. There's a long history. It has not perforated.
No, no, ma'am.
If it is bacterial gram-positive cocci, the ulcer would have perforated in 25 days. It's a bacterial ulcer. Which gram-positive cocci will give rise to a bacterial corneal ulcer?
Ma'am, gram-positive cocci would be, ma'am, then pneumococcus can be there, and pseudomonas.
Pneumococcus will be gram-positive cocci normal. You did not say gram-positive cocci. Pneumo will be what kind of a cocci? You will give an exact shape.
Ma'am, yes, ma'am, it should be, ma'am, diplo. It will be diplococci dots. Ma'am, colony would be there for pneumococcus.
That is diplococci. Pneumococcal will last for 25 days, just like that. Think there's something ringing. Your patient is diabetic.
Ma'am, fungal. Can we just
if it's fungal, which fungal? You're going on the right line, but which fungal? patient is diabetic.
Ma'am, Candida will be the most common affected for diabetes mellitus patient.
Candida will be the most common. You're right about that. So think more in, because you have given 45 eye drops. What all did you give in 45 eye drops?
Ma'am, as the culture showed gram positive, ma'am, we started the patient on fortified cefazolin and ma'am vancomycin, fortified vancomycin.
So do you think the vanco and pneumococcal will not respond?
Ma'am, the patient, ma'am, but it was, ma'am, the patient had already used ma'am natamycin also. She was already taking natamycin since 20 days, but the ulcer did not improve, or even the symptoms did not improve for the patients.
Is natamycin drug of choice for Candida?
No, ma'am, amphotericin.
Then, before taking for therapeutic, we must exhaust the options which are medical options, right?
Yes, ma'am.
We need a little more investigations here. As per nobody can say really exactly with authority, but the things that we should keep in mind are these what I've talked to you about.
I think a refractory case, you should revise your treatment. Did you do a scraping? Or
Yes, ma'am.
She did.
Yes, ma'am. Yes,
And the culture? And the culture?
Culture showed no growth. Yes, ma'am, culture showed no growth.
Maybe she's overlapping the treatment and not being consistent with one particular like antibacterial.
So if it is bacterial, it should have shown up in the growth.
Yes, ma'am, it should have, but ma'am, the initial report.
Ma'am, time is up.
Okay, for a fungal ulcer, how long should you take for and which medium you should take? This is a take-home message for you. For fungal, you suspect fungal, which culture medium, and for how long should you wait?
Ma'am, at least when we should, ma'am, we should calcofluor white staining.
Culture medium.
Time is up.
Culture. Go home and see. Time is up.
Yes, ma'am.
Go home and see it, right?
4 to 4 weeks. Yes, ma'am. Thank you.
Thank you. Ritika, please stop sharing your screen.
Yes.
So thank you, WOS, for giving me this opportunity to participate in such a enlightening and informative webinar. So now I give over to Dr. Vinita Ramnani from Bhopal. She's going to conduct the next session.
Thank you, boss. We will go for next presentation from MP, and I am very happy to see all the PG students doing justice to their cases and learning. Thank you, Mohita ma'am and Madhu ma'am, for the opportunity. We will begin with the first lecture by Dr. Divya Trivedi. She is a research fellow in phaco and refractive surgery at Narayan Nethralaya, and she has passed out as MBBS from KMC Mangalore and PG from KMC Manipal. And she has done 1 year fellowship, and in this 1 year, though it's a COVID time, she got a wonderful presentation and prizes. And she is an international hero award awardee of AIOS 2021, and she will be presenting my journey as a clinical scientist. Dr. Divya, are you ready?
Yes, ma'am. Thank you, ma'am. Can I share my screen?
Yeah.
Is it visible, ma'am?
Yes, you can go ahead, Divya.
So good afternoon, everyone. A very happy new year to all of you. I'm Dr. Divya Trivedi. I'm a fellow at Narayan Nethralaya, Bangalore. At the outset, I'd like to thank Women Ophthalmologists Society for the opportunity to present our work at this platform. And I'd like to thank my mentor, Dr. Rohit Shetty, sir, for charting the course of this amazing journey that I'm going to share with all of you today. The journey began towards the end of my MS. After a fruitful 3 years of the postgraduate course, reading all these books and studying precious handwritten notes that are passed down one batch of postgraduates to the next, I was awarded my postgraduate degree. Having crossed that milestone, the question arose, what next? What are the options for an ophthalmology postgraduate in India? Either you become a clinician running an OPD and performing surgeries, or you become a researcher, innovating and publishing your work. And while I was trying to make a decision here, India went into a complete lockdown. There weren't as many opportunities for a freshly baked ophthalmologist. Another thing I realized during this period was I wasn't the only one. There were hundreds of young ophthalmologists out there with whom I had to compete. Taking you back, my question was, is there a way to do both? Every resident is part researcher and part clinician, but not everyone manages to strike a balance between the two. The quest for this balance took me to Narayan Nethralaya, Bangalore. This was a place that showed me and taught me to grow as a clinician, a researcher, and a surgeon, all three simultaneously. I opted for a fellowship in refractive services and phacoemulsification. It was the very first time in my life that I had seen a refractive surgery being done, and very soon I was the one sitting in that chair doing the surgery myself. I learned phacoemulsification here, making the journey from the wet lab to the simulator to the OT. And along the way, I had the opportunity to learn from many well-known experts in the field. Coming to the research aspect of my training, NN works in close tandem with GROW Lab. GROW stands for Genes, Repair and Regeneration at the Ophthalmic Workstation. The lab comprises a team of imaging scientists, microbiologists, immunologists, and an entire crew of innovators and thinkers who work together at the frontiers of science. It's an exciting place bubbling with innovations and discoveries. The collaboration between NN and GROW Lab helps in the translation of scientific findings to cutting-edge clinical work. Working with such a diverse group of people enabled me to develop a more nuanced understanding of ophthalmology. And today I'll take you through some of the fascinating work done by NN and the GROW Lab. The BioPathfinder. Putting it very simply, it's a point-of-care diagnostic kit that studies biomarkers in tears. Normally, to do a basic tear fluid analysis, you need an elaborate setup and well-trained staff. In an attempt to simplify this process, an immune assay-based point-of-care rapid diagnostic kit was developed. As we're all aware of the Schirmer strips that are used in the assessment of dry eyes, instead of throwing them away after the test, we collect them in these little Eppendorf tubes for analysis. The tear proteins are extracted and transferred into antibody-lined wells within these cartridges. These antibodies bind to the antigens in the tears, and a second antibody is added, which forms an immune fluorescence complex. This sandwich protein is read by the BioPathfinder, giving us a biomarker profile like this. The kit has several potential applications in the management of dry eye, uveitis, and so on and so forth. The polarization-sensitive OCT is a novel imaging technique to visualize the arrangement of fibers in the cornea. Normal eyes contain a compact checkered arrangement of collagen fibers. A loss of this arrangement when these fibers are sparsely arranged results in a weakening in the structure of the cornea. That is the picture that we see in ectatic conditions of the eye like keratoconus and post-LASIK ectasia. It has several applications in ophthalmology, both for diagnostic as well as prognostic purposes. Gene therapy. By definition, gene therapy is the process of fixing defective genes responsible for disease. Is it that simple? Not at all. Vectors are used to deliver the correct copy of a gene into the target cells. Our lab works on recombinant adeno-associated viruses as a vector for gene therapy. We engineer these vectors to regulate genes, and we've developed a clinical grade vector production process for this purpose. As you can see here, we have a first of its kind CGMP vector production facility with 3 class 100 clean rooms. Artist with artificial intelligence. The biggest worry on a refractive surgeon's mind is the development of ectasia after surgery. This led to the search for a method to predict the corneal stiffness after refractive surgery. So we created a finite element model of the cornea using data from the Pentacam and Corbis and combined it with artificial intelligence to develop a novel diagnostic tool, the AccuSymX. AccuSymX, as the name rightly suggests, accurately simulates the outcome of refractive surgeries. So you can plan and customize your surgery accordingly. At around the same time that I joined NN, a new hybrid tomographer aberrometer had been procured, the Pentacam AXL Wave. We were one of the newest fellows at the time, and we were given a chance to work with the newest machine in the department. We assessed its repeatability and agreement, culminating in 3 papers published in renowned journals. So NN Narayan Netralia not only showed me how to strike a balance between these two, it also showed me how to integrate them. We put together clinical dilemmas, genetics, biomarker profiles, imaging, AI-based applications, and put them all together to look for answers to the unknown. This led to the birth of IGAPS, inflammation, genes, and applied proteomics in surgery, a more holistic and personalized approach to ophthalmology. What are the future developments? After our work on PSOCT, we now plan to delve into the world of optical elastography. Brillouin microscopy gives us a new perspective on tissue biomechanics. We aim to expand our work on gene therapy, moving towards human clinical trials. India needs gene therapy, but the cost is very high, and the only way to reduce this cost is to develop this indigenously. Our lab has taken the first step in this direction. Using the BioPathfinder, we aim to expand the spectrum of analytes that we study using this modality. This can be used to answer a lot of unanswered questions like, why does a good trabeculectomy sometimes fail? Or why do some eyes respond well to anti-VEGF treatment and some don't? The answers might lie in the biomarker profile. We won't know unless we try. An important lesson that I've learned through my journey as a clinician scientist is the need to step out of your comfort zone. Only then is it possible to explore new opportunities, new territories. They say a ship in the harbor is safe, but that's not what ships are meant for. Every individual's journey is unique and different. It is up to each one of us to chart our own course. This was my journey so far. I have learned much, and I hope to learn a lot more. Thank you.
Thank you, Divya, for such an excellent presentation. It will provoke more PGs to learn, be a clinician as well as the researcher. Thank you so much.
Dr. Vinita, can I speak something?
Sure, ma'am.
So that was an excellent talk by Dr. Divya. And this concept of clinician scientist is an excellent concept, and this is all about what we were talking about initially, that being different. Now, if you're different, it is not just that you are different and you are, competing with the world, but you're also doing things which are actually going to make a lot of difference in the clinical practice also. So that is what these clinician scientists are doing, and our aim of Women in Research is to create more and more clinician scientists. And it is not that it is not possible to do it. It is possible to do it. We have several people in our team, just like Divya. I'm sure she will also join us now as one of the mentors for others who want to go into research along with the clinical work. Thank you. Thank you so much.
Thank you for those kind words.
Thank you, Dr. Mohita. Now we will move ahead, and I'm very pleased to invite two presentations from Bhopal. That's Gandhi Medical College under mentorship of Dr. Aditi Dubey. She is an associate professor, and she has two PGs. One is Dr. Tejaswini Saxena. It's a second year GMC PG from Gandhi Medical College, Bhopal, and Dr. Rishi Prasad. So I will invite Dr. Tejaswini first to share her screen and present her. Dr. Tejaswini, please. And I just want to remind, it is only 5-minute presentation, and there will be -1 deducted for exceeding your time for 1 minute. So just give the salient point and give your things in a crisp and clear manner. Go ahead, Dr. Tejaswini, your time starts now.
Good morning to everyone present over here. I'm presenting a case of delayed sequelae of post-COVID ROCM. My case is a 31-year male who presented with a chief complaint of left eye diminution of vision since 5 days, left eye redness and discharge since 5 days. History of present illness is, as per the patient, he was apparently all right 5 days back, then he developed complaint of diminution of vision associated with redness and discharge from left eye, which was gradual in onset, progressive in nature, watery discharge, associated with pain, discomfort, photophobia. There is no history of diabetes mellitus, hypertension, tuberculosis, or HIV, no history of fever with rashes in the past, blisters over the face, or ocular trauma.
Past history, there's a history of COVID positive 8 months back and a history of ROCM 7 months back, during which he developed numbness over the left side of his face associated with double vision, drooping of left eyelid, which was associated with restricted eye movements. His MRI also showed involvement of the trigeminal nerve and the Michel's cave as well as the cavernous sinus. He was administered IV amphotericin for this, and endoscopic debridement was done. And to be noted is that during endoscopic debridement, his first division of trigeminal nerve was severed. The patient has taken oral antifungal tablet posaconazole for 2 months. On examination, the general and the systemic examinations were within normal limits. On ocular examination, his left eye showed, the right eye had normal findings and the left eye had visual acuity of 636, and there was no improvement on pinhole. Left eye had mild ptosis and the lateral movements were slightly restricted. The lacrimal passage was patent. His conjunctiva showed ciliary and conjunctival congestion. There was on corneal examination, there was an ulcer present, which was central disc-shaped patch with peripheral punctate lesions in all the quadrants, and the size was 3 into 3 millimeters with infiltration of 4 into 4 millimeters. The margins were distinct with base having necrotic slough. The depth was up to the stroma 30 to 40%. The corneal sensations were reduced in all the 5 quadrants. The staining showed was positive for about 3 into 3 millimeters in the central area. The keratic precipitates were absent and the vascularization was present as superficial vascularization 360 degrees. Anterior chamber was normal in depth, but the content could not be appreciable due to hazy cornea. The iris was normal in color. The pattern was not appreciable. The pupil was central circular reacting to light. Lens was transparent with digital tension normal, and the fundus was within normal limits. Sensations over the same side of the face and nose were diminished due to severed trigeminal nerve, the first division. This is the disciform keratitis on slit lamp examination, which showed positive staining. And these are the corneal diagrams. The differential diagnosis of my case are left eye herpetic keratitis, metaherpetic keratitis, and neurotrophic ulcer. This investigations which were advised were corneal ulcer culture sensitivity, on which we found no growth. The KOH mount showed no fungal elements, and the gram strain had no organism seen. The recent MRI showed normal sinuses. The cavernous sinus was normal, and there were diffuse mucosal thickening in the left frontal sinus. However, the middle turbinate was not seen due to operative resection. Management given was, patient was advised systemic and topical antivirals, so with tablet acyclovir for 10 days, 5 times a day. And the topical acyclovir eye ointment was advised 5 times a day with preservative-free carboxymethyl cellulose eye drops. And mild steroid was started as fluorometholone in a tapering dose. Atropine eye ointment was also advised. Conclusion is, with antiviral treatment, the patient recovered of the ophthalmic symptoms and regained visual acuity of 6/6. Extensive lubrication and mild steroids were the mainstay, and partial features of 6th and 3rd nerve palsies remained as a sequelae of ROCM. Probable diagnosis is left eye viral disciform keratitis, status post rhino-orbital cerebral mucormycosis with recovering partial 3rd, 5th, V1 and 6th nerve palsy. Discussion is trigeminal nerve severed, which led to diminished corneal sensation, which led to delayed manifestation of disciform keratitis. The immune-mediated disciform keratitis was a sign of recovering stage of ROCM, a rare entity and first of its kind. Early detection and timely intervention is the key. Thank you.
Thank you, Dr. Tejaswini, for presenting the case well in time. And now it's open for discussion.
Dr. Tejaswini, why do you say it is the sequelae or the it happened because of ROCM?
Ma'am, because the patient was in a recovery stage of ROCM, so he was in an immunocompromised state where he contracted that viral keratitis.
Simply, why can it just not be a neurotrophic ulcer? It is a central ulcer, and if you see the findings, they are coming in exactly the same way the way neurotrophic ulcer comes, clear, round, which healed on. You gave obviously supportive treatment, lubrication, and which is exactly treatment of neurotrophic ulcer. And second thing, because in the end you are saying that it's an immune mediated because of RCOM. Then is it immune-mediated herpes or RCOM? Because there are really nothing of herpes. And disciform keratitis of herpes responds to steroids and not to antivirals.
Ma'am, steroids were given under cover of antiviral treatment.
That's what I'm saying. Disciform keratitis responds to straight steroids. So why are we getting two diagnoses at all? RCOM itself has given rise to corneal anesthesia, a typical classical neurotrophic ulcer in the center of the cornea. And if the ulcer is not treated initially properly, it will lead to tissue necrosis, which was happening in this patient. And you added the right kind of treatment, it responded. Like if you get herpes, there has to be a reason for it.
Ma'am, due to immunocompromised state, the patient had herpes keratitis.
No, why do you say
When
herpes?
was it?
What is the evidence for herpes? I want to know that.
Need to have a systemic manifestation also, no? Or it is an exposure and it had a trauma and epithelial loss, and that led
Sorry, ma'am, the patient was having a reduced sensation on that side of face, so patient could not present early, but he must have wrapped his eye, or there must be a history of some trauma which the patient did not notice in the early stage.
Did the patient have any prior history of HSV infection before his COVID?
Ma'am, the patient did not give proper history of having any prior.
So we can't assume too many things, that he might have done this, might have done that.
And no KPs, no KPs and disciform keratitis of herpes.
So
at least disciform will always have some KPs.
So Tejaswini, we're not saying that your diagnosis is incorrect. I think that probably what you've not managed to do is convince that it is herpes, active herpes. So I do agree that RCOM or post-COVID status is an immune deviation or an immune compromised status. And the chances of having herpetic disease or herpes keratitis can be high. It's good enough theory to buy. So in this particular case that you had, I think clear cut, we are not sure yet. I think you did show in your presentation, she did show that there was a lot of exudates behind in the deeper part. So when I looked at your slit lamp photograph, it looked more like herpetic endothelitis or a keratitis rather than just exposure. And so they have used antivirals and they have used steroids. So that may have been sufficient in this case. And obviously the corneal sensation will be lost. I think what was not a very good way of the differential diagnosis, where you said herpetic disease and then you said metaherpetic, then you said neurotrophic. So one leads to the other, leads to the third. So, it's not clear in your mind what kind of herpes are you talking about in this case. It's an interesting case, as in a young patient developing herpetic eye disease due to RCOM, but a few points could have sort of added up to your presentation.
Good point. Good point is the mind is open.
Yeah.
Thank you, ma'am.
I think we are over with the discussion time. We'll go to the last case.
Thank you so much. Now we will invite Dr. Nishi Prasad to present her case. Dr. Nishi.
Yes, ma'am. Thank you, ma'am. Good afternoon, everyone. I'm going to present a case on a 27-year-old female who is a housewife and resident of Shivaji Nagar, Bhopal. She complains of painless diminution of vision in both eyes since one day. As per the patient, she was apparently all right one day back when she had undergone cesarean section at full term due to raised blood pressure and has given birth to a healthy baby boy. Now notice diminution of vision in her both eyes on her post-operative day 1, which was sudden in onset, gradually progressive, painless, associated with headache. Initially, she could see the ceiling, but now she cannot even see faces of her relatives properly. Headache was throbbing in nature, diffusely present over entire head and throughout the day with no aggravating or relieving factors. There's no history of altered mental state, seizure or unconsciousness, no history of ocular trauma. No similar complaints in past. Primary gravida female detected with raised blood pressure at 28 weeks of gestation, for which appropriate treatment was given. History of cesarean section one day back. Not a known case of hypertension, diabetes, TB, renal, vascular or autoimmune disease. No history of taking any other drugs apart from her routine calcium, iron, folic acid and multivitamin tablets. No similar complaints or any chronic illness in family. Her personal and menstrual history is within normal limit. Examination, a moderate build with 65 kgs with no signs of pallor. Her blood pressure was 160/100 mm of mercury. Pulse rate, respiratory rate being normal, afebrile. Systemic examination, C-section dressed wound present in lower abdomen with a slight tenderness around the wound. Apart from that, other systemic examination was within normal limits. On ocular examination, her visual acuity in both eye was counting finger 1 feet, PR accurate, and projection of rays accurate in all the quadrants. On pinhole, there was no improvement. Both eyeballs was normal in position and size. Extraocular movement and anterior segment was within normal limit, including pupil, which was central circular and reacting to light in both the eyes. Intraocular pressure was also within normal for both the eyes. On detailed fundoscopy, medias were clear and this was within normal limit for both eyes. My differential diagnosis: posterior reversible encephalopathy syndrome, fat embolism, intracranial hemorrhage, metabolic encephalopathy. Her blood investigation was within normal limit. Only urine routine and microscopy showed protein, coagulation profile and ECG was within normal limit. So with the normal fundus picture, to rule out other causes of blindness in a young postpartum female with history of preeclampsia, MRI brain was done and it showed multifocal hyperintensities, especially in occipital lobe and also to some extent in parietal and frontal lobe. So my probable diagnosis: sudden painless bilateral diminution of vision in young postpartum patient with history of preeclampsia and normal fundus picture with MRI brain report showing multifocal hyperintensities in subcortical and deep white matter of bilateral frontoparietal occipital lobes, most likely posterior reversible encephalopathy syndrome. So the treatment was the mainstay of treatment was to control the blood pressure, and hence labetalol and hydralazine was given along with other supportive symptomatic treatment. On follow-up on her post-operative day 5, her blood pressure was 140/90 mm of mercury. On systemic examination was within normal limit. Ocular examination, visual acuity was improved to 6/60. Extraocular movement and anterior segment and fundus within normal limit. On her follow-up on post-operative day 10, her blood pressure was 120/80 mm of mercury. Systemic examination within normal limit. Ocular examination, visual acuity had improved to 6/6. Anterior segment fundus within normal limit. Patient had denied for check MRI. Posterior reversible encephalopathy syndrome, also known as reversible posterior leukoencephalopathy syndrome, is a neurological condition characterized by headache, altered mental status, visual disturbances, seizures, and unconsciousness. There are two main theories given. One is cerebral vasoconstriction and other one is endothelial dysfunction. Systemic associations: preeclampsia, eclampsia, acute hypertension, renal disease, vascular autoimmune disease, exposure to immunosuppressive and cytotoxic drugs, organ transplantation, sepsis, and multi-organ dysfunction syndrome. Sequelae being cortical blindness, homonymous hemianopia, visual neglect, blurred vision, auras, and visual hallucinations. MRI brain is the gold standard, where typical lesions are noted in occipital and parietal lobes. Mainstay of treatment is control of hypertension. Prognosis is usually good. Clinical syndrome usually resolves within a week and MRI changes over days to weeks. There are some studies which showed that endothelial dysfunction as a major pathophysiologic mechanism and acute hypertension was present in 86% of the patients. And on brain imaging, posterior lobe was most commonly involved. Another study done by Minnesota in 2007, where parieto-occipital lobe was involved in 98.7% of the patients. And another study by KU University, Belgium, seizure was found to be the major predictor of PRES, followed by encephalopathy, and majority of the patient had hypertension as a risk factor, followed by renal disease and immunosuppression. So it's a reversible change which includes visual symptoms, and a high index of suspicion and prompt treatment can reduce morbidity, mortality, and pave the path for an early recovery. Thank you.
Thank you, Dr. Nishi, for such a unique case presentation. Now it's open for question and answer.
Good presentation, Nishi, and you completed it in all aspects.
And also one of the rarer cases.
Yes. And
how is it different from HELP syndrome, Nishi? How do you differentiate this with HELP, or is it the same as HELP, wherein there is hemolysis?
Yes, ma'am. It's different, ma'am. Here, both will present with sudden painless diminution of vision, but then the prognosis is very good in PRES syndrome, and usually in a week, the outcome we see the improvement in visual changes, and also the coagulation profile will be normal in PRES syndrome. and with no thrombocytopenia as such. And in HELP syndrome, there will be thrombocytopenia with some coagulation profile changes. And even clinically, rashes could be seen in HELP syndrome.
Because commoner is a HELP syndrome.
Commoner is a HELP syndrome, ma'am. Yes, ma'am. Breast
Yeah,
is
and-
a rare entity, ma'am.
And also the embolism, amniotic fluid, this thing.
Not, yes, ma'am. That's what I included in my DD, ma'am.
Yeah. So DD
It had a cesarean section history one day back.
Yes. Then your thing was all right. Fine.
Thank you, ma'am.
Well presented, Nishi.
Thank you, ma'am.
Is this the end or more?
There's more.
I think 2 more in our group.
Yes. So now with this, we will move ahead with 2 more presentations from Sadhguru Netra Chikitsalaya Chitrakoot under mentorship of Dr. Amruta More. She is a vitreoretinal and uvea consultant at Sadhguru Netra Chikitsalaya Chitrakoot. And 2 of DNB resident, Dr. Aishwari Revankar and Dr. Darshan Shah will be presenting the cases. So the first will be Dr. Aishwari. Please share your screen and keep in time of 5 minutes. All the best.
Yes, ma'am.
Yes, go ahead.
Should I start, ma'am?
Yes, please go ahead.
Good afternoon to one and all. Today I'll be presenting a case of a 48-year-old male who came to our OPD with painless progressive diminution of vision in both eyes since 6 months. Patient is a known diabetic since 4 years on oral hypoglycemic agents. Patient presented to us with best corrected visual acuity of 6/9 in the eye, wherein the anterior segment was within normal limit on slit lamp biomicroscopy with clear lens in both the eyes. There were few cells noted in the anterior vitreous space in both the eyes. On fundus examination, there was presence of hyperemictus with venular dilatation along with few pigmentary alterations present at the fovea. Considering there might be a uveitic etiology, we asked the patient relevant history, wherein there was no history of fever, tuberculosis, weight loss, no history of rash on the body, no history of orogenital ulcers, backache, neck stiffness, joint pain, and no history of other systemic illnesses. We further went on to investigate the patient, wherein we found there was elevated neutrophil count with deranged blood sugar levels and HbA1c suggestive of poor glycemic control. The labs were suggestive of non-infective etiology. We further went on to perform a fundus angiography, wherein the arm to retina time was normal and multiple hyperfluorescent dots were present over the posterior pole with leakage of dye from all major vessels, increasing in area and intensity in subsequent phases. There was increasing hyperfluorescence of the disc also evident. Similar angiographic findings were also present in the other eye, which were all suggestive of vasculitis. Based on clear history, clinical evaluation, and labs, we made a diagnosis of idiopathic vasculitis in both eyes, and patient was started on oral steroids, prednisolone 1 mg per kg, along with calcium supplements and proton pump inhibitors under physician's care for glycemic control. 2 weeks after initiation of steroid, there was a drop in the best corrected visual acuity from 6/9 in both eyes to 6/12 in the right eye and 5/16 in the left eye. Disc appears hyperemic with venular dilatation and pigmentary alterations present at the fovea, with a single dot hemorrhage present just below fovea in the left eye. On fundus autofluorescence, there was presence of stippled hyper and hypoautofluorescent dots all over the posterior pole. On fundus fluorescein angiography, the arm to retina time was normal. However, for the first time, we noted presence of hyperfluorescence with interspersed multiple early hypofluorescent dots temporal to the fovea and outside the arcades, both superior and inferior to the disc, which was suggestive of leopard spotting. There was diffuse vascular and disc leakage along with stippled background fluorescence evident in both the eyes. The leopard spotting was also present over the posterior pole in the left eye. On OCT, raster scan passing through the fovea shows presence of multiple hyperreflective deposits present between the posterior hyaloid face and the internal limiting membrane. Focal contour and parallelism of retinal layers is maintained. However, there is nodular thickening of the RPE evident, associated with patchy loss of external limiting membrane and ellipsoid zone overlying these pigmentary changes. Multiple hyperreflective dots were also present in the choroid with an increase in the choroidal thickness. Based on OCT findings of nodular retinal pigment epithelial thickening, stippled hyper and hypoautofluorescent dots on autofluorescence, leopard spotting on fundus fluorescein angiography, and poor response to oral steroids, we reconsidered syphilitic chorioretinitis with vasculitis as one of our differentials, along with autoimmune retinopathy and primary intraocular lymphoma as our other differential diagnosis. We went on to investigate the patient to rule out our other diagnosis, wherein the other investigations were normal. However, at this point, we also advised the patient a more specific test for syphilis, that is the fluorescein trypanomal antibody absorption test, which came out to be positive, surprisingly, even after a previous negative VDRL. On re-inquiring, the patient also revealed a history of painless genital ulcer, which healed spontaneously about an year back. Considering stigma in the society, patient had not revealed this history previously. Thus, we made a diagnosis of syphilitic chorioretinitis with vasculitis in both eyes and started the patient on IV ceftriaxone 1 gram twice a day for 14 days. After 14 days of IV ceftriaxone, there was an improvement in the best corrected visual acuity from 6/12 to 6/9 in the right eye and to 6/18 in the left eye. On fundus fluorescein angiography, there was also a reduction in the disc and vascular leakage, and the leopard spotting had also decreased post-treatment. On OCT also, there was complete resolution of nodular thickening of retinal pigment epithelium in both the eyes and resolution of subhyaloid hyperreflective deposits as well. From this case, we would like to highlight the usefulness of multimodal imaging like OCT and FFA in diagnosing syphilitic chorioretinitis. Also, reverse testing algorithm for syphilis proves to be important, wherein an enzyme immunoassay or a chemiluminescent assay is done for prior screening of the patients, which is a much more sensitive and specific test than the routinely performed VDRL test. Since the 20th century, there is an increasing trend in syphilis cases as quoted in multiple articles. Therefore, in our routine uveitis workup, it is important to include a specific test like fluorescein trypanomal antibody absorption test or a trypanosome pallidum hemagglutination test, which is a much more specific test, along with a sensitive test like VDRL to prevent missing out on ocular syphilis. As we know, it is also called the great imitator and thereby easily misdiagnosed, as in our case. Thank you.
Thank you, Dr. Ishwari, for presenting such a wonderful case. Now it's open for question and answer.
Classical presentation of once upon a time common disease, rare now. And I think what is good point about this was that clinically suspected, and the picture actually, if you see the evolution, it turned out the same way. So I think the case is really good. But tell me, what are the pointers that made you think of syphilis?
Ma'am, initially when the patient presented to us, he did not have any significant history. We even asked the patient for presence of any orogenital ulcers, for which patient denied the history.
No, I'm not asking that. I'm asking the pointers in the clinical picture that made you suspect syphilis.
Yes,
There are very clear-cut pointers to think of it. So you should
Yes,
be able to tell that in the exam. Yeah.
Yes, ma'am. Ma'am, there was presence of these multiple hyporeflective hypofluorescent dots interspersed in between the background hyperfluorescence. That is a typical leopard spotting that is seen on fluorescein angiography. Also on OCT, we can see that there is there was nodular
One
thickening
more
of
clinical point you said, which you're not saying now. Did you see hyperpigmentation?
Yes, ma'am. Pigmentary alterations present at the fovea.
Salted pepper classical fundus was the fundus of syphilis.
Yes,
right?
ma'am.
Yes. And actually, VDRL is a non-specific test. FDA is the right test for syphilis. So, like whosoever treating person has gone correctly on the right lines. Well done.
Thank you.
You can go to the next. Anybody else? Yeah.
That's fine. All residents are beautifully presenting, and what a gamut of cases we are coming across. I think this is one of the platforms where there's a great, exposure to all diseases, and amazing thoughts and knowledge of Dr. Madhu, really, making us educated and summarizing the whole thing beautifully. Very well done, everybody.
Oops.
Now I invite Dr. Darshan Shah for his presentation.
Is my screen visible?
Yes,
Darshan is sharing, but it's not come yet.
Yes, now it's visible. You can go for slideshow.
Okay, good afternoon, everyone. Today, I'm going to present a case of a 31-year-old male
who came to our OPD with complaints of sudden onset painless diminution of vision in left eye since 2 days. There was history of single episode of fever 4 days back. There was no history of any rash. The anterior chamber and anterior vitreous face appeared to be quiet. The systemic examination were within normal limit. The best corrected visual acuity in the right eye was 6/6 and in the left eye it was 6/36 part with near vision of N36. Now on coming to the left eye fundus examination, the disc and vessels appear to be normal. There are two distinct coin-shaped lesion, deep retinal lesion of the size half this diameter inferior to the inferior temporal arcade. We can see two large deep retinal yellowish white ground glass appearing lesion, one being inferior to the inferior temporal arcade and other being at the posterior pole just inferior temporal to fovea. The right eye fundus appeared within normal limit. So the patient was advised ancillary tests such as OCT and FFA, and the patient came next day, and to a surprise, we saw that rapid progression in the size of the pre-existing lesion, which also now involved the fovea, and two new coin-shaped lesions at the superior temporal arcade and inferior nasal to the disc can be seen. And we can also observe a streak of subhyaloid hemorrhage along with the inferior temporal vessel. Therefore, on a raster scan OCT, passing through the lesion, we can see there are no hyperreflective dots in the vitreous suggestive of no cells or vitritis. The vitreoretinal interface was being normal and the nasal part of the retina appeared to be normal, whereas in the temporal part, we can see ballooning of the internal limiting membrane and its separation. There is disorganization of all the retinal layers suggestive of full thickness retinitis and interruption of the ellipsoid zone. The choroid appeared to be normal. So we went ahead and did a FFA, and we can see a laminar flow in the superior temporal vessel and delayed feeling of the inferior temporal vessels. We can see a blocked hypofluorescence which correspond to the hemorrhage seen in the fundus picture. The lesion appeared to be smudge and hypofluorescent initially, and in the later frames it became hyperfluorescent at the edges suggestive of a retinitis lesion. So based on this, there are certain characteristics of different differential diagnosis which met the criteria. That is why we had this 4 differential diagnosis in our mind for this young adult who came to us. So what we thought, the patient will be a case of viral retinitis, and this 4 differential diagnosis of acute retinal necrosis, progressive outer retinal necrosis, cytomegalovirus retinitis, and measles associated retinitis was made. But both the diagnosis of progressive outer retinal necrosis and cytomegalovirus retinitis were not possible as the patient was immunocompetent young adult and was HIV negative. And in acute retinal necrosis, we get a tongue-shaped peripheral lesion accompanied with lot of vitritis. So we ruled it out. So this in this young adult with no anterior chamber reaction, no vitritis and vasculitis with full thickness retinitis lesion at posterior pole and at inferior temporal arcade, a diagnosis of measles associated retinitis was made, and to see the further neurological involvement, the patient was referred to a neurologist. So MRI and EEG were done and they were within normal limit. On cerebrospinal fluid analysis, there was increased CSF and serum IgG levels, and with CSF and serum quotient being 13.4, which is more than 1.5, suggestive of highly positivity. The patient was then started with valcyclovir, and the patient came for follow-up after 2 weeks, and in this left eye fundus picture worsened, and we can see there is thinning and mottled appearance of the retina along with hemorrhage suggestive of necrotizing retinitis. On OCT of the left eye, we can see that there is a passing through this lesion, we can see disorganization and loss of all the retinal tissue, giving a moth-eaten appearance, whereas choroid appeared to be normal. So to conclude, subacute sclerosing parencephalitis, which is a % of fatal condition, is known to have a neurological manifestations. When Daikon et al. Or Jabbar et al. Gave stages of the illness of SSPE, none included ophthalmologic findings. Certain times when the patient has no neurological manifestation and has only visual disturbances, such as in our cases, then it is of utmost importance that the ophthalmologist should take note of this typical OCT findings and diagnose it on basis of that. Multiple case reports given by Shah et al., Agarwal et al. Have now and then specified the importance of typical OCT pictures and short diagnosis one can give based on it. It was actually not possible for the earlier authors to give the detailed picture of the eye, since the OCT as a tool for better retinal evaluation was only available after 90s, making it impossible to include it as a feature. Hence, I conclude at this by saying that such a stereotypical cases should not be missed as an early diagnosis, and an early diagnosis may not prevent death but may prolong the lifespan.
Thank you, Dr. Darshan, for such a unique case presentation. Now it's open for question answer.
Darshan, yours is also a rare case. Tell me, what is the common age group when you have SSCP? Do you have SSCP in actually this age group or some other age group in which it's more common?
SSP is seen in specifically seen in later age, like 5th or 6th decade. It is not seen in young, because it is due to a mutated virus and not the measles actual virus.
So that is what there is a challenge, because SSCP is seen in people who become so much older. They are more vulnerable people. So you thought of it is also by itself is a good thing, but I think you made a good attempt to make a diagnosis of exclusion rather than diagnosis of inclusion, because your clinical assessment of AND and PON and CMV, they were all correctly placed in your slide. That was a good thing that you did. And here is the little odd thinking mind that you've got to think and investigate further. Like eye is not the B end and the end. So we must move beyond eye, and as and when there's full thickness retinal involvement. Brain is, we must not forget eye is extension of brain. So therefore, whatever is happening there, something could be happening there as well. But there was something very strange. You could have done an ultrasound. If you see there's some round lesions, in the center of that, there was a white dot. Did you notice that? If you go back to your fundus slides, just open the slides. When you showed the first fundus, show second fundus. Yeah, just go serially. Now, if you see that, I can't, no, you were right on the same thing. Yep, if you see here, now what are you seeing? These pictures are looking almost like a subconjunctival cysticercosis. But this is actually retinal necrosis, which is going through full thickness. So if you had you done a ultrasound, you may have got another.
No, ma'am, the B scan was within normal limit.
See, the B scan, what you've seen for B scan was, what you all see is the vitreous and retina attached. It wasn't retina attached. It was like intraretinal peaks. See, this must have been fibrotic. Actually, it's beyond the MBBS level, beyond the MS or a DNB level case. But here you could have got some peaks on high resolution of the retina. So, but good, very well presented, and I think this is one case which is an eye opener sorts. It deserves a publication somewhere.
Dr. Madhu. Yeah. Darshan, what about the status of measles vaccine? Does it have any correlation? Is it
Yes, ma'am. Yes, ma'am. Ma'am, the only now the hope against SSP currently lies in its prevention, and like it is seen in countries with effective measles control and vaccination, SSP is virtually an extinct disease. So a universal measles vaccination is of a paramount importance, ma'am, to wipe out this devastating disease from the face of the earth.
So this person was not vaccinated?
Ma'am, the vaccine status was not, the patient did not know. He has not brought any vaccination details, or we can see, or
So this history was important, right?
This history was relevant. Yeah. It is part of universal program. Measles is being given to everybody now. So that's not a challenge.
Correct.
But
there are misses which we get to know by these.
Yeah. So good, I think we are good. We're just half an hour over, like instead of 1:30.
We have, I think this is the last presenter.
No, it's done. We are done, no?
Yeah, the last one is done.
There are a lot many.
Yeah,
so now we have come to.
No, the set of judges will change.
After this, the set of judges will change.
So she's not in our list.
No, we don't have this candidate on the list.
Ma'am, this is a talk. Dr. Mehzabeen is a
the other session talk.
Okay, okay, all right.
Okay,
Second
okay.
half
It's
of
not
the
a
day.
paid presentation.
Okay, all
Okay,
right.
my
When do we give the marks and all? Like we are just calculating.
And whom to give?
I think
But
maybe
ma'am,
Shweta
you
can
can.
just share the email ID and everybody can send it to Shweta.
Yes, ma'am. Yes, ma'am. I'll share. On the judges group, I'll share.
Yeah.
Yes, ma'am.
Can I
So
just
now,
WhatsApp? Can I just take a shot of the marks and WhatsApp it there?
Yeah, we'll have to do that.
You
Yes,
can
ma'am. You can do.
you
You
can
can
do
do
it
that
to
also.
Shweta individually rather than do it to
Yes,
the
yes.
group.
Yeah.
Okay, ma'am.
Okay.
Thank you. Thank you. Thank you so much.
Thank you, everybody.
so now,
We'll be
now
moving
I'm
on.
happy to invite Dr. Mehzabeen Rahman. She's a research fellow in phaco and refractive surgery at Tirupati Eye Center, Noida. She's a recipient of DST grant from Government of India for research work in ophthalmology and recipient of AIOS 2021 International Hero Award. And she will be talking about enhancing the skill after residency, which is very important. So Dr. Mehzabeen, please do the honors. You can share your screen.
Thank you, ma'am, for these kind words. And at the onset, I would like to thank WOS chapter MP for giving me this opportunity to speak at such a platform where such famous ophthalmologists are there, and I'm just an up and coming ophthalmologist. Thank you again. So I'll be talking about enhancing skills after residency. So can I? So during residency, as we all know, we don't really get too much of exposure to surgical exposure. So in various countries like Australia, New Zealand, UK, they have fixed minimum surgery requirement that you have to complete these many surgeries once you are about to finish your residency. But we don't have such a criteria till now in our country. But hopefully they're working on it. So there's always inadequate surgical exposure, and we need to address this burning question. There has been studies in which they found that female ophthalmologists get less surgical exposure. It can be due to a lot of reasons to balance between work and family. Many of the female residents, they get married early, and then they lose track of their surgical exposure. Also, many patients, they feel they like to get their surgeries done by male doctors, which is an ingrained bias since forever. But in ophthalmology, we see that females are doing a lot more nowadays, which is thankfully, which is present. And we also see a lack of mentorship. At this point, I would like to mention my mentor, Dr. Mohita ma'am, who has been kind enough to be my mentor since the last 1.5 years. And I don't have words to express my gratitude for my mentor. She has helped me enhance my surgical skills and like improve my ophthalmology to a level I couldn't have imagined without my. See, it is not going. Okay. So my professional journey was, I have done 3 years of residency from Assam Medical College, Dibrugarh in Assam. There we had few SICS exposure. There was no phaco, like in most residencies. Then I worked for 18 months at a charitable hospital in Rishikesh. There I got around a lot of SICS surgeries and around 120 phaco surgeries. Now, since the last 1.5 years, I have been at TC, and I have had a great many exposure to phaco, topical phaco, refractive surgeries, and like doing the workup of refractive patients, which is so important. So we can also take the break that female ophthalmologists usually find as an opportunity, because there's a lot of like WINAR, Women in Research, and Department of Science and Technology. They have started a lot of programs which involve women ophthalmologists, women scientists who have had a break in the career due to any reason, and they give you grants if you submit your proposal. And I have been recipient of such a grant from DSG, and I have started my project at TEC itself. So life at TEC, first I started as a trainee. There was a little break in my career, and as a trainee in FACO. Then lo and behold, I was, like promoted to a trainer. I train a lot of new doctors who come for FACO training, and it has been a very fulfilling experience at TEC, Tirupati Eye Center, because I get hands-on and I get to deal with private patients, which is like high demanding patients, which helps with your own private practice later on. How to improve surgical skills at residency level? There should be some criteria, like we need mentors who pass cases to the residents. We can also tie up with tertiary centers which have more complicated cases, and we should have a separate training OT for the residents. The residents themselves, post residency, during your fellowship, most important factor is you should have communication, good communication and managerial skills, and you should always have review of your videos, which is the most important. One of the most important criteria. You review your videos with your colleagues, and then you know where you are lagging, and always take in constructive as well as any kind of criticism and apply it to your later surgeries. Obviously, we are still in the pandemic. So there have been a research in which they said at the end of the year in residency, the surgical challenges the residents are facing are a lot. Most common problems is poor hand-eye-foot coordination during phaco and poor intraoperative judgments. So with WOS, we can attend grand rounds, and there is always this mentorship program, which is a huge help to all the new residents who are just fresh out of college. You can always attend these WOS, mentor-mentee and online resident programs. And WOS gives us a platform in which all of us can come together and help each other increase our skills and expand our horizons. So we have to celebrate how far women ophthalmologists have come and also help each other out to move forward. Thank you.
Very true, Dr. Mezabeen. Thank you so much for your feelings at Tirupati Eye Center. Thanks a lot. And with this, now I invite Dr. Sonam to do further moderation. Thank you so much, WOS, for giving me this opportunity.
Thank you, ma'am. First of all, it was a very heartfelt talk by Dr. Mezabeen. Great wishes for your future. And here I would like to say, Dr. Respected Shreya ma'am, Meeta ma'am, Jagriti ma'am, they were all my mentors to my residency program. And breaking the stereotype, my thesis guide was Dr. Nitin Meema sir. So his guidance has been like very influential in making my career choice as a super specialty choosing retina. And further saying that, I think the history is repeating again, that further now we have from People's Medical College, we have 2 lady doctors who are going to be joining us now, and their mentor is none other than Dr. Harpal Singh sir. So I would like to introduce sir right now, and also welcome our second set of judges to evaluate and assess the session ahead. Thank you so much to the session 1 judges for their active participation since the very chilled morning into the afternoon. May I please share my screen? Dr. Mezabeen, can you please stop sharing your screen?
My sharing screen is on.
Yeah.
Then again share. Is my screen visible, ma'am?
Yeah, it is still visible. I think there's a view box at the top. From there, you can stop sharing the screen.
Okay, sure.
It's done. It's done.
So, Dr. Harpal Singh, sir, he is currently the professor and HOD of the People's College of Medical Sciences and Research Center at Bhopal, with his advanced training in phaco glaucoma and his continuous service to Seva Southern Eye Hospital. Now he is today with us and mentoring the cases to be presented by Dr. Ritu first. And meanwhile, I would request Dr. Mehak Gupta to be please ready with the first slide. Dr. Ritu Gupta, are you there?
Yes, ma'am. Can I start, ma'am? Ma'am, can I start?
Yes, you start your screen share. Your screen is not visible.
Shweta ma'am's screen is still on, so my share screen is not.
You'll have to click on share screen. Nothing is visible on the screen here.
Sorry, Shweta ma'am, can you please turn off your screen share?
My screen is not being
I
shared.
don't think Shweta is sharing her screen.
I am. No one is sharing screen at right now.
Can the tech support please help in the situation?
Good morning, everyone. Thank you for this opportunity. My case is of a 32-year-old Hindu female resident of Bhopal, Madhya Pradesh, who is a clerk by occupation, presented in IOPD of People's Hospital with chief complaints of drooping of right upper eyelid since 8 days and right periorbital pain since 8 days. History of presenting illness was, my patient was apparently all right 8 days back when she developed drooping of upper eyelid of right eye, which was sudden onset and progressive in nature, associated with pain in right periorbital region, which was continuous, sharp, low-grade intensity, radiating to right hemicrania and later became diffuse headache. No diurnal variations, no significant aggravating or relieving factors. She also complained of redness and watering from right eye since 2 days. No history of similar episode in past. Also no history of ocular or head trauma, double vision, painful eyeball movements.
We are able to see only the first slide.
Can you please switch to the full screen mode and change the slides? Only the first slide is visible where you have written a clinical presentation. Yeah. Please switch to the current
Go in slideshow mode. Go to slideshow mode. Yes, from here. Yes.
Should I continue, ma'am?
It's not still not in slideshow mode.
At the bottom left, you will see the full screen mode and resume from the place you were already talking about. Otherwise, you
yes, click on it. Click on it.
Is it okay, ma'am?
Okay, you continue.
You can continue.
It's still not in slideshow mode.
Your presentation.
You continue.
Okay, ma'am. Past history, medical history, she was a recently diagnosed type 2 DM with no history of tuberculosis, sarcoidosis, COPD, thyroid disease, hypertension, seizure disorder. Drug history, she was on OHAs for type 2 DM, no other long-term drug use.
Surgical history, family history, and personal histories were non-significant. Clinical examination, in general examination, she was afebrile and all other vitals were within normal limits. Systemic examination, on doing systemic examination, no apparent defect was seen. On ocular examination, best corrected visual acuity in right eye was counting fingers 1 feet with accurate projection of rays in all the quadrants. In left eye, it was 6/9. Near vision in right eye N36 and in left eye N6. Color vision was normal in both the eyes. Dilated refraction was done under tropicamide drug, but there was no improvement with glasses. Head posture, chin elevation was present. No facial asymmetry was seen. Diminished sensation of pain, temperature, and touch over skin of right periorbital, frontal, and maxillary area was present. On further examination of left eye during slit lamp examination under diffuse and focal illumination, no apparent defect was seen. But in case of right eye, eyeball was partially covered by eyelid. No proptosis was there. Hirschberg test showed 0 degree of corneal reflex in both the eyes, and convergence was restricted in right eye, whereas present and normal in left eye. During the ocular movements examination, in uniocular examination, eyeball movements were restricted in right eye, whereas full range in left eye. And in binocular examination, the eyeball movements were restricted in all the directions in right eye, whereas there was overaction in the directions shown here in left eye. These are the pictures of the ocular movement examination of the patient. During eyelid examination in right eye, Bell's phenomenon was intact. Diffuse mild edema of the lid was seen. Severe ptosis was seen, and the margin reflex distance 1 was -2, MRD 2 was +5, MRD 3 was 0. Interpalpebral distance was 3, and LPS function was 6 millimeters. The lacrimal apparatus was normal in both the eyes. Conjunctiva showed mild conjunctival congestion and mild chemosis in right eye, whereas normal in left eye. Cornea was clear and transparent in both the eyes, but sensations were reduced in all the quadrants in right eye, whereas normal sensations were present in left eye. Sclera was normal in both the eyes. Anterior chamber was normal. Iris had normal color and pattern. Pupil in right eye was central, circular, mid-dilated, fixed, but the absent direct and consensual light reflex, whereas in left eye, central, circular, both direct and consensual light reflex were present and normal. Lens was transparent in both the eyes, and vitreous showed no apparent effect. Orbital margins in both eyes seems to be intact on palpation. No tenderness or discoloration or crepitations were seen. Intraocular pressure was digitally normal in both the eyes, but by Schwartz tonometer, it was 13.5 millimeters of mercury in right eye and 14.6 millimeters of mercury in left eye.
Your 5 minutes for presentation are over. Can you please stop sharing the screen?
Okay.
I open the case for discussion with the judges and for question answer session.
So Sonal, what is the diagnosis?
Ma'am, Dr. Ritu is presenting. I'm the moderator.
Sorry, Ritu, what?
Ma'am, my differential diagnosis were idiopathic orbital inflammatory disease, orbital myositis, thyroid eye disease, orbital cellulitis, Tolosa-Hunt syndrome, acute dicryoadenitis, vaginous polyangiitis, and multiple sclerosis, sarcoidosis, tumors, and
How
trauma.
did you come to a diagnosis? You have enumerated so many conditions.
During various investigations, routine blood investigations were within normal limits. Sugars were raised, thyroid profile was normal, and during MRI of brain and orbit with contrast, there was an enhancement of right optic nerve sheath from orbital apex to cavernous sinus, showing acute inflammatory etiology in type 1 weighted images suggestive of Tolosa-Hunt syndrome. It was a diagnosis of exclusion.
Okay, so the MRI findings were suggestive of Tolosa-Hunt syndrome.
Yes.
So how did you ensure that whether the optic involved or not?
Ma'am,
say that optic nerve was involved.
The consensual light reflex in left eye was normal, so I deducted that the optic nerve in right eye was normal. And during the
why vision was so less in the right eye, and why both direct and consensual was absent in the right eye? If left normal, then you expect a good consensual light reflex in the right eye. So why you said that it was absent?
Ma'am, due to third nerve palsy, both internal and internal ocular muscles were also paralyzed. So the light pupil was fixed mid-dilated.
In the right eye?
Yes, ma'am.
And in the left eye, both the reactions were normal?
Yes, ma'am.
That was suggestive of normal optic nerve in the right eye?
Yes, ma'am.
So, but why vision was so less in the right eye?
Ma'am, because of because of ptosis and pain, the patient was not able to perceive.
But ptosis, you can always retract the lid and measure, take the vision.
Yes, ma'am.
This cannot cause decreased vision that way.
Yes, ma'am.
But you are not. That means you are not very sure about the vision of right eye.
Yes, ma'am.
So what treatment have you given to this patient?
Ma'am, intravenous methylprednisolone for 3 days, 1 gram, and then tapered orally over 2 months. And along with that, topical lubricants and the methylcobalamin was given, and blood sugar monitoring was done.
So how do you expect, what do you expect now in long run, whether this patient is going to improve, the vision is going to improve?
Ma'am, during when at discharge, her visual acuity improved to 636, and after the intravenous methylprednisolone therapy, and she was discharged with the advice of recurrent attacks might be present, so she has to be careful about it.
We have finished the 4 minutes for question answer session for this case. May I please request Dr. Mehak to start sharing her screen? Dr. Ritu, can you please stop sharing your screen?
Thank you.
It was a nice presentation.
Thank you,
so please keep the time in mind.
Okay.
So there's 5 minutes for case and 4 minutes for question answer session for the judges. Dr. Mehak, please start your case.
Can I start?
Yeah, sure. Definitely, you can start.
Good morning, everyone. Today I am presenting a case. Before starting the case, I would like to say a proper consent was taken from the patient for using the information and photographs. A 25-year-old female, teacher by occupation, resident of Hoshangabad, came with the presenting complaints of burning sensation, redness and watering in both the eyes since 2 years. As per the patient, she was apparently already 2 years back when she first complained of mild burning sensation in both the eyes that was associated with redness of eyes, on and off, relieved on closing the eyelids and resting, with no aggravating factors. She also had complaints of watering from both the eyes that was insidious, progressive, more during the daytime while working, not associated with any discharge, itching or pain. There was no history of diminution of vision, headache, floaters, flashes, photophobia or curtain vision. The past medical history, surgical history, family history were all not relevant, and there was no history of addiction. The vitals were normal and the general physical examination was under normal limits. The systemic examination showed no murmurs, no focal neurological deficits, and the clear. On local examination though, patient had normal head posture, a normal chin posture, facial asymmetry was seen, the right-sided maxillary area and the jaw appeared to soft palate had dilated tortuous vessels. Coming on to the ocular examination, the right-sided ocular examination showed the best corrected visual acuity of 1/60, which was not improving with refraction. The pinhole vision was the same. The color vision and the near vision were normal, but the eyelids showed slightly dilated vessels in the lateral half of the upper eyelid in closed position. And other than that, the inferior episcleral vessels also appeared to be dilated. The anterior chamber content was clear and the peripheral anterior chamber depth was 100 grade 4. The pupil showed RAPD grade 2, central and circular in size, circular in shape, and the on measuring the intraocular pressure, Digitally, it was normal. Applanation tonometry done at 11 a.m. Showed 16 mm of Hg in the right eye, whereas 15 mm of Hg in the left eye. The gonioscopy was done using a 4-mirror, and it showed no evidence of peripheral anterior synecdoche. The trabecular meshwork appeared normal, and there were no abnormalities in the angle, no blood in the Schen's canal. The vitreous was clear. While examining the fundus, it was revealed that the median here, the disc was obscured by dilated tortuous vessels in which the CD ratio could not be assessed, and the tortuous vessels starting from the optic disc were extending peripherally, more prominent in the temporal half. The vessels were seen to be hyperreflective, and the differentiation between arteries and veins were not very clear. The macula was covered by dilated tortuous vessels, and the FR was not visible, and the peripheral fundus also had a few dilated vessels, whereas the left-sided fundus was within normal limits. This is the fundus photograph showing the right-sided and the left-sided fundus. These are some other pictures of the right-sided fundus. Coming on to the investigations, since the patient had complaints of watering and redness, a Schirmer's test and tear film breakup time was done, but it was under normal limits, and diplopia charting was done. No diplopia was seen. Visual fields were examined. Concentration test was done, which revealed no visual field effect. Perimetry could not be done as the patient was not very cooperative, and the blood investigations were all within normal limits. MRI brain in orbit was done, which was suggestive of a lesion involving the right-sided posterior most optic tract, and the lesion was extending up to the optic chiasma. It could represent an AV malformation or a neoplastic etiology was another possibility. A contrast is needed for the definitive correlation. These are the MRI findings. As the pointer shows, the optic nerve is involved up to the level of optic chiasma. Further investigations that have been advised to the patient are fundus fluorescein angiography and MRI brain with orbit. A digital subtraction angiography was also involved. For establishing the clinical diagnosis, a 25-year-old female with unnoticed uniocular diminution of vision, with facial dysmorphia, right-sided prognatism, with enlarged eyelid veins, with dilated episcleral vessels, with dilated retinal vessels in the same eye, right eye, which cannot be differentiated from the veins, with no history of convergence, with no history of any facial cutaneous involvement, no episodes of raised intraocular pressure. The gonioscopy findings were normal, and the MRI findings were showing vessels exceeding up to the level of optic chiasma and no brain involvement. This suggests of a group 3 kind of retinal AV malformation. The differential diagnosis that I came down to were Sturge-Weber syndrome, vascular tumors, and von Hippel-Lindau disease. The treatment modalities, symptomatic treatment was given, an eye drop, a lubricating eye drop was advised for symptomatic treatment, and since brain was not involved, the further treatment modalities were not very useful in this patient, but in case the might have been involved, then surgical management would have been considered, that is an endovascular embolization, surgery. The complications which can be faced by this patient is epistaxis while tooth extraction, since the palate vessels are also dilated. Central retinal vein occlusion is another complication. Neovascular glaucoma can result, and several complications like subarachnoid hemorrhages or convulsions might result. Patient has been...
Your time for presentation is over. You're exceeding.
Okay, ma'am.
Can you please stop the screen share? And judges, please, you can ask questions you may ask the questions related to the cases.
So how did you manage this case?
Only a symptomatic treatment was given, and other than that, patient was advised to follow up regularly.
What do you expect? You said gonioscopy is normal. Over a period of time, what do you expect in gonioscopy?
Since one of the complications is since the episcleral veins were also prominent, we were suspecting that glaucoma might come as a differential. But since the IOP was normal and the other sided disc was also...
So you would look for blood in Schlemm's canal.
Blood in the Schlemm's canal. Yes,
okay, and IOP was normal?
Yes, ma'am, it was in the normal limit.
Like, what is the role of digital subtraction angiography and what it is? And how is it different from superior or, different to CT angio and all in such cases?
Ma'am, in a digital subtraction angiography, the bones, like the radiopaque structures like bony prominences are removed from the film, from the screen. So only the vessels are like focused on. So that will help us in focusing on the vessels clearly.
Okay, so if the patient develops later on neovascular glaucoma or high pressures, how would you how frequently would you follow up this patient, and how will you look for and manage?
The patient should be followed up in every 3 months, and in every visit the intraocular pressure and the gonioscopy should be done. And fundus examination is advised again 3 monthly, so that if there is any progression in the dilated in the tortuosity, and if the more area of the fundus is being covered, so we can, and to avoid and we should not miss any new vascularization that might occur because of obstructions.
Is there any role of beta blockers, systemic, or propranolol in these AV malformations?
Not that I've heard of.
The discussion time for the case is finished, so can we please proceed to the upcoming presentation? Dr. Mehak, can you please stop sharing your screen?
Yes, ma'am.
Thank you for your case presentation. Now, your screen is still on. Dr. Mehak? Dr. Mehak, can you please stop sharing your screen? Okay, so now we have presentations from Index Medical College. So the mentors are Dr. Sonali ma'am. She is currently the professor and HOD of the Department of Ophthalmology there, also director of Drishti Vision Eye Hospital in Indore. She's been a speaker in various state and national level ophthalmology conferences. And the second mentor for their cases is Dr. Supriya Mushrif ma'am, associate professor at the same college. And her field of interest are medical retina, cataract surgery, also co-guide to the thesis, active in UOC and DOS. Their PGs who will be representing Index are Dr. Mansi and Dr. Akshita. So I request Dr. Mansi to please start her case. And meanwhile, Dr. Akshita, please be ready with your first slide. Don't share the screen yet. Dr. Mansi, you can go ahead, please.
Ma'am, am I audible?
Yes.
Okay, ma'am.
Your time.
Ma'am, hello.
Yeah, please start your case. Your
Okay.
time has started.
Okay. Good afternoon, respected seniors. I am Dr. Mansi Kechri, PG resident, second year from Index Medical College. First of all, I would like to thank my mentor, Dr. Sonali Mittal, for her constant support. So here I am going to present a case on retinitis pigmentosa. First of all, chief complaints. An 18-year-old female resident of Pithampur came to ophthalmology OPD with chief complaints of diminution of vision at night in both eyes since 1 year, frontal headache on and off since 1 year, history of presenting illness. As narrated by my patient, she was apparently all right 1 year back. Then she noticed diminution of vision in both eyes, which was gradual in onset, progressive, painless in nature, and was more at night. It was associated with frontal headache, which was intermittent and not associated with nausea, vomiting, or photophobia. There was no history of any hearing defects. A past history, she had a history of spectacle use in 7 months, not using them regularly. There was no history of any drug intake for any systemic illness, and no history of any head or eye trauma, no history of any systemic illness like hypertension, diabetes mellitus, asthma, tuberculosis, or syphilis, no history of any eye surgery or any eye drop installation. Her family history, history of consanguineous marriage was present in the family. Her father also had similar complaints, and she had 3 siblings, 2 brothers and 1 sister. Her younger sister also had similar complaints. Personal history, diet was mixed, appetite was normal, bladder bowel habits were regular, sleep was regular, and no history of addiction was present. General examination, Patient has an average build and is well oriented to time, place, and person. There were no skeletal anomalies like polydactyly were observed. Cyanosis, pilar, icterus, clubbing, lymphadenopathy, and edema were not seen. On ocular examination, head posture was straight, face was bilaterally symmetrical, extraocular movements were full in all 6 cardinal gazes, uncorrected visual acuity in both eyes was 6/60 with pinhole 6, which was improving to with pinhole to 6/24. Near vision was N9 in both eyes, and best corrected visual acuity in right eye was 6/24, and in left eye it was 6/24 partial. Near it there was no acceptance. Eyebrows present at same level with normal cilia, lids and lashes were normal, and lacrimal sac area, Ropla's negative in both eyes. On ocular examination in anterior segment, conjunctiva, cornea, and sclera were normal. Anterior chamber grading was Van Erich's grade 4. Iris was normal in color and pattern. Pupil was central circular and reactive to light. Lens was clear in both eyes, and intraocular pressure was 16 mmHg in both eyes by Goldman applanation tonometry. On dilated fundus examination, in both eyes, media was cleared, disc was pale disc, circular disc, distinct disc margin, cup disc ratio was 0.3:1 in both eyes, macular foveal reflex was present, retinal blood vessels, arterial attenuations were present in both eyes, peripheral fundus, multiple hyperpigmented bony spicules were present in mid-peripheral retina in both eyes. Investigations, keratometry was done. In right eye, it was 44.25 at 180 degrees and 45.50 at 20 degrees. In left eye, it was 44.50 and 45.50. Color vision was tested using Ishihara chart, and patient was able to read all sides of Ishihara chart correctly in both eyes. Perimetry was performed using Humphrey field analyzer, but it was inconclusive in both eyes because the patient was not cooperative. Other investigation which could be done, but we didn't do these, were full field ERG, EOG, and dark adaptometry. In full field ERG, it would have shown reduced photopic rod and combined responses. In EOG, it is subnormal with absence of light rise, and in dark adaptometry, prolonged in equivocal cases. These are the fundus pictures of both eyes. In the right eye, there was a pale disc. Arteriolar attenuations were present. Multiple hyperpigmented bony spicules were present in right eye, and in the left eye also pale disc arterial attenuations and multiple hyperpigmented bony spicules were retinitis pigmentosa. It could be retinitis pigmentosa, trophy, choroidemia, labor, congenital amyloidosis, drug toxicity due to thoridazine, infections, or pond root dystrophy. My definitive diagnosis was bilateral apical retina. Why? Because it had a triad of pale disc, arteriolar attenuations, and multiple hyperpigmented bony spicules which were present. Atypical retinitis pigmentosa is usually associated with other syndromes which were not present in this patient. Vitamin A deficiency also presents with night blindness, but the fundus picture would be relatively normal. Why not gyrate atrophy? Because there are chorioretinal lesions which would be noted in the periphery which were not present in this patient. Choroidemia and cone root dystrophy usually involve the macular area first, then the periphery of the retina is involved. And in the Leber's congenital.
5 minutes are over.
Okay, ma'am.
I request the judges to please ask questions regarding the case.
How much was the vision of this patient?
Ma'am, 6/60 with pinhole 6/24.
Okay, so eventually these patients lose vision over a period of time. So how do you plan rehabilitation of patients of retinitis pigmentosa?
Ma'am, in this particular case, thankfully the vision is still in that range that we have prescribed spectacles in this patient. Other than that, for the visual rehabilitation, what we can do is we can counsel the patients for low vision aids. Like in these patients, there are recently night vision telescopes which we can tell this patient in the early stages if the vision is near to 6/60 or less than 6/60. If the vision has significantly deteriorated, we can also advise these patients for magnifiers and closed circuit PVs
which they can use. And we also counsel these patients for regular follow-up in order to detect the treatable vision threatening complications, because there are certain complications like open angle glaucoma, posterior subcapsular cataract, keratoconus, which can develop in these patients. So regular follow-up is must. And we should also counsel the patient regarding her profession as per her vision. And we should also avoid such kind of patients not to have any consanguineous marriage, not to have consanguineous marriages. And if in case she does, then there should be a proper screening.
So what are the recent development in terms of the, because it's a genetic disease, gene therapy and retinal implants and yeah.
Yes, yeah.
So
Ma'am, exactly.
Can you throw some light on the use and availability of such implants, prostheses, as you have mentioned, Argus retinal prosthesis? So is it available and is it feasible?
Ma'am, definitely gene therapy is the first thing which is rapidly going on. In Leber's hereditary amaurosis, it is mainly due to RPE65 gene. So there is an adenovirus aided transfection of RPE gene, and it has been said that if we give it for once, then the patient can get improved. And secondly, about Argus retinal prosthesis and alpha MS, yes, definitely they are available, but they are not feasible. And also they are under trials, and there are a lot of many complications which arise from their use. So yes, they are still under trials. But yes, they are
Argus retinal prosthesis is approved, FDA approved, and some patients have received. In not in India, it is not, of course, available, but in US and all.
Okay, ma'am.
Mansi, in your examination, did you check the color vision of the patient?
Yes, ma'am. We did examine the color vision. Patient done using chart, and patient was able to read all the lines.
Okay, so what is the importance of color vision in your case in retinitis pigmentosa?
Ma'am, basically, if the macular area gets involved, so there will be a defective color vision in such kind of patients, and basically we also can differentiate between the macular cone rod dystrophy, because what I am seeing in my case is that it is a rod cone dystrophy. So cones will be definitely involved, but in later cases, and in cone rod dystrophy, macula will be involved first, so color vision will be affected first. So we can help that in differentiating it.
One more point
for discussion. Okay. All the things still here, please, Dr.
No, that's all. I just wanted to point out that in any retina case, you should always represent the fundus picture on an Amsler's chart. In this, you only showed the findings. As a retina person, I would always want to see how it looks. So either presenting photographs or putting it on Amsler's chart will be effective. That's all.
Okay. Thank you, ma'am.
And one more thing, one investigation that you have to tell patient for which you want to follow up your patients on.
Ma'am, OCT macula.
For retinitis pigmentosa, something else maybe?
Ma'am, what could be?
You just want a good fundus picture. So you ask the patient for every follow-up, whenever the patient comes, just get a fundus picture done. Generally you can follow up the patient, because these patients sometimes they progress, and you have to catch those patients, who are progressing, so that you can counsel them, and you can, give them like low visual aids, or you can tell them that not to go out during the evening time and all those things. So a good fundus picture is very important.
Okay, ma'am.
Of course, apart from your electrophysiological tests like ERG and all. Yeah.
Nice presentation, Mansi, and smart way to share the slides during answering. And also for your curiosity to ask about the last question. So, Dr. Akshita, are you ready?
Yes, ma'am. Am I audible?
Yeah, you are audible. And Dr. Mansi, can you please stop sharing your screen so that we can have Akshita over?
Ma'am, I've stopped sharing.
Yeah. Akshita, I can see you right now. Yeah.
Good
Please start.
afternoon, everyone.
Not able to see your presentation. Yeah. On your full screen here.
Ma'am, may I start?
Yeah. Can you switch to the full screen mode? Yeah. You may start, please.
Good afternoon, everyone. Before starting, I would like to thank the former members of WOS for giving me this platform. My patient is a 26-year male student of Indore who presented to our OPD with chief complaints of diminution of vision in both eyes since 12 days, which was painless, sudden in onset, and progressive in nature. There was no history of floaters, flashes, trauma, constipation, or he did not give any history of lifting heavy weight or wearing spectacles. He was a known case of hypoplastic myelodysplastic syndrome without any history of hypertension, diabetes, TB, or asthma. There was no history of any eye drop installation. My patient had repeated transfusion of red blood cells, and he was a documented case of allergy to paracetamol. His personal history did not reveal anything significant, and no member in the family had any similar complaints. On general examination, we realized that our patient, although was well oriented to time, place, and person, but he was unable to stand or sit on his own. He had come to OPD on wheelchair, and he had severe pallor. Other findings were within normal limits. On ocular examination, we saw that the best corrected visual acuity in right eye was 6/60 and in left eye was 5/60. Head posture was maintained, facial symmetry was maintained, ocular movements in both the eyes were present in all the cases. The anterior segment findings in both the eyes were within normal limits. Intraocular pressure by Goldman inclination tonometer was 14 millimeter of mercury and 16 millimeter of mercury in right and left eye respectively. We dilated the patient, and dilated fundus examination was performed with the indirect ophthalmoscope. The media was clear. The cup to disc ratio was 0.2:1. The disc was normal with circular distinct margin, pink in color with neuroretinal within normal limits. In this dilated fundus photo, I would like to show that over the macula we can see a very well boat-shaped hemorrhage which was dark red in color. It was a subhyaloid hemorrhage, and there were multiple superficial hemorrhages on the posterior pole as well as in the periphery, which were accompanied by rod spots. In the same eye, in the temporal, on the nasal side, we can see another subhyaloid hemorrhage, which was lined by flame-shaped hemorrhages and multiple rod spots in the periphery. The left eye fundus shows a very well circumscribed dome-shaped dark red hemorrhage, which was either subhyaloid or subialum hemorrhage, with multiple nerve fiber layer hemorrhages and rod spots. There were multiple hemorrhages all over the fundus, which covered all the quadrants. In systemic investigations, we found out that the hemoglobin of our patient was as low as 3 gram per DL, and he had a normocytic, normochromic leukocytopenic picture with thrombocytopenia. We did OCT macula. Now, when there are hemorrhages like this, we started from the upper border of the sedimentation of the blood, wherein we saw, as you can see in the middle, there is a hyper-reflective, well-defined oval area, which is superlined by a patchy hyper-reflective membrane, which was the posterior hyaloid, and a single hyper-reflective membrane, which was the ILM, internal limiting membrane. So we realized that this was a posterior or subhyaloid hemorrhage. However, when we scroll down further, we realize that this lesion, which was hyper-reflective, has casted a shadow, and it has actually backshadowed the underlying retinal layer. So it was a subhyaloid hemorrhage, but on scrolling down, we realized it is also an internal limiting sub-ILM hemorrhage. And a similar OCT picture was seen in the left eye, where we can see there is a posterior hyaloid phase by patchy hyper-reflective membrane, the hemorrhage is overlying the internal limiting membrane. However, as we scroll down, there was a backshadowing of the other retinal layers, and it was a sub-ILM hemorrhage. Other investigations that we could not do was fundus fluorescent angiography. We deferred because the general condition of the patient was very poor, and his renal function might have gotten compromised with fluorescent. So my provisional diagnosis was bilateral hyperviscosity retinopathy because of the typical type of hemorrhages, which was subialum and subhyaloid hemorrhages, and because the patient was a known case of hypoplastic myelodysplastic syndrome. Central retinal vein occlusion, but there was no disc edema. Also, the hemorrhages were not typical. The age of the patient, there was no history of hypertension, diabetes, etc. Valsalva retinopathy, there was no history of any Valsalva maneuver. Blunt trauma to the eye was not present, and Jersey syndrome I excluded because there was the patient was well oriented to time, place, and person. So his general condition was very fine. So my diagnosis was bilateral hyperviscosity retinopathy. We could not do the management, but in management, I would like to say we could have done NDR hyalodectomy, in which we should point the laser at the inferior margin of the hemorrhage so that the blood gets drained into the vitreous cavity and then gets absorbed in a span of 1 to 3 weeks. We could have also done pars pana vitrectomy to induce posterior vitreous detachment after ILM biostaining by either infracyanine green or trypan blue and ILM.
Dr. Akshita, your time is up.
Thank you so much.
May I please request the judges to proceed forward with the questions?
I have a lot of questions to ask actually for you. Number one, why did you do this OCT? I mean, you did just for the sake of doing it, or you thought it was necessary?
Ma'am, it was very necessary because we could not differentiate between if the hemorrhages were subhyaloid or sub-ILM. I think fundoscopically it was very difficult for us to judge. So we wanted to know at what level the hemorrhage is. So for that we did.
What the pictures you showed, I thought it was very clear from the fundus picture itself. I mean, if I was there, I probably would have done this OCT. Anyways, now the management you said, I think you had given in general the management of a large subhyaloid hemorrhage, but you are not listing the management pertaining to this case. In this case, I mean, we will never do things like YAG hyalodotomy or pars plana vitrectomy or, you know, all those things. So you just have listed general management of large subhyaloid hemorrhage. I want to know what you have done in this case.
Ma'am, because as I told, the general condition of the patient was not good. He came to us primarily, so we referred him to our emergency medicine department when we came to know his hemoglobin was so low. And they further referred him to the oncology department in other hospitals.
What was the hemoglobin?
Ma'am, 3 grams per day.
3. So, okay, now I come down to my question, the main important question. How did you make this diagnosis of hyperviscosity retinopathy? You don't think it was a case of anemic retinopathy and not hyperviscosity retinopathy?
Ma'am, definitely anemic retinopathy could have been there because of multiple rod spots. But ma'am, in this case, wherein there is hypoplastic myelodysplasia,
so what? I mean, did you do a complete hematological test?
Yes, ma'am. Later, when we had done his viscosity, blood viscosity had come out to be raised approximately 9, wherein it should have been 3.5 to 5.5. So blood viscosity was also increased. We didn't have any documentation. We had actually followed up the patient later on. So we had come to know.
What were the platelets? Did you see the platelets and?
Yes, ma'am. The platelets were low, ma'am. 12,000.
So, I mean, did you consider other things? Probably, had the patient did he give any history of fever, recent onset fever, or any viral illness or anything?
No,
I think you have to rework up your case. I don't agree with this diagnosis of hyperviscosity retinopathy. I mean, there has to be something else. Probably we need to investigate more. I would think more in terms of anemic retinopathy, seeing a lot of rod spots that you saw in your fundus picture. If you go back and see your fundus picture, I don't know what is the opinion of other people, other judges.
Yeah, I think there is a like DD very close to anemic retinopathy in this. So I think maybe further investigations are required, and since the case of leukemia, what is the diagnosis?
It could be some kind of leukemia also.
Yeah,
so you have to investigate the cause of anemia. There could be a underlying cause of anemia. So clinically, what first differential diagnosis you can put as anemic retinopathy. And a lot of times anemia, low platelets, because the patient hydration is probably low, so even that causes hyperviscosity in your hematological test.
Okay, ma'am.
And I think this patient will require more of systemic treatment than
systemic evaluation.
Systemic evaluation and treatment. Then I don't
refer the patient to hematology department. Let hematologist also see all the investigation. Do a peripheral smear, and probably also investigate for some cytomegalovirus or other viral pathology. You never know, even she might had something like a dengue earlier. A lot of times dengue retinopathy also presents in this. I'm just saying on the basis of your fundus picture.
Judges, I would request to proceed forward for the other case. Dr.
But nicely presented.
Yes.
Thank you, ma'am.
Your patient was more like pancytopenic. Sometimes
nice documentation also. Very nice pictures.
Thank you.
Great case. Now I request the judges to continue evaluating the other cases, and I would like to invite Dr. Meeta Joshi ma'am, not only my mentor, but the person who introduced me to WOS in 2016, the very first meeting when I was a PG, and she was my mentor for the case. Dr. Meeta ma'am.
Thank you, Sonam. And we'll continue with the case presentations. Next, we have from Shyam Shah Medical College, Rewa. And the mentor is Professor Anamika Dwivedi, who is the Associate Professor in the Department of Ophthalmology. And we have cases from Dr. Bimlesh Ojha and Dr. Preeti Tripathi. So, are you people ready?
Yes, ma'am. Good afternoon, ma'am.
Yeah, Dr. Preeti, good afternoon. You can start sharing your screen, either of you.
Hello, good afternoon, ma'am. Good afternoon, ma'am. Is it audible?
Yes, yes, Bimlesh.
Good afternoon, ma'am.
Start with your case.
Yes, ma'am. Very good afternoon, everyone. Today I am presenting a case of a 29-year-old male presented with chief complaint of headaches in 7 days and diminution of vision in right eye since 5 days. As per the patient, he was apparently alright 7 days back. Then he developed sudden onset headache, which was dull in nature, persistent throughout the day, and not associated with nausea, vomiting, and fever. Patient also complained of sudden onset, painless, non-progressive diminution of vision in right eye after the onset of headache. And there was no significant past personal and family history. In ocular examination, visual acuity was 624, not improving with pinhole 6 in left eye. Rest of the anterior segment finding in both eye within normal limit. There was no cellular reaction in AC, and AC was quiet. Intraocular pressure of the both eye within normal limit. Fundus examination of the right eye revealed clear media with no evidence of vitritis. Optic disc normal in size, shape, color, and margin. Cup disc ratio was 0.3. Blood vessels normal over disc and elsewhere. On macular examination, fovea reflex was absent. A single yellowish subretinal lesion, approximately half disc diameter in size, and located one disc diameter temporal to the temporal disc margin, accompanied with single intraretinal hemorrhage and an elevated area of 4 disc diameter horizontally and 3 disc diameter vertically, involving fovea suggestive of the neurosensory detachment. Fundus examination of left eye did not reveal any abnormality. With these clinical findings, fundus examination of unilateral solitary yellowish subretinal lesion, we included unilateral acute idiopathic maculopathy, unifocal choroiditis, atypical Vogt-Koyanagi-Harada disease, and choroidal neovascular membrane. Furthermore, due to the presence of single intraretinal hemorrhage, solitary choroidal granuloma with retinal angiomatous proliferance also included. Because of neurosensory detachment, idiopathic central serous chorioretinopathy also considered. In macular function test, absence of central line in ancillary test suggestive of the central scotoma. OCT of the right eye showing hyporeflective space below the neurosensory retina suggestive of neurosensory detachment, and hyporeflective space also found between inner and outer segment in photoreceptor layer suggestive of bacillary layer detachment, and CMT was 718 micron. All these findings better visualized in HD raster image, additionally with choroidal elevation and a hyperreflective line suggestive of the RPE thickening. Both high choroidal thickness with the normal limit in B scan. In FFA of the right eye, in early venous phase, a hypofluorescence lesion which was corresponding to yellowish lesion in fundus, persistent throughout the late phase and surrounded by a hyperfluorescent ring-like structure, and there was a pooling of dye in the subretinal space also found. FFA of the left eye was essentially normal. So after completing all ancillary investigation, we made a proper diagnosis of acute idiopathic maculopathy and atypical VKH disease. All lab investigation, including chest X-ray and Montu test, were within normal limit. And when we assessed our patient for systemic association on neurological, auditory, integumentary, as well as pulmonary examination, they did not reveal any positive findings. So we kept as an inflammatory entirety in our mind. Treatment started with the pulse therapy methylprednisolone for 3 days, followed by gradual tapering of the oral prednisolone, and patient was evaluated on day 1, day 2, and day 4. There was a progressive resolution of the subretinal fluid and bacillary layer detachment, and CMT was gradually decreased. And after treatment, a drastically resolution of the subretinal fluid, but hypofluorescence lesion persists till end. At last follow-up, at 3rd week, as compared with the day 1, visual acuity was improved up to 6.6, and nearly resolution of the subretinal fluid. Only residual fluid seen in OCT. In raster image, there was flattening of the choroid, but hyperreflective line still persists, suggestive of RP thickening, and a hyperreflective dots present in RP layer. So my final diagnosis is right eye acute idiopathic maculopathy, which was first described by Yanuji et al. In 1991. A rare RP disease affects young adults, presented with sudden onset vision loss, yellowish lesion associated with single intraretinal hemorrhage, similar with our case, and hyperreflective thickening with subretinal fluid and bacillary layer detachment in OCT, and central hypofluorescence, which was surrounded by single ring-shaped hyperfluorescence and pooling of the dye in subretinal space in FFA, also found in our case, and they describe as this is a self-limiting condition. Thank you.
Thank you for finishing quite on time. Over to the judges.
So your DD was atypical VKH. So findings you'll get in VKH.
Ma'am, a single yellowish lesion choroiditis, and neurosensory detachment and pooling of the dye in FFA, early hypofluorescence and pooling of the dye in subretinal space. In OCT, bacillary layer detachment. Bacillary layer detachment is a characteristic feature for VKH. Ma'am,
No, it is just you're talking about the retinal features. Because VKH mostly is a pan uveitis.
Yes,
what are the features and associated systemic features also?
Systemic features मैम neurological examination में मैम meningismus मिल सकता है, उसमें auditory symptoms मैम tinnitus मिलता है, sensory neural hearing loss मिलता है, और integumentary examination करने पे मैम उसमें vitiligo, alopecia, poliosis मिल सकता है मैम integumentary examination में.
So in your case, did you have any systemic associations? The case
yes,
you presented?
No मैम, सिस्टेमिक एसोसिएशन उसमें एग्जामिन करने पे मैम सब नॉर्मल मिला मैम, उसमें सिस्टेमिक एसोसिएशन नहीं थे, इसलिए वीकेएच को लॉक किया मैम. और यूनिलेटर जनरली मैम वीकेएच बायलेटरल प्रेजेंटेशन होता है मैम, इस केस में यूनिलेटरल प्रेजेंटेशन, इसलिए एटिपिकल वीकेएच रखा है.
So you did consider CSTR as your differential diagnosis?
मैम CSTR में मैम न्यूरोसेंसरी डिटैचमेंट मिल रहा है, इसलिए मैंने उसको डिफरेंशियल डायग्नोसिस में लिखा मैम. लेकिन FFA में उसमें मैम डॉट इनलार्जिंग डॉट साइन, इंक ब्लॉट अपीयरेंस, एंड मैम उसमें स्मोक स्टेक अपीयरेंस मिलता है CSCR में, और इसलिए CSCR को उसमें रूल आउट किया।
No, but atypical CSR, you do see some other angiographic features also.
Yes, ma'am. Sorry, ma'am.
In atypical CSCR, you do see some, different type of. It's not necessary that always you say that you see ring or smoke stack appearance on FFA.
मैम PD CSCR में मैम PD पिगमेंटेड एपिथेलियल डिटैचमेंट मिलता है मैम, इसमें PD भी प्रेजेंट नहीं था, इसलिए नॉर्मली मैम CSCR के केसेस में मल्टीपल PD मिलते हैं।
PD नहीं हो सकते CSCR में?
मैम CSCR में हो सकते हैं मैम, VKS में मैम। यस मैम।
But in this case, in your OCT, you did have PDs also, no?
No मैम, PD नहीं।
I think एक तुम्हारे OCT में शायद there was a PD.
No ma'am.
नहीं, maybe I was mistaken. So you didn't consider intravitreal, any kind of intravitreal management, intravitreal agent, India management?
No मैम, उसमें मिथाइल प्रेडनिसोलोन पल्स थेरेपी इन्फ्लेमेटरी इंटाइटी कंसीडर किया था मैम इनिशियली, इसलिए उसको पल्स थेरेपी मिथाइल प्रेडनिसोलोन स्टार्ट किया था। लेकिन मैम एक दिसंबर 2021 में एक पेपर पब्लिश हुआ जिसमें एक्यूट इडियोपैथिक मैकुलोपैथी उन्होंने डिस्क्राइब किया है। मैम उन्होंने ये बताया कि ये सेल्फ लिमिटिंग कंडीशन है और उसके जितने भी फीचर्स हैं वो सारे सिमिलर हैं हमारे केस में, तो हो सकता है मैम कि वो एक्यूट इडियोपैथिक मैकुलोपैथी रहा और वो सेल्फ रिजॉल्विंग कंडीशन रहा हो, विदाउट ट्रीटमेंट भी वो इम्प्रूव कर सकता था।
So why did you consider IV methyl prednisolone?
मैम क्योंकि पहले डायग्नोसिस मुझे इन्फ्लेमेटरी इंटाइटिस जैसे मैम VKH जैसे ट्रीट किया था, तब हमें उस टाइम पे पता नहीं था मैम कि एक्यूट इडियोपैथिक मैकुलोपैथी के बारे में, तो उस टाइम पे VKH सस्पेक्ट करके ट्रीटमेंट चालू किया था।
And patient improved immediately after that?
Yes ma'am, improved after 20 days. 24 डे पे मैम उसका फॉलोअप किया था, मैम इम्प्रूव हुआ था उसका, मतलब विजुअल एक्यूटी 6 हो गया था और सब रेटिनल फ्लूइड भी रिजॉल्व हो गया था, ओनली रेसिडुअल फ्लूइड था।
And spontaneously, if it resolves spontaneously, as you're saying, how much time it takes to resolve?
मैम जो पेपर पब्लिश हुआ है उसमें मैम 28 डेज का दिया है कि सब रेटिनल फ्लूइड रिजॉल्व हो जाता है, केवल हाइपर रिफ्लेक्टिव डॉट्स रह जाते हैं, उसमें हाइपर रिफ्लेक्टिव डॉट्स मिलते हैं और RP थिकनिंग रह जाती है, और रिजोल्यूशन ऑफ द आउटर रेटिना की जो थिकनिंग होती है वो रिजॉल्व हो जाता है 28 डेज के फॉलोअप में। और VKH में मैम ऐसा होता है कि VKH का ट्रीटमेंट में जो ओरल स्टेरॉइड है वो 4 to 6 वीक करते हैं, फिर उसके हायर डोज में उसके बाद 6 मंथ तक उसको कंटिन्यू रखते हैं अगर VKH रहता है।
VKH IV MP दे सकते हैं, oral VKH also you can give IV MP, not necessary.
Yes ma'am, 3 days के IV MPSL देते हैं, 3 days pulse therapy, उसके बाद oral.
So any chemo, sorry that thing, treatment, azathioprine or anything?
Yes ma'am, immunosuppressant therapy भी देते हैं फिब्रोल मैम। Yes ma'am, cyclosporin, mycophenolate mofetil, azathioprine, immunosuppressant भी दे सकते हैं।
Can we move on to the next case then?
Okay.
Thank you so much, ma'am.
Thank you so much. Dr. Preeti, are you ready? Please share your screen.
Sure.
Hello, good afternoon, everyone. Am I audible? Is my slide visible?
Yes, you are audible and visible.
Good afternoon, everyone. I am going to present the case of a 42-year-old male patient presented with chief complaint of left eye extension of vision since 2 days. He was attending to outright 4 days back. Then he noticed left eye diminution of vision, which was sudden, non-progressive, and painless.
Vimlesh, please mute yourself.
There was no significant past and family history. He gave used for cigarette smoking since last 10 years. He used to smoke 1.5 packet cigarette daily. His general and systemic examination was unremarkable except for his basal metabolic index, which was 32.1, which shows obesity. In his ocular examination, anterior segment finding was normal in right eye, while in left eye his visual acuity was 660, which did not show improvement with pinhole, and there was presence of relative afferent pupillary defect in anterior segment. In fundus examination, his right eye fundus was normal, while his left eye fundus shows clear media with no signs of vitritis, and there's blurring of disc margin with few superficial hemorrhages seen over the disc, along with the fluffy yellowish white lesion, ill-defined lesion seen over the disc as well as along the vessels. There are few superficial hemorrhages seen in the peripapillary region, and there is obliteration of physiological cup. Arteries show arteriolar attenuation, as well as there is dilatation and tortuosity in veins, and there are few blurred hemorrhages seen in the along the vessels as well as in the general fundus. In macula, there is foveal reflex was absent, and there are multiple perivenular dirty white deep retinal lesion seen at the macula. After this comprehensive ophthalmic examination, I keep these diseases as my differentials. Left eye non-ischemic CRVO with associated paracentral acute middle maculopathy. Left eye central retinal vein occlusion with transient central retinal artery occlusion. Left eye inflammatory vasculitic CRVO, and left eye CRVO with acute macular neuropathy. In FFA, in arterial phase, arteries show no abnormalities, while in venous phase there is delayed in venous filling seen, and there are multiple areas of hypofluorescence seen in the venous phase, which correspond with the fundus finding superficial hemorrhage which was seen in the fundus, and in the late phase there is a few leaky hypofluorescent lesions seen, and there was no finding in FFA seen which correspond with the those deep retinal lesions seen in the fundus. In OCT image of left eye, OCT shows normal vitromacular phase with no signs of macular edema, and there is hyperreflectivity of inner retinal layer, and the corresponding SD raster image shows multiple patchy hyperreflective lesion seen in the inner nuclear layer, which probably could be because of ischemia of deep capillary plexus, suggestive of paracentral acute middle maculopathy lesions. While in the second HD raster image, which was taken over the fluffy lesion on the vessels, there were increased reflectivity of inner nuclear layer along with the elevation of retina, suggestive of cotton wool spot. Emphase OCT image of left eye was also taken, which shows multiple hyperreflective fern-like lesion seen, which is again suggestive of paracentral acute middle maculopathy lesion. And this scan was taken from the mid retina. OCT image of right eye was within normal limit. Laboratory investigation of my patient was within normal limit. So after this detailed examination of my patient, my probable diagnosis is right eye within normal limit and left eye non-ischemic CRVO with associated paracentral acute middle maculopathy. And we kept our patient under observation and asked him for regular follow-up, and we advised him to quit smoking as well as lifestyle modification with weight reduction. In first month follow-up, his left eye visual acuity reaches up to 612 partial with no improvement in with pinhole, and there is still RAPD present. And in SD raster imaging, there is a complete resolution of those fluffy lesion, as well as there is thinning of inner nuclear layer. While in Emphase imaging OCT, there is partial resolution of those hyperreflective fern-like lesions. While at third month follow-up, visual acuity of left eye reaches up to 6.9 partial with no improvement in pinhole, and there is still RAPD present in the left eye. There is no obvious finding seen in the fundus, and in HD raster imaging of left eye shows marked thinning of inner nuclear layer. This novel finding of PAM lesion associated with non-ischemic CRVO was first described by Sharaf et al. In 2013, and in recent publication they have shown an increased incidence of these PAM lesion in retinal artery occlusive diseases, and there is association of cigarette smoking also been identified as a risk factor, similarly as seen with our case, and there is a role of Emphase imaging also been highlighted in the diagnosis of these PAM lesions. Thank you.
Thank you very much, Dr. Preeti. Over to the judges.
Thank you, ma'am.
You did angiography, fluorescein angiography, no?
Yes, ma'am.
I think somehow I missed. Can you show me the Can you just tell me the FFA findings again?
Ma'am, there was normal arterial phase and there is delayed in filling of veins, which shows venous obstruction, as well as there are multiple areas of hypofluorescence which correspond with those superficial hemorrhages seen in the fundus.
Just tell me the salient positive findings. No, don't give me
And
so
ma'am,
much detail.
and there was positive finding, like there is a delay in filling of veins, which shows evidence of there's some type of venous obstruction in the vessels.
Did you see any leakage? Did you find any leakage?
Ma'am, there is no obvious leakage in the fundus, but there are few points of leakage at the seen in the later stages. Few points of one and two.
Those were just leakages, or those were just staining of tissues?
Ma'am, they could be staining, because there is no obvious leakage point seen in the fluorescent angiography.
So I'm asking you leakage, so you have to understand the difference between staining and leakage.
Ma'am, there is no obvious
thing.
there is no obvious leakage seen.
Any non-perfusion areas did you find?
No, ma'am, there is no non-perfusion areas.
But you said there is delayed in filling. So didn't you investigate this little more, that why there was delayed in filling of
Ma'am, I investigated my patient.
So what investigation now you would like you would have in mind?
Ma'am, just keeping CRO as a bidifferential, I advise my
CRO?
patient. Ma'am, as these obstruction, as my patient is a smoker and obese, there is a probability of atherosclerotic changes in the vessels. So I advise my patient for 2D echo as well as carotid Doppler, which shows no abnormalities.
So you have to go in for a Doppler imaging, maybe a carotid Doppler, or you would like to do a Doppler MRI angiography also,
Yes, ma'am.
Color-coded MRI angiography. So you have to go into the vascular imaging now.
Yes, ma'am.
Okay, which you haven't mentioned earlier.
Yes, ma'am.
So basically, your management. What did you do for management?
I kept my patient under observation and advised him for lifestyle modification, as well as advised him to quit smoking. And it shows the drastic changes in the fundus finding, as well as his visual acuity improves up to 6/9 partial.
Preeti, what is PAM?
Ma'am, PAM stands for paracentral acute middle maculopathy, which basically caused due to ischemic changes seen in the deep capillary plexus, which are located at the junction of outer plexiform layer and the inner nuclear layer. So, due to ischemic changes in deep capillary plexus, there is ischemic changes seen in the inner nuclear layer, which appears like a hyperreflective band-like lesion seen in the inner nuclear layer.
So how did you differentiate it from on fundoscopically from cotton wool spots?
Ma'am,
could you make them out fundoscopically?
जी मैम, I did fundoscopy and cotton wool spots are a superficial finding. They are more white, fluffy, ill-defined lesions, while the PAM lesions are more deeper. They are located in the nuclear layer and they are dirty white in color. So,
why did you include it in your diagnosis? Does it change your management in any way, or is it just a non-specific finding in any vascular disease?
जी मैम, sorry, I'm not able to hear.
You included PAM in your diagnosis. We diagnose as ischemic or non-ischemic CRVO because of its prognostic value. Okay?
Yes, ma'am.
So, including PAM in your diagnosis, does it change your management in any way? Why did you include it in the diagnosis?
Ma'am, since it is a noble finding which was recently diagnosed in the year 2013, and this finding comes, I have seen this finding in my patient. That's why just I included into my diagnosis. Otherwise, this is a non-ischemic CRVO. My patient is of non-ischemic CRVO and associated PAM lesion.
So PAM is a finding which can be found in any
cases of
event
yes,
which is
ma'am.
affecting retina and is a non-specific finding.
Yes, ma'am.
Okay, and I don't think there is any prognostic value to it. Maybe they have good prognosis. That might be there.
Ma'am, in one literature I found that patients which have TAM lesions, they will not reach normal visual acuity. There is some lack in the normal visual acuity just because of ischemic changes, permanent ischemic changes in a nuclear layer. So although it is a finding, but it will affect a patient's visual acuity.
Can we move on to the next talk now? Dr. Ashu, you had a query?
Dr. Meeta, your
Okay,
mic is
sorry. The next team is from Dr. R.D. Gadi Medical College, Ujjain, Dr. Apurva and Dr. Akshat. And they are mentored by Dr. Shubhra Mehta. And she is one of the silent leaders in WOS, and they have a wonderful team in Ujjain with a lot of female ophthalmologists who work for medical conferences also and for the PCs also. Dr. Akshat, please share your screen.
Yes, ma'am. Ma'am, is it visible?
Yeah.
Yeah. Good afternoon, everyone. Respected judges and my colleagues. Myself, Dr. Akshit Gupta, I'm going to represent a case of 70-year-old male from village Surasa district, Ujjain, was admitted in R.D. Gadi Medical College with the complaints of diminution of vision in right eye since 6 months, pain in right eye since 2 months, redness in right eye since 2 months, and watering in right eye since 2 months. My patient was apparently all right 6 months back. Then he experienced diminution of vision in right eye, which was gradual and progressive. He complains of pain in right eye since 2 months, which is severe in intensity, associated with right-sided headache and blowing. The pain is associated with episodes of nausea and vomiting, which is aggregated at night. The patient has taken eye drops and analgesics from local hospital, which provided partial and temporary pain relief. He also complains of redness and watering in right eye since 2 months. He underwent left eye cataract surgery 2 years back in eye hospital Maksi. There is no history of trauma or any surgery in right eye. Was using a spectacle since 2 years for distance vision and not using any spectacles for near vision. He is diabetic since 10 years on irregular medication with poor glycemic control. He has a history of hypertension since 6 months. On examination, his visual acuity in right eye was PL negative. Left eye was 636 with pinhole vision 624 and restricted visual acuity 624. And area vision in both eyes was entered. In left eye was entered. Intraocular pressure with apprehension tonometry, right eye 43 mm Hg of mercury, and in left eye was 12 mm Hg of mercury. Ocular alignment, right eye exotropia at 45 degree according to Hirschberg corneal reflex test. Eyebrow raised, both eyes. Senile ptosis more in right eye than left eye. Right eye congenital circumcorneal conjunctival congestion was present. Corneal stromal idea with diffuse microbulli. Pannus at 11 and 1 o'clock. Endothelial dusting posterior inferior and nasally. Left eye cornea was clear. Anterior depth was normal. Anterior depth was normal in both eyes. In right eye, iris superior iritis with neovascularization present around the pupillary margin extending from 4 o'clock to 8 o'clock position with posterior synecdoche at 2 o'clock. Left eye iris was normal in color and pattern. This is a cross-section view of cornea and anterior segment right eye. In this, we can see pannus is superiorly, microbulli at epithelium of cornea, posterior synecdoche at 2 o'clock, neovasculation pupillary margin and neovasculation at angles. Right eye pupil was non-reacting, semi-dilated and fixed. Left eye was reacting to right and circular. Right eye lens was nucleus close grade for according to log streak with streaks of iris pigmentation from 11 o'clock to 2 o'clock position. Left eye pseudophakic with posterior capsular occlusion. On fundus examination, there was no fundus present. Seen on left eye, moderate non-proliferative diabetic retinopathy was seen. This is left eye fundus showing dot hemorrhage, exudates, and microaneurysms. On right eye gonioscopy, right eye open angle in all quadrants with neovasculation at inferior and nasal sides. In left eye, angle open in all quadrants. On investigation, his blood sugar levels are deranged with FBS 186 mmHg per deciliter, PPS 320, HbA1c 10.4, and sugar 1 piece in urine. Rest is normal. On ocular investigations, tonometry, right eye 43 mm Hg pressure, left eye 12 mm Hg of mercury, syringing was patent, corneal sensation was diminished, fluorescence angiometry was negative, and B scan shows vitreous hemorrhage. Other investigations which can be done are ASOCT, ultra biomicroscopy, and iris angiography. With this, we conclude that our patient has right eye neovascular glaucoma, open angle stage with immature senile cataract with vitreous hemorrhage. Left eye has pseudophakic with posterior capsular occlusion with moderate non-perfect diabetic retinopathy. So first differential diagnostic solution was absolute glaucoma of primary open angle closure, but as on gonioscopy angle is open and there is neovasculature present, we excluded this diagnosis. Second is uveitic glaucoma, but there was no capillaries, no cells or no flares. And third is lens-in glaucoma, but lens was not instrument, not hypermature, and there was neovascularization of iris and angle. So
Please move on to discussion now.
Yeah, so we started with treatment of.
You'll have to stop sharing your screen now.
Yep.
Okay, so patient of neovascular glaucoma.
Yes.
So why, as you mentioned, the gonioscopy, the angles were open.
Yes.
So why the pressures were so high, 43?
And pressure was high as there was a neovascularization at the angles and the margins.
Neovascularization in two angles.
Yes, ma'am. At inferior and nasal
normal.
side.
Okay. So was there a lot of inflammation?
No, ma'am. There was not. There was endothelial dusting present at the corneal endothelium.
Why the pressures are high in case of neovascular glaucoma? And in which stage it becomes intractable? What is the mechanism?
Ma'am, because of ischemia in any kind of ischemia in retina, there is a factors VGF which leads to proliferation of vessels at the iris, which leads to fibrovascular membrane at the angles, which occluded the angle. And
No, but in this case, I am just talking about your case, open angle. Yet the fibrovascular membrane has not occluded the angle as yet. They were just NVA. Okay, so in such case, why the pressures would be high? So, what management will you do in such cases?
In this first we reduce pressure by giving tablet acetazolamide. Then we started with the combination of brimonidine and timolol. Then we have planned as the patient is blind and eyes painful, we have planned for cyclocryotherapy.
No. I think you are because this patient is not in any case having that much of high pressures also, and patient is not blind, vision is good. Although there is cataract, pressures are high, there is glaucoma, there is inflammation. So you are not going to go for cyclophotocoagulation in such patients. So what is the strategy? Like as you're saying, that there is iris neovascularization and angle neovascularization. So what treatment will you do? Will you refer the patient to retina specialist? Is there any other management, PRP or some kind of anti-VEGF agent?
First, we can give PRP. If patient has a vision, then we can give PRP. First line of treatment will be PRP to reduce the ischemic effects. Then we can give anti-VEGF, and then we can plan for a surgery.
But in this patient, PRP may not be possible. You said no, you couldn't.
Couldn't see the fundus, yes.
So what strategy you adopt in this particular patient?
As the patient is blind, this is PL negative patient, so we have planned for cyclocryotherapy.
Patient has PL negative?
Yes, ma'am.
What is the reason?
That's what I was just about to ask you, that how could you do a PRP in such patients?
Yeah. No, but the angle is not completely closed. Yes. I don't understand the reason PL negative. Because of, I don't know whether the pressures have been high for quite some time, but then I don't expect pressures to be so high in an open angle, more or less open angle. Okay, if angle was closed, then it would have been expected that the pressures would have been very high and the PL may have become, but I don't know. Something is
Are you
missing
sure
somewhere.
you haven't missed any NVG? There must be some, there might be some vessels in the angles.
Can we move on to the next case, please? We are running short of time.
There are urological angles.
I think it's just that the cause of glaucoma, it's a secondary glaucoma. It's not primary, and the cause of glaucoma lies in the diabetic retinopathy that the patient has. So the patient has probably PDR, which is hemorrhage, and then maybe CRAO or one of those. That's why the vision is lost, and it can't just be the NVG.
Okay. Yes.
Dr. Apurva, are you ready?
Hello. Good afternoon, ma'am. Am I audible?
Yes, you are audible. Please share your screen.
Is it visible now?
Yes.
Good afternoon, everyone. I'm presenting a case of 60-year-old female who is a resident of Rajgarh and a housewife by occupation who came in OPD, IOPD of RD Medical College, Ujjain with following chief complaints. Diminution of vision in right eye 6 months, foreign body sensation in right eye since 3 months, watering in right eye since 3 months, ocular pain in right eye since 1 month. History of present illness. My patient was apparently all right.
That's why you need to go to full screen and go to the slideshow.
Is it visible now?
Yes.
History of present illness. My patient was apparently all right 6 months back when she experienced diminution of vision in right eye, which was progressive in nature and initially painless. The diminution of vision was typically worse in the early morning and improved as the day progressed. Since 3 months, my patient has also complained of foreign body sensation, which is associated with watering from right eye. The patient has complained of ocular pain in right eye since 1 month, which is pricking in nature. Past ocular history, no history of any ocular surgery in past, no history of wearing glasses in the past. Personal history, no history of hypertension, diabetes, mellitus, COPD, thyroid, or any other systemic disorder, not allergic to any medication. Bladder and bowel movements were unaltered. Sleep pattern was normal. On ocular examination, visual acuity was 2/60 in right eye, 6/24 in left eye. With pinhole, it was 6/60 in right eye and 6/9 in left eye. Near vision with glasses, it was 6/18 in right eye and 6 in left eye. Head posture was normal, eyebrows were normal, lids normal, lacrimal apparatus was patent. Ocular movements were present in all quadrants, conjunctiva normal, sclera normal. On cornea, we found epithelial microcyst diffusely present, ruptured bullae present on lower quadrant, stromal edema and haze present, endothelial gutted changes seen in right eye. In left eye, central gutted changes present. Anterior segment was normal in both eye. Iris normal in color and pattern. Pupil central circular reacting to light in both eyes. Lens grade 3 in nuclear color and opalescence. Fundus was within normal limits in both eye. This is right eye showing diffuse corneal edema, epithelial microcyst, and ruptured bullae. This is slit view. Left eye. This is left eye showing central gutted changes. On ocular investigation, intraocular pressure by attenuation tonometry, it was 19 mm Hg in right eye and 14 mm Hg in left eye. Corneal thickness was 0.617 mm in right eye and 0.518 mm in left eye. Endothelial cell count by specular microscopy, in right eye it was not recordable. In left eye it was 2224 per mm square. Corneal sensation was normal in both eyes. On staining by 2% fluorescence dye, positive in right eye, stained ruptured bullae was seen, as we can see in picture. My clinical diagnosis is right eye Fuchs endothelial dystrophy stage 3 with immature senile cataract, and left eye Fuchs endothelial dystrophy stage 1 with immature senile cataract. Differential diagnoses are congenital hereditary endothelial dystrophy, congenital stromal dystrophy, herpetic stromal dystrophy, iridocorneal endothelial syndrome, Hessel-Henle bodies, posterior polymorphous dystrophy. Management, we provide her with hypertonic saline 5% eye drops 4 times a day, sodium chloride 6% eye ointment twice a day, carboxymethyl cellulose eye drop 1% 4 times a day, moxifloxacin 0.5% eye drops 4 times a day to prevent infection. Following surgeries can also be done: penetrating keratoplasty, Descemet stripping, endothelial keratoplasty, DSEK, Descemet membrane stripping, endothelial keratoplasty, DMEK. Recent advances are descemetorexis without endothelial keratoplasty with topical Rho kinase inhibitor and tissue engineering therapy by cultured corneal endothelial cell. Thank you.
Thank you, Apurva. Over to the judges.
So, Apurva, you presented this is Dr. Somshila, by the way, presented a very classical case of Fuchs endothelial dystrophy. And a couple of things that I would disagree with you is in your differential diagnosis, you had put in shed and stromal dystrophy and Hassel-Henle bodies. So those are not really differential diagnosis for this case. There's hardly any, except for maybe herpes. I wouldn't put in any other differential diagnosis really. But then yes, for the sense of confusion, I guess you've put that. And when you said management, whatever medications you're using, that's just for symptomatic relief. Antibiotics are not really necessary. The only medical therapy that I would probably go with is the Rho kinase inhibitors, that too for the left eye. For the right eye, are you sure that you only want to do an endothelial keratoplasty? You will not combine with cataract surgery?
Yes, ma'am, we can combine it with
What is the
cataract
patient's
surgery
age?
with phacoemulsification. Yes, ma'am.
Yeah. What's the patient's age?
Age is
I missed that.
60 years.
Okay. So you may or may not want to combine it because it's age 50. But it makes sense to, usually it makes sense to combine both both the surgeries. So you did mention one new procedure. Can you mention any other new procedures that we have been trying for endothelial disease?
Ma'am, tissue engineering therapy by cultured corneal endothelial cells.
Okay, all right, thank you.
Thank you.
Right. Thank you so much, Apurva. You can stop sharing your screen.
Yes.
Geeta ma'am, your mic.
Am I audible now?
Yes, ma'am.
Yeah. So that brings us to the end of our cases, and while we await the results, I'd like to introduce you to Dr. Nilima Mehrotra, who's the Dean and Professor and HOD, Department of Ophthalmology, SRM MS Medical College, Bareilly. She has initiated the department single-handedly and brought it up to a level of a tertiary eye care along with the eye bank, and has over 30 publications and several ongoing research projects, has done over 20,000 cataract surgeries and a high volume of charitable work also for blindness eradication and public awareness. So over to Dr. Nilima Mehrotra.
Thank you so much, Dr. Meeta. Can you hear me?
Yes, ma'am.
All right. Can I share my screen?
Yes, ma'am. You can start sharing.
Is it visible?
Yes, ma'am.
So thank you so much for a wonderful scientific session we had to the MP WOS wing, and in fact the mentorship which I am going to talk about in short today is has already been given as an excellent example today by all the presentations we saw with mentoring by their professors and heads in their departments. So it's but obvious, it's been an excellent example, as I just said, of how mentors would help us in career advancement, where all these students stood up to present their cases, and these residents would also face the judges
and came up with their presentation. So let me just go on to mentoring. We know that mentoring is what a peer or a more experienced person can guide a less experienced person and help as a mentor or mentee. So if we go on to search the brief history, the poem Odyssey, which was written in 800 before Christ, 800 years before Christ, is an example, one of the first examples of how mentoring is done. There is this king Odysseus, the king of Ithaca, who goes for a battle of Troy, and he is actually gone for 20 years. And before he goes, he wants someone who's going to be a teacher, advisor, friend, or in other words, a mentor for his son Telemachus. So this man, who was kept as a teacher, advisor, friend for Telemachus when his father Odysseus goes away on war, is the first example.
जब तुम वहाँ गए थे
So I think, am I audible as well, Dr. Meeta?
Yes, ma'am. Yes, ma'am.
Yes, you are audible.
Okay. So if we go deeper into history, actually this mentor did not do all his work, and it was Athena who was actually mentoring all the time. But this is what I wanted to show you as one of the first examples of a mentor-mentee relationship. So the word mentor is of a Greek origin, and in Greece it has been very, very conventional to have youngsters be under mentors who guide them. So here, men stands for one who thinks, and ter is the masculine and tricks the feminine. So if you are a male mentor, you are a mentor, whereas if you are a female mentor, you are a mentor. Similarly, a mentee would be a protege or a teachee. But now in the 2000s, we always have either the feminine or the masculine form to be the mentee. So we don't go into protege. So usually the mentee is younger, but age is actually not a determinant. So the person with more experience is a mentor. So you can learn from anyone, But if you want to find out the definition of what a mentor is or a mentor-mentee relationship is, then the definition is pretty elusive, and it is governed by a lot of adjectives like the influence, guidance, someone who shows direction, who helps in professional and personal growth. So the range is pretty wide, if you go into personal growth as well. Provides psychosocial support, and most importantly is a good communicator and is a role model. So you're present as a role model makes you more of a mentor than anything else probably. And the Oxford Dictionary simply states that it's an experienced and trusted advisor who can be a mentor. There are so many examples which can help you understand the mentor-mentee relationship. So many celebrities, sometimes a mentor may take you to heights even the mentor himself has not experienced. So that is how much a mentor-mentee relationship can do to one another. Like Oprah Winfrey, we all know about Oprah Winfrey show wouldn't have happened if it would not have been for her mentor Maya Angelou. So we have Thomas Jefferson, who's famous for Declaration of Independence of USA. George Mason was his mentor. Martin Luther King, all actually considered Mahatma Gandhi as his mentor, though the two never met. So you can follow someone as a mentor even in this manner. There's a very interesting concept of an NGO who has made Mentor Me India as an organization where they set up small children who are low income group as mentees with their privileged grown up bhaiyas and didis who are more who can mentor them for 2 years. So this is a real good social cause also as an example of a mentor-mentee relationship. As far as we are concerned, the medical profession, mentorship has been traditionally associated with our profession, the medical, with the legal and with the business professionals. It's a very interesting book by Levinson, Seasons of a Man's Life, which talks a lot about how mentorship can affect your life. if we want a mentor, so we would like to know who is a perfect mentor. Unfortunately, there is no formula to be a perfect mentor. But very simply put, you would be a perfect mentor if you are a mentor the way you wished you had one. On the other hand, there is Achilles heel to this, that mediocre mentoring, where the person, most of the people we would want as mentors are very busy. This is a fact. If they're busy in their work, so they may be disinterested. But on the other hand, there may be mentors who are incompetent, mentors who have never had mentors themselves. So a mediocre mentoring is probably worse than no mentoring at all. So that means to have a mentor is not simply to just get attached to someone, but you must have someone who is a good mentor or not have anyone at all. Sometimes some of these mentoring arts can be teachable as micro skills. So when you select your mentors, think of virtues like personal integrity, good judgment, confidentiality, the inclination towards being caring for the mentee, approachable for the mentee, genuineness, and one who has the mentee's best interests at heart. So do you think all these virtues can be taughtable? I don't think so. These can be hardly incorporated. They may be innate or inborn. So if you see these virtues in someone, that is perhaps the best person to pick up as your mentor. I was seeing some statistics. 70%, over 70% of Fortune 500 companies have mentoring programs. And almost all of those who have mentors say that it's valuable to have a mentor. But everybody does not get a mentor, and it's only about 40% people who do have a mentor. 90% people who have been mentored will also go on to mentor someone. So that is how a mentor-mentee relationship can work in the present days. There was a pilot project by the Johns Hopkins University School of Medicine in 2012, where they wanted the master-mentor approach, and they decided on giving perks and recognition to mentors. Now, this model was that they would have a master mentor or have a team of master mentors, which would help accelerate the enhancement of talent in the people they hire, and also elevate the quality of mentorship all over the organization. So they decided it is important for there to be resources for mentors so that they can dedicate time to the mentee and they can dedicate priority to the mentee. So they keep mentoring as a high priority for themselves. So some of these resources would be public recognition, awards, and other perks for these mentors. This mentor-mentee program was found to have built a sense of community and encourage networking and peer consultation. As I said, that medical profession has a lot to do with mentoring. If you quote a part of the Hippocratic Oath, it also says to hold the one who has taught me this art as equal to my parents and to live my life in partnership with it. So this is how important a mentor is in our profession itself. What I myself have my own feelings or opinion or my own learnings about mentors and mentor-mentee relationship is that our peers are probably our greatest resource and we must recognize it. Regardless of our age, our tenure, position, or the years of experience we have, do we have all answers? I'm sure all of you agree, no, we don't. We can get into sticky situations because I always like to quote that Murphy's laws really hold well. Anything that can go wrong will go wrong, and we have all faced it. So whenever we are in sticky situations, it's it helps to think that somebody else might have been in a similar situation and come out of it. So that person can be our mentor. So this is how we can connect at various generations, various experience levels. And a mentor is not a leader who wants followers or creates followers for himself. It's a mentor is a leader who creates additional leaders. And towards the end of this small presentation, I would like to quote Dr. James Barandis from Harvard Medical School when he took up his presidentialship. In his presidential address, he talked about Bill, his mentor, in the New York Yankee language. That Bill is learning me his experience. So this is how it explains to you what a mentor is. You know, you learn from the experience of someone who's been through more of it than you have been yet. So thank you, because you must be the mentor you wish you had, and people can be better if they have, and more towards success if they have more mentors, because that pulls you towards your better career. And to live, we can live by what we get, but we make a life by what we give, is what Winston Churchill said. And the simplest form of mentoring is the role modelship. So the way you live your life may change the way I live mine. Thank you so much, and all the best to all the participants. Let's see who has really bagged the award here. Thank you, Dr. Meeta, and thank you all of MP, WOS, and the Women of Ophthalmic Society. And we at UP also look forward to making such a program. Thank you so much.
Thank you, ma'am. Thank you for your wonderful words. And it's honestly an eye-opener what a mentor can do for you. And I think at WOS we are already practicing this. So thank you very much for your talk. Moving on to our next presentation, we have Dr. Natasha Pahuja with us. And she's a cornea refractive surgeon and clinical and research scientist who has also done her PhD on keratoconus and refractive surgery. So without wasting much time, I'd like to invite Dr. Natasha Pahuja for her talk.
Thank you. Thank you very much for that kind introduction. If you could stop sharing your screen, ma'am. Yeah, thank you. Well, I think I'm a personification of the previous talk, the things that a mentor can do for you in your life. And I'm extremely grateful for my mentor for making me slightly more able than I am today. So in the next couple of minutes, actually at the outset, I would like to thank WOS, Mohita ma'am and Allergan for this humbling opportunity. Are my slides visible?
Yes, they are visible.
Okay, perfect. So in the next few minutes, we are going to be talking about just one particular aspect of dry eye disease, that is hyperosmolarity. Now, the reason why all of us are gathered here is because we have a very strong intention of evolution. We want to evolve as a clinician or as a researcher or a scientist. WOS is a living example of evolution and how it has incorporated so many people together in the journey. Coming to dry eye disease in particular, irrespective of whatever be the stimulus for our evolution, we are still evolving. So much so that dry eye disease was earlier defined as, it has been known for the longest time possible, and it was defined as the water within, and was being treated with lead salts or mire or incense sticks to cause reflex secretion and reflex watering, and that's how dry eye disease was being treated. To actually coming today and having diagnostic test in terms of either Schirmer's or tearfilm breakup time and classifying them as aqueous deficient or evaporative disease, and to having a multimodal definition in terms of evolution, we have evolved in understanding this neuropathic component in dry eye disease. So the evolution is constant. And why are we discussing so much about dry eye disease and the evolution is because this disease is extremely common. As high, the incidence is as high as 73.5% in a certain subset of population. To understand how common it is in our geographic location, we did a small exercise and we figured that if I particularly see 80 patients in a day, almost 52 patients come with me with dry eye-like symptoms as a presenting symptom. Now a disease that is so multimodal and it is so common, it takes 43 words to describe dry eye disease. It's as big as a short note. And how are we treating this? We're treating it with lubricants, non-specific lubricants. Probably the last MR that visited me is the next lubricant that I'm going to write. It's basically, if I have a compound fracture, a displaced fracture, and I put a cast over it. This is what a lubricant is doing if we are not very mindful of our choice of lubricant. So putting dry eye disease under the X-ray and figuring out what exactly is happening, we are just going to take one aspect of it, which is instability and hyperosmolarity. Now down the chain, it can either be aqueous deficient or evaporative. If there is aqueous deficiency, it is going to cause in the osmolarity of the surface. If there is evaporation of the tears, it is going to cause destabilization of the proteins on the surface, and hence it leads to hyperosmolarity, which is why we are concentrating specifically on hyperosmolarity right now. And there's a wonderful paper, and I would request everybody to go ahead and read it. It's a brilliant paper. What it essentially does is it shows that there are multiple factors that can cause dry eye disease, and all these factors have been enumerated. What it essentially shows is that there is tear film instability, which causes hyperosmolarity, programmed cell death. This further causes inflammation that causes tear film instability, and we are set into a forward feed loop mechanism. On top of that, if there is an evaporative component, that adds to the tear film instability, and hence the dry eye disease goes into a vicious cycle. Now let's just understand this and put it into a clinical perspective. If I had a patient, what would the patient feel? How would I approach it as a doctor, and how would I treat it? So let's just understand what would a patient feel. These are the obviously most common clinical symptoms that a patients come with dry eye disease. What is very important here is that when we are looking at these symptoms, we have to ask leading questions. The one question that I always keep asking, especially it's a female, I ask them how frequently do they wash their face, because face washes have a detergent action and they tend to change the osmolarity of the surface. And a lot of females have a tendency to clean their eye makeup with face washes or scrubs that eventually lead to more dry eye disease rather than the actual mascara or the eyeliner that is causing dry eye disease. So this is something that has to be mindfully asked in the clinic as a leading question. Of course, these other symptoms that can worsen dry eye disease have been self-explanatory, have been beaten to death. Here's one perspective that I would like to share. Now, if a patient comes to me who is a contact lens wearer, sits in the AC, has a tendency to smoke, has increased screen time, and has frequent coffee breaks. Now, this is a very good milieu of a very typical patient who's an IT professional. All this adds up, and these patients are the ones who are our most common patients who come for dry eye disease like treatment. Another perspective is because of the new normal, our screen time has increased. We are working from home, and that has led to increased incidence of dry eye disease. Now, as a clinician, what would I want to examine? We basically need to understand that these are key mechanisms, and let's just address these one by one. So what I would do is, in a stepwise approach, first when the patient is sitting to me in the clinic, I would probably have good history and questionnaires, examine later, and then do the treatment. Now, the most easiest way of understanding the patient has got dry eye-like symptoms or not, just hand out a questionnaire. Let it be an OSDI or a speed questionnaire. The advantages which are practically present in these questionnaires have been enumerated here. My personal favorite is using the OSDI, which has been presented by Allergan. It's freely available over the internet and anybody can use it. What it essentially does is it gives us a discomfort subscale and a vision subscale, so you know what exactly is the patient presenting with and what part of the symptom do you need to treat it. Coming to the examination, and a very good slit lamp examination is indispensable tool. It is much more better than all the high funda gadgets that we have. Coming to the high funda gadgets, actually, we do have a dry eye clinic, and what we essentially do in that is the patient spends a good 30-35 minutes for a dry eye evaluation. And what we essentially look at is studying the structure and the function. The structure can be studied obviously by meibography, and the function of the glands can be studied by interferometry at the non-invasive tear film breakup time. What this essentially does is helps us to understand the kind of evaporative dry eye disease the patient has. You do not need fancy equipments. Sometimes an autorefractometer or a fundus camera will be able to do the same for you. Now, this is just an enumeration of what level of structure are you looking at in the eye, and which component of dry eye disease is affecting it. But what is most important in all of this is that we are forgetting the absolute essential elementary question, that is, what is the composition of tear film? Now, how do we measure the composition of tear film? Understand is the clinical tools that are available is the MMP9 kit and the tear osmolarity meter or the tear osmometer. This basically tells us if the tear osmolarity is high, we have to be extremely mindful of our treatment or the choice of lubricants that we are prescribing. So essentially, if we are investigating these patients, what we invariably miss is actually the most important component, which is the tear film composition. It has the highest weightage as compared to any other diagnostic tool, because it is essentially that is what we need to treat. So understanding grossly of what the tear film composition does to the ocular surface is it causes desiccation, it increases the osmolarity and causes apoptosis on the ocular surface, and that's why the patients are having those symptoms. Sorry, are my slides advancing? Okay, yeah. So eventually, when we look at the dry eye disease, this is what the image here shows, that there is increased osmolarity, increased desiccation, and increased apoptosis. How do we apply it in understanding dry eye disease is because there is significant ocular surface inflammation. The cells are under oxidative stress. This increases the inflammation. Now, this is similar to what when we were trying to understand the mechanism of dry eye disease. Why are we discussing so much about the mechanism is because let's just look at the patients that come to us when we are intervening. For instance, LASIK. A patient of refractive surgery, there is the LASIK procedure itself causes change in the homeostasis. And how do we document it is that if you look at the various methods of refractive surgery, it is noted that the denervation or the nerve stimulation that is less affected is by a smile. And we have noticed that in patients who undergo LASIK, it takes more than a year for the nerves to grow back. That too, not all of them. Only 50% of the nerves actually grow back post LASIK surgery. This basically shows that there is, and this is image that I had taken for my smile patient. In my case, I had noted that the regeneration had happened in 6 months post smile surgery. I want to put this into perspective. Now, this patient was referred to me by a colleague. She said that the patient, I have operated this patient. This was a pre-op topography. This is the post-op topography. The patient is having a small cylindrical number. She showed me the topography and she said that the patient has undergone post-LASIK ectasia. It was slightly shocking to me because it's just 3 months and has got significant surface irregularity. The keratometry has changed. So I said, just send the patient to me and then probably we might have to consider cross-linking for this patient. But when I put the patient on slit lamp, this is what we saw. There was in the inferior quadrant, in the inferior palpebral fissure, there was staining. Now, this patient was actually a case of dry eye disease. Now, because of the epithelial irregularities that were present in the inferior palpebral fissure, it, at least on a placido imaging, it looked like ectasia. It is very, very important that we look at all these aspects and before we actually jump on intervening on these patients. So a clinical examination and a right tool for investigation is what is absolutely important in case of dry eye disease. So the possible mechanism in terms of LASIK, whenever there's denervation, the corneal sensitivity is decreased, it causes inflammation. This causes decreased blink rate and decreased tear secretion that will lead to hyperosmolarity. Of course, because of the tear film instability and the ocular surface damage, there is apoptosis or programmed cell death, which leads to dry eye-like symptoms. Now, let's just come to what is absolutely important, the crux of the matter, which is how do we treat it? Now, if there is inflammation, we need immunomodulatory drugs. If there is hyperosmolarity, we need to have osmoprotective agents. And if there is apoptosis, we need autophagy induction drugs, which in this case are the line of management. So if there is immunomodulation, we have cyclosporin or lifitegrast. Lifitegrast is yet to come to India. Autophagy induction can be done by chloroquine or Relose. And we have to be extremely mindful of the kind of lubricant that we are prescribing to our patients. Because this is what is going to probably, this is an adjuvant therapy. The other way of managing this is, of course, if we want to intervene, is by, if we want the meibomian glands to function better, then we do thermal pulsation. Or if we want the tears.
Sorry to interrupt, but could we shorten up the talk?
Yes, these are last 2 slides, 2-3 slides.
Okay, thank you.
So essentially what I'm trying to say, I'm just going to skip these slides. Any patient who, especially if I'm considering a post-LASIK patient, my choice of lubricant and the choice of immunomodulation that I give to the patient is extremely important, because these patients after a good surgery also need a good outcome. Now, this is a non-sponsored study, and which showed that if you have a good osmoprotective agent, the corneal staining decreases significantly. In this case, they had used Optiv, and they had compared it to HA. What are we essentially trying to say by this is that there's increased osmolarity, there is increased desiccation with just osmoprotective agents, which is just simple lubricant. The surface improves significantly. So in this cycle, what we need to understand is our choice of lubricant, and we need to have proper immunomodulation. So this is published by DEWS, which is a very good stepwise approach and classify them in terms of evaporative and aqueous deficient. Step 1 in any dry eye disease patient is the choice of lubricant. I can't stress enough on it. It has to be an osmoprotective agent. If the patient does not improve with that is the time you would want to specifically investigate further and give an immunomodulatory drug. Just a passing remark, we are using a lot of sanitizers in our clinics, in our homes. These sanitizers, this paper has been published by Narayan Netrale group. These is going to change the osmolarity on the surface. So it is wise either we stop using the sanitizers, wash our hands more frequently, or use osmoprotective agents on the surface. I can't thank enough for these two men who have made me the woman that I am today. One is my father, one is my godfather, and it's just thanks to both of them for making me slightly more able than what I was before. Thank you so much. I'll be happy to take any questions if there are any.
Thank you so much, Dr. Pahuja. Very interesting talk, and it definitely gives a guideline as to what kind of lubricants we need to use. Dr. Preeti, would you please mute yourself? We now move on to the result of this interesting case presentation, and let me tell you, it has been a massive exercise with input from everybody, and it is really a teamwork. We wouldn't have been able to do it without the input from everybody, from all the medical colleges, the DNB institutes, and all the residents and their mentors who have put in their hard work, plus all the professors and colleagues which we have all around the state. And I'd now like to request Dr. Mohita Sharma to please announce the results.
So can we have all the cameras on, please? So first of all, thank you MP team for putting in this great effort. It was an amazing day today, and lots to learn for everybody. And before the results, thank you to the Allergan team, because they have been instrumental in making this happen. Allergan has always been associated with WOS, and it is responsible for WOS being where it is today. So a big thank you to Allergan. And congratulations to everybody who has presented, because today you have not only gained in knowledge, but I'm sure you all feel that this is a milestone for you, because your confidence must have gone 10 times up for the next presentation. And another thing that has happened today is you have become associated with WOS, which as WOS, we will keep knocking at your door and trying to push you to do even better every time. So now let's come to the results. So we've always heard of ladies first. Today it's a women's organization which is conducting the program, and it is not the ladies first, but the man first this time. So the winner is Dr. Darshan Shah and the mentor Dr. Amrita More from Chitrakoot. A big round of applause for them, for the team. And can we have you here, if you can just raise your hand so that we know where you are, Dr. Amrita and Dr. Singh. Congratulations, a very big congratulations to both of you. The first runner-up is Dr. Nishi Prasad, and the mentor being Dr. Aditi Dubey. Congratulations again, Dr. Nishi and Dr. Aditi.
Thank you so much, ma'am.
We all are clapping loud. Maybe you can't hear it, but we definitely, there's a big round of applause for you.
Yeah.
And the second runner-up is Dr. Aishwari Revankar, the mentor again, Dr. Amrita More from Chitrakoot. So congratulations again to both of you.
Thank you, ma'am.
So it was, I think, an amazing session and amazing presentations. And Dr. Shweta, can you just brief about what will be the next step for the final state rounds?
Since our Dr. Darshan Shah is a male and he can't be a member, the second position is by Dr. Nishi Prasad, who is a WOS lifetime member. She moves to the next round, which will be an interstate competition. After the rounds of all the states, we'll have an interstate competition, and Dr. Nishi would get a chance to go to that level. Dr. Nishi, great.
Certificates would be given to everybody, all the three?
Certificates, yes, certificates would be given to all and to the winners too.
So congratulations once again, everybody. And thank you so much and for all your presentations.
We would now like to call Dr. Sujata for the vote of thanks. Dr. Sujata.
Thank you, Dr. Shweta. Very good afternoon to all of you, and heartiest congratulations on the successful conduction of this state competitive resident virtual session of MP State Chapter of WOS. Before proceeding to the vote of thanks, I would like to congratulate all the winners and all their moderators for such a wonderful job. I'm Dr. Sujata Laktakia, Associate Professor of Ophthalmology at SS Medical College, Riva, and obviously a member of this esteemed society. I hope you all have enjoyed this academic feast today. It is now my privilege to give a vote of thanks to everybody on behalf of the MP State Chapter of WOS. I start by extending my gratitude to Dr. Madhu Bhadoria ma'am, President of WOS, and Dr. Mohita Sharma ma'am, Secretary of WOS, both of whom consented to grace this event with their presence and lend support to the State Chapter of Madhya Pradesh for organizing this virtual PG competition. I would also like to thank Dr. Ulka Srivastava madam, ex-Director of Medical Education of MP, who despite her traveling schedule also participated in this online event for a little while. I wish to express my sincere thanks to our revered speakers, Dr. Namrata Sharma ma'am, Dr. Rohit Shetty, Dr. Divya Trivedi, Dr. Mehzbeen Rahman, Dr. Nilima Mehrotra, and Dr. Natasha Pahuja for taking time out of their busy schedule and giving their talks, all of which I think will immensely benefit our budding ophthalmologist residents. No competitive session can be made interesting without the active appraisal of experts, and for today's event we were very fortunate to have a whole panel of them amongst us. Heartfelt thanks to all our esteemed judges, Dr. Madhu Bhadoria ma'am, Dr. Meenakshi Dhar ma'am, Dr. Sunita Dubey, Dr. Devi Aishwarya, Dr. Anshu Agarwal, Dr. Aarti Nangya, Dr. Sandhya Makhija, Dr. Shubhra Goyal, and Dr. Somashila Murthy for not only judging this competition, but also for giving critical insight into all the cases presented. I'm sure their comments and questions have been of immense value to not only to the presenters, but also to everyone in the audience. I would like to express my sincere thanks to all the moderators, Dr. Meeta, Dr. Vinita, Dr. Anshu, Dr. Manushri, and Dr. Sonam for their enthusiasm, professionalism, and the ability to keep time, which played a great part in the successful conduction of this online event. A mentor helps to enhance the mentee's knowledge and vision, and all our presenters have had the benefit of some wonderful mentors. I thank each one of them for guiding their mentees. Dr. Pragya, Dr. Shweta, Dr. Preeti, Dr. Abha, Dr. Navneet sir, Dr. Aditi, Dr. Amrita, Dr. Harpal, Dr. Sonali, Dr. Supriya, Dr. Anamika, and Dr. Shubhra. Thank you all, and your efforts are highly appreciated. A big thank you to all the resident presenters. Without their enthusiastic performance, obviously this program would not have been possible. And I'm sure they all must have benefited immensely from this competitive session. I also wish to express my thanks to our IT person, Mr. Bageshwar, for his technical support, and our sponsors, Allergan and AbbVie Company, for their contribution in today's online event. Last but not the least, my sincere appreciation for the MP State WOS committee, especially to Dr. Shreya ma'am, Dr. Meeta Joshi, and Dr. Shweta Walia for their untiring efforts in organizing this event and making it such a huge success. Once again, a heartfelt thanks to all of you, and hope to see you again soon in many such interesting and informative sessions. Thank you so much.
Thank you, Dr. Sujata. So with this, we come to the end of this virtual session. Hope to see you soon again
with the next session, which will be more interesting one. Thank you so much for participating.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Bye.